Good morning and welcome. My name is Linda Ostosky, president of the Judy Nicholson Kidney Cancer Foundation. We have a great day ahead of you with the latest information regarding kidney cancer. The presenters are from all over the country and they are the best in their fields. They are here to give you knowledge and hope. Even though this is a virtual symposium, we are all going to be connected. There will be an open discussion in which you will be able to ask questions. And we are now truly international because our virtual attendants are from all over the world. We have people from Poland, Sweden, the UK, Canada, and the US. Go to our website for more information on the foundation and for future symposiums, and Facebook for our support group. We are truly blessed to be here and give you a platform for learning and sharing. Enjoy the day.
Hi, good morning, everyone. My name is Osama Mohammed. I'm a radiation oncologist from the MD Anderson Cancer Center in Houston, and I specialize in treating prostate and kidney cancer. It's a pleasure to be here with you today. All right, let's start. Today, I'm going to be talking to you about the use of radiation therapy in patients who have kidney cancer. And we're going to specifically talk about a specific form of radiotherapy called SBRT. And let's start with my conflict of interest disclosure. I don't have any conflicts of interest to disclose. And let's start with the learning objectives for what my goal for you today is. So today I want to go into details into the use of, again, SBRT in patients with kidney cancer. And I'm going to specifically talk about 5 different kinds of patients or 5 different presentations of patients. And I promise I'm going to define each of these in a second. So patients who have primary RCC, patients who have oligometastatic RCC before starting systemic therapy, patients on systemic therapy but then limited progression or oligoprogressive, and then patients who have kidney cancer which has spread to the brain or spine. And again, let's start first with definitions. So today we are going to talk about kidney cancer, and that kidney cancer it can be still in the kidney, or it could have traveled or metastasized somewhere else outside the kidney. But we are going to still call it kidney cancer, even if it's in the brain, even if it's in the bone or in the kidney. We're going to call it kidney cancer that metastasized. And we're going to specifically talk about one particular form or subtype of kidney cancer called RCC. And it stands for renal cell carcinoma. This is the most common subtype of kidney cancer. About 85% of patients with kidney cancer has this type, RCC. And we're going to talk about the utility of SBRT, which stands for stereotactic body radiotherapy. And this is different than the traditional radiation that is mostly given for other disease sites. It's definitely gaining more and more popularity, the use of SBRT. And when we say SBRT, we mean three things. First, we are giving high dose of radiation per treatment session. And we are doing the radiation under image guidance. This is why we call it image-guided radiotherapy. And this means that before every radiation session, we are going to take a picture, usually with a CT scan, to make sure that we are precisely targeting the tumor that we want to target. And also SBRT automatically implies that we are delivering the treatment in 5 or less sessions. And we need the three criteria for the definition of SBRT. Now, the disease sites we are going to talk about, the location of the kidney cancer, we're going to talk about kidney cancer that has remained in the kidney. We call it primary RCC. Primary means it's in the primary site, which is the kidney. And we're going to talk about three other manifestations or spread of kidney cancer. The first one is when the cancer spread to the brain or to the spine. And we are going to talk about oligometastatic RCC. This is when the cancer has spread beyond the kidney, but oligometastatic. Oligo means few spots. So it's only has spread into only a few spots outside the kidney. And we're going to talk oligoprogressive RCC. This is cancer that has spread outside the kidney to limited sites, and the patient is getting already the systemic therapy. And by systemic therapy, I mean whatever infusions or pills or immunotherapy they're getting. And while they are on the systemic therapy, the cancer is progressing in a limited number of spots. I promise you, I'm going to repeat these definitions multiple times before each section. So let's start. So it's very important for me to tell you, before we talk about all these applications of radiation, I want you to see what is radiation and how it's applied. This is a video I put from YouTube, and I am not making any advertisement for the company, but they have a very nice video. So let's look at it.
Today's radio.
So this is called IMRT. SBRT is delivered using MRT. As you can see, this is the patients on the machine, and you see the head of the machine here is shooting the radiation to whatever site we want. And then these two parts take pictures. I told you about image guidance. So you have image guidance, radiotherapy delivery. And it's very important here to look at the head of the machine. As you can see, in the head of the machines here, there are these metal-like structure, which as the machine is rotating around the patient, these structures will move in and out to conform to the shape of the target that we are treating in order to give this very precise radiation. And now that I've told you how the radiation is delivered, you have an idea what it means. So let's start with my presentation. So the first most common question actually I get asked is this question. And usually when a patient comes to me to see me in radiation oncology or other non-radiation oncology, our colleagues in different specialties, they always ask me the same thing, that my doctor or the doctor would say, kidney cancer does not respond to radiation. Is that true? Well, that was true, but probably a few decades ago. And historically, when we were doing radiation therapy to the kidney, we were using conventional radiation treatments. And by conventional, I mean the delivery methods were old, there was no image guidance. Instead of giving high doses per treatment for 5 or less sessions, we were doing small doses or treatment for large number of sessions, usually 20, 30, or 40. Because of these older conventional radiation treatments, radiation therapy was not effective against kidney cancer until SBRT came and the new studies started to show some effectiveness, some good effectiveness of radiation therapy against kidney cancer. So now almost all patients who are getting radiation for kidney cancer are getting this SBRT. So let's start. I told you we're going to talk about 5 presentations of kidney cancer. The first one is SBRT for primary RCC. Again, these are patients whose cancer is in the kidney, did not spread beyond the kidney. As you can see here, this is a patient. These are the 2 kidneys. Eventually, some of us will develop kidney cancer, and then we can use the radiation to kill the cancer in the kidney. As you can see here, there is no cancer anywhere else on the body. We are going to call this localized primary kidney cancer or localized primary RCC. Who are the best candidates for primary RCC? These are patients who have a single lesion or a single mass in the kidney and it's growing. We do often see many patients who have like two centimeter mass that maybe it's growing like 1 millimeter or 2 millimeter every few years. We don't need to treat these patients. So single mass is great. Growing is good because if it's not growing, probably does not need to be treated. Of course, the smaller, the better. Think about it. If we are treating a small mass versus a larger mass, it's always safer and more effective to treat a small mass. Also, the best candidates are those where the cancer did not spread to the kidneys around, to the tissue around the kidney, and there is no cancer in the lymph nodes and no metastasis, meaning that the cancer did not spread. The best candidates will have good baseline kidney function because radiation will affect kidney function. So the better your kidney function at baseline, the less likely that your kidney function will decline significantly or that you will need dialysis after treatment. And at least 1 centimeter from bowel, because the kidney is here, the mass is on the kidney. Usually there's lots of bowel, small bowel, large bowel, very close to the kidney. So if there is at least 1 centimeter, this can be done very safely. If there is less than 1 centimeter, the radiation could still be done, but we have to do more maneuvering, or maybe we have to reduce the radiation to part of the cancer a little bit in order to make sure we do not damage the bowel. And finally, it's best if the cancer is on one side of the kidney, usually upper pole or lower pole, and rather than in the center, because cancers that are in the center, usually when we do radiation on them, we impact a larger proportion of the kidney as compared to the ones that are more polar, either upper part or lower part. And I just want to point out something very important, that patients with primary kidney cancer that did not spread yet, their standard of care today is surgery. And usually if surgery is not possible, then the patients are sent to our colleagues in interventional radiology to do ablation. However, more recently, SBRT is gaining more popularity, and we are seeing more patients with primary kidney cancer. What's the process like? Usually patients walk through the door, I meet them as a radiation oncologist, and then once we have decided that, okay, the radiation is useful for them, usually we can do a CT scan and MRI before the radiation in order to understand the anatomy, the size of the cancer, the location in the kidney. We may also need to check other body sites, like to get a CT scan or a bone scan to make sure that the cancer did not spread beyond the kidney. And very often also I would get kidney function testing, like a creatinine blood levels or a GFR. And we may also get a scan called kidney nuclear scan, which tell us the function of the kidney, how it's going. Once we have decided the patient is a good candidate to get SBRT, we bring them to the clinic. We do what we call CT and MRI simulation scan. And on that day, we evaluate how the kidney cancer is moving, because as we move, the kidney move with breathing. And we may do some techniques like breath hold or abdominal compression to limit this up and down movement. And sometimes we may insert a marker. This is a separate procedure by our interventional radiology colleagues. They put a small needle, put small gold marker inside the kidney so that we can see it. And then we may use CT or MR contrast. These are injectable dye during the simulation scan in order to see the mass better. Once we are done with this procedure, we get the CT and MR pictures. We draw our target, we draw the organs that we want to avoid, such as the bowel, the rest of the kidney, and the spinal cord. And the radiation usually starts 2 to 3 weeks later, and it's usually lasts either 1 session, 3 sessions, or 5 sessions, usually every other day, and each session would last 1 hour. What to expect? We don't have like 10-year data or 20-year data because this technique is very new, but at least for last year, a very nice paper was published, and it showed that patients who received SBRT to the kidney cancer that is in the kidney, there is about 90 to 95 chance of cancer control in that area. Of course, smaller cancer has better control than larger cancer, and the cutoff, like we usually say, 4 to 5 centimeter. treatments done in one session maybe have better control than those done 3 or 5 sessions, but it's not always feasible or technologically possible to do one session. Most centers can do 3 to 5 sessions. One session, we are still, most centers are still trying to understand if they can do it, whether they have the technological capacity. Very, very important point. Let's say a patient comes in, they have kidney cancer, and we treat it with radiation. Although radiation is capable of taking care of that mass in 9 out of 10 patients, in a lot of these patients, we have to continue to monitor the abdomen and the chest, because even if I control the cancer in this area, it's possible that even before the radiation, one of a few cancer cells have already gone to the bloodstream, and eventually they are in the kidney or eventually they are in the lung or they are in the bone. And so we have to continue monitoring for cancer spread, even if the treatment in the kidney has been successful. During treatment, I expect some patients to have some side effects, usually very mild side effects. Nausea, vomiting, we treat them conservatively with Zofran or just lifestyle changes. Very commonly, patients have some mild fatigue. Some patients may have diarrhea. Almost all of these symptoms usually resolve in 1 to 4 weeks. However, from my experience, I know this, like patients in their 80s, and I occasionally have treated some patients in their like late 80s, and it just takes a little bit more time for these symptoms, specifically the fatigue, to resolve in these patients. And honestly, in 4 years of practice, the only patient I see, like hundreds of patients, I've seen treated hundreds of patients, the only one patient that could not continue any kind of treatment is a patient who had a kidney cancer. She was an elderly lady, and she was feeling very tired. She was telling me like it felt like she was having the flu every time she get the treatment. So she received 4 sessions and she refused to continue the end of the treatment. But again, in younger patients, like in their 60s and 70s, this is very, very well tolerated. Long-term side effects, the most common question I ask, will I become on dialysis after treatment? Dialysis is very rare in these patients. However, we have to be very careful. There will be a drop in kidney function, but usually the drop is very mild. As I told you, we usually do a blood test to get a number called creatinine or GFR. Usually in normal kidney, that number is greater than 60. As it drops 60, 50, 40, 30, then the kidney function is not as good. So patients whose kidney function is in the 30s and 20s, they may progress to dialysis. However, the caveat here is that if we don't treat that kidney cancer, the cancer will grow enough to affect the kidney, and they will progress they may progress to dialysis anyway. So it's a balance. And so we have to be mostly careful about those patients who have poor baseline function, if they have single kidney, or if they have like advanced diabetes or hypertension. Serious side effects such as bowel injury is rare, less than 1 in 50 patients. So the take-home points for patients with primary RCC: SBRT is safe and effective. Control rates are high. Only 1 in 10 will have a recurrence in the kidney. The side effects are rare. However, we have to be careful. We need enough good setup to see the tumor, to manage the motion during the radiation. And it's also very important to know that this is not the number one standard of care for these patients, but it's gaining more popularity as the time goes by. So this is the first indication. Let's go to the second indication, SBRT for oligometastatic RCC. Let's define it again. These are patients who were recently diagnosed with RCC, renal cell carcinoma, that has already had a limited number of spread, like usually less than 5 sites. Or, for example, 3 years ago, they had kidney cancer only in the kidney. The kidney was removed, so we thought they were cured, but now they have recurrence, and the recurrence, let's say, is in 2 or 3 spots in the bone. So it is new diagnosis or an old diagnosis, but new spread, limited number of spread, and should not have aggressive features. We'll go and we'll just explain these aggressive features. And these patients usually, this is what happens. So again, no aggressive cancer, usually less than 5 lesions. Usually our colleagues in medical oncology, they look at the patient in general and look at the big picture. Patient does not have a very aggressive cancer. And they think the patient has 3 sites, 2 in the bone, 1 in a lymph node, or 1 in the lung. And they think, what? The cancer is not very aggressive. Maybe I can hold the progression of the cancer, not cure, but hold the progression of the cancer with SBRT or radiation, and I can save the chemotherapy or the immunotherapy or the pills for the future. And usually for example, like this schematic here, 3 sites, we can target them with radiation. Usually after this radiation, we monitor with imaging, such as CT scan or bone scan. And usually in the future, if they have a new sites that's coming up, then we have to make the other decision. Can we repeat the radiation for the new spot? Or should we start systemic therapy again, the immunotherapy or the pills or combination? And this is, as you can see, this is a multidisciplinary discussion. These decisions can be complex actually, because there are lots of different little details that are very important for the discussion. Here in MD Anderson, I see we have a lot of discussion in tumor board with our colleagues in urology, the surgeon, or medical oncology to discuss these patients. Now, what's the process like? Similar to when we are treating the primary kidney, you come to me, I do evaluation, suitability for the SBRT. But then here, because I'm not treating, I could be treating the kidney, but in general, this is when the cancer spread, I treating the area where the cancer has spread. So depending where the cancer is, the setup of radiation, the number of treatments, the side effects of the treatment may be different. For example, somebody who has metastasis to the rib is different than someone who has metastasis to the pelvis, is different than somebody who has metastasis to the lung. Usually, for example, this is my own style. There's different ways of doing it. In the rib or in the bone, I usually do 1 session or 3 sessions. In the lung, I usually do 4 to 5 sessions. Each one is a little bit different, and this is beyond the scope of this talk. And again, for each one, there is a different setup. For example, the lung, the cancer in the lung will move with breathing, but the cancer in the bone will not move with breathing. So the way I set up the patient and evaluate and treat is different. But again, usually 1 to 3 to 5 sessions, 1 hour each session. And usually I can treat multiple sites. For example, if there is a rib and a pelvic bone, I can treat both on the same day, no issues at all. What to expect? Again, cancer control in the area that is treated is very high. 1 in 10 or 1 in 9 patients will not have recurrence in that particular spot. But remember, the cancer is already spread. So our enemy is not where we treated, but in the other spots where we did not treat because we cannot see. There's nothing visible on imaging yet. So the highest risk of recurrence is elsewhere, usually in the bone and lung. And studies have suggested that in carefully selected patients, this SBRT strategy may delay the start of systemic therapy by 1 year. Again, I told you this is a patient comes to the door. Our colleagues in medical oncology say, you know what, maybe I don't need to start you on systemic therapy. Let's do the SBRT, and then we give you systemic therapy when you progress in the future. And again, this strategy may delay systemic therapy by about 1 to 1.5 years. Again, the side effects of the treatment are dependent on where the cancer is. Cancer in the abdomen, kidney cancer in the abdomen or pelvis usually cause nausea, vomiting, diarrhea, fatigue. In the lung, fatigue, difficulty swallowing, cough, chest pain. Again, mostly are mild. They resolve within 1 to 4 weeks. Have to be very careful with older patients. And again, long-term side effects usually are the serious ones are not very common. Bone fraction does happen, such as in the rib or vertebra, is in about 1 in 10 or 1 in 5 patients. However, most of these are completely asymptomatic. For example, somebody fractured the rib. In the majority of cases, it is not a big deal. Now, take-home message, the decision for the treatment of patients with oligometastatic RCC is multidisciplinary. We have to be talking with our colleagues, medical oncology, urology. The treatment is safe and effective with minimal impact on patients' quality of life, and it's supported by retrospective and prospective clinical trials. Large clinical trials are pending, they are on the way, and it's good for patients mostly with non-aggressive subtypes. The third presentation of patients is patients with oligoprogressive RCC. Again, these are patients who have, for example, give you an example, they have metastatic RCC that has spread, and maybe last year their medical oncologist already started them on some form of systemic therapy, for example, immunotherapy and pills, or pills alone, or immunotherapy alone. And the patient is doing great, they are tolerating the treatment very well, and everything's going well, except maybe one or two spots in the body are showing that they are becoming resistant to the immunotherapy or the systemic therapy. So here the medical oncologists, they say, what, the patient is on systemic therapy, these sites are limited, and I don't want to switch the systemic therapy. The patient's tolerating it very well. Overall, in general, he or she is doing well. So, and because keep in mind that although the treatments for kidney cancer have significantly improved over the past few years, we still have limited number of systemic therapy options, and we still have to be very careful. We have to talk with our colleagues, and we have to really make sure that every option, we use it very judiciously. So the medical oncologists say, let's try to do SBRT to the progressing side. So I'll give you this schematic. Patients initially treated with 1, 2, 3, 4, 5, 6 spots, metastatic RCC. The doctors say, let me give you a systemic therapy. All of these spots are not growing or are gone, except one area, let's say in the pelvic bone. Instead of switching systemic therapy, we can do radiation to the spot. Again, the patient gets radiation, continue on the same systemic therapy, and in the future, if they progress again somewhere else, we can either repeat the same strategy, SBRT, or we can at that time switch systemic therapy. The process is exactly the process to the kind of cancer I explained in a few minutes ago, which is the oligometastatic cancer. That the process with radiation oncology and the treatment and the breath hold or no breath hold and the imaging and the number of treatments is exactly the same, and it's dependent what area we are treating in the body. But very important caveat, previously the patients are not usually on systemic therapy, now they are. And for a lot of these systemic therapy, for example, immunotherapy, we do not like to give immunotherapy on the same day as radiation, so we try to not have them overlap. You can be getting immunotherapy, let's say you get your immunotherapy every 3 weeks. We can squeeze the radiation between these immunotherapy. And some of the pills, we also will talk to you and to the medical oncologist to stop those pills. We really don't know how much, but usually 7 days to 10 days before and 7 to 10 days after to let the radiation pass, and then we can get back to it. What to expect, again, in the area that we treat, very high rates of cancer control. However, again, because the patient has already cancer that spread and it's already showing signs of resistance, there could be in the future risk of cancer progressing somewhere else. And by doing this strategy in carefully selected patients, this SBRT strategy may delay changing systemic therapy by about 9 to 12 months. Again, what to expect in terms of side effects? Mostly it's related to the areas we are treating. Again, abdomen, nausea, vomiting, lung, fatigue, and difficulty swallowing, and the long-term side effects are rare. Take-home points, decision again should be multidisciplinary. The treatments are safe and effective with excellent control, minimal severe side effects, and it's supported by small clinical trial. Now, the last kind of presentation is patients who come to us usually either with a spot or cancer of the kidney that spread to the brain or to the spine. I will not get into too much detail for this section, but basically patient on systemic therapy, everything is going well. The brain a spot shows up in the brain. This can be also a nuanced presentation because some of the systemic therapy can cross the blood-brain barrier, go to the brain, some don't. But usually these patients, we see them a lot in the clinic. We give radiation to the brain. Again, the decision should be multidisciplinary, the treatments are safe, and we have to really do good image guidance so that the brain or the spinal cord are not damaged. So finally, in summary, the indication of SBRT for RCC is for primary RCC, kidney in the cancer that did not spread, or cancer that spread but did not start. We don't want to start the systemic therapy yet. We want to delay it a little bit, or that cancer that spread and they are on systemic therapy and 1 or 2 spots are not responding too well, or cancer in the brain, spine, and I did not talk about this indication at all, but sometimes patients come to us, they have very advanced cancer, but it's, for example, it's in their femur, the hip, or the arm, or the shoulder, or a rib, and it's very painful, or maybe at a high risk of fracture. We can do short course of radiation for these patients. And I just want to point out 2 important national studies that are ongoing or about to start. The ECOG, which is one of the national groups which design clinical trial, and the NRG, also a national group which design clinical trial. We have 2 studies. One is called SOAR and one is called Samurai. And both of them are using radiation in conjunction with systemic therapy to treat kidney cancer. If you want, I think you should ask your doctors if you are eligible for either of these studies. And this is all what I have. I really appreciate the invite from the Judy Nicholson Foundation to give the talk. It has been a pleasure. And this is my email if anybody has any questions. Thank you so much and have a great day.
Good morning. My name is Vivek Narayan. I'm a GU medical oncologist here at the University of Pennsylvania, and I'm really glad to be a part of this conference again this year, and specifically to present this year on the topic of locally advanced kidney cancer. I think as brief background as we get started, one important concept to begin with is the concept that kidney cancer we know is a highly variable disease. There are some kidney cancers that can be more slow growing and have more indolent disease behavior. And these are the snails or the tortoises of the kidney cancer spectrum. And these particular kidney cancers, we generally expect not to be the types of kidney cancers that may cause cancer-related symptoms and be at risk for distant spread or ultimately kidney cancer mortality. However, on the other end of the spectrum, we know that there are some kidney cancers that can grow more rapidly and reach more advanced stages. And these are the kidney cancers, the so-called hawks or hares, that we know are those kidney cancers that are much more likely to result in cancer-related symptoms and ultimately distant spread and cancer-related mortality. We have many different ways of trying to estimate or understand the potential biologic behavior of a kidney cancer. But one of the ways that's most commonly used is an understanding of the size and extent of the kidney tumor itself. And this gets to the concept of locally advanced kidney cancer. The way that we make this assessment is largely through what we call tumor staging. We know that stage 1 and stage 2 tumor stage kidney cancers are those that are under 7 centimeters in size and are largely confined to the kidney tissue itself.
Hi, I'm Phil Perazio, professor of urology and the section chief of urology at Penn Presbyterian Medical Center and the west side of the campus in University City. It is my absolute pleasure to be talking to you today about my surgery for kidney cancer. We're going to do this talk in two main parts. We'll talk about the surgical options for kidney cancer so we understand what they are, and that will help us choose the right surgery and the right surgeon. So the first big question is, do you actually need surgery for your kidney tumor or for your kidney cancer? And it's really important to start this conversation about surgery with active surveillance. And active surveillance is a strategy that is purposeful, where repeat or serial imaging is used to evaluate patients, typically with what we call small renal masses. These are tumors less than 4 centimeters. And the AUA, or the American Urological Association, says that this is a completely safe initial strategy for the vast majority of patients with tumors under 4 centimeters. And where does that data come from? Well, it actually comes from us. We started the Disarm Registry in 2009, back when I was at Hopkins, and we brought it here to Penn. It now catalogs almost 1,000 patients who've chosen either surgery or active surveillance for their small renal mass. And what we've seen over time is, even though about 10% of the population has died, only 3 deaths out of 1,000 are attributable to kidney cancer. And actually 2 of those happened in patients who had surgery. So we know surveillance is an extremely safe option for patients with small kidney tumors. And once we leave the realm of active surveillance, we get into active treatment. So what are the invasive treatments for kidney cancer? Well, partial nephrectomy is removal of just the mass and sparing a kidney. Radical nephrectomy is removing of the entire kidney. That can be done with a node dissection, with what's called a tumor thrombectomy, if that kidney cancer is actually growing into the veins that surround the kidney. And it can also be done in a cytoreductive or consolidative manner, which is done for patients who have metastatic cancer, cancer who's already spread from the kidney. And lastly, there's ablation, which I'm not going to talk too much about today, but thermal ablation is most typically done with cryoablation, either freezing a mass or burning it with radiofrequency or microwave. Can be done with radiation therapy or something called stereotactic, extremely high doses of radiation. And there are some new technologies emerging, something called ultrasound ablation, which should be coming online in the next year or two. And so let's start with radical nephrectomy. Traditionally, this was the classic surgery for kidney cancer, and it refers to removal of the entire kidney. Typically, it refers to what's called Gerota's fascia, which is the natural fat coating that surrounds the kidney, as well as the kidney. All of that fat and the adrenal gland can or cannot be removed as part of a radical nephrectomy, depending on a variety of circumstances. Radical nephrectomy can be done for both small tumors and large tumors, but is typically most appropriate for patients who have what we call advanced stage cancers. These are either locally invasive cancers or cancers that have enlarged lymph nodes or have spread elsewhere around the body. We really want to avoid removing an entire kidney for patients who have benign tumors, the most common being angiomyolipomas or AMLs and cysts. And we really try to avoid removing the entire kidney for patients who have those small renal masses, the ones we can also watch. We'd hate to go down a kidney unless we absolutely need to. Radical nephrectomies can be done through an open incision or in a minimally invasive fashion. We tend to prefer minimally invasive when we have small tumors or smaller tumors. The benefits of doing a radical nephrectomy is that it's relatively straightforward. There are minimal risks typically associated with the surgery because we're removing the entire kidney. The biggest risk is that it will affect patients' kidney function the most because we're removing half of their functioning nephrons or kidney filtering units. All patients who have a radical nephrectomy will experience a decrease in their kidney function, but very few patients, in fact, less than 2% of them, if you look at large population data, will actually end up on dialysis or need a transplant. So it's incredibly rare that this would affect your overall kidney function. This is a video. This is actually a robotic radical nephrectomy with a tumor thrombus. And just to get you oriented, the right side of the screen is the patient's head and the liver is the large organ there. The left side would be the feet. And what we're doing here is we've temporarily stopped the blood flow through the vena cava, and we're removing a tumor thrombus from the vena cava. This isn't a very big tumor thrombus, so this one is done robotically. But you can see small camera, small incisions are done to detach the kidney from its vascular supply. Basically, one artery supplies it, and then the vein here with the tumor thrombus in it. And we can do pretty complex radical nephrectomies now robotically. Now, this does require a big incision to remove the tumor and the thrombus at the end of the case. So why would we do it robotically? Well, patients do a lot better with this operation, and then that large incision is really only open for a matter of minutes at the end of the operation, as opposed to hours for a larger case. And that brings us to partial nephrectomy. This is otherwise known as nephron-sparing surgery, where we just remove the tumor and we spare most of the normal kidney. This is the preferred management strategy for most masses that are what we call stage 1, 7 centimeters or less, although we can even do larger tumors depending where they're located in the kidney. Can be done open or robotic. Typically, robotic is the preferred approach by most kidney cancer surgeons now. The big benefit is we're preserving kidney function, but the risk is that this is the highest risk of the surgeries we do. Kidneys get a ton of blood flow. They get a quarter of what's called the cardiac output, or the blood flow that leaves the heart every minute goes through the kidneys. And so you can imagine there's a tremendous risk of bleeding by cutting into the kidney and reconstructing it. You could also have urine leak, although those risks can really be minimized with expert surgeons and expert centers. When we used to think about what are called absolute and relative indications, we don't use those terms so much anymore as surgeons, but it's important to think about as a patient. You absolutely need a partial nephrectomy if you only have one kidney or if you have tumors in both kidneys. You don't want to have both of your kidneys removed if it can be helped. But we also know patients are at risk of kidney disease, patients who have diabetes, hypertension, genetic conditions that predispose them to kidney tumors are all at risk for future renal insufficiency and should really think about partial nephrectomies. The technique, well, we temporarily stop the blood flow to the kidney. This can be done with what's called warm ischemia or cold ischemia, using ice to cool down the kidney. We want to remove the entire tumor, typically with a small but clear margin to make sure no cancer is left behind. We then reconstruct the kidney and restore the blood flow. As we said, can be done robotically or open. Robotic is the most common and preferred approach now. Once again, I'll show you just a brief video. Once again, same orientation, head to the right, feet to the left. That is a clamp going on the renal artery, which is temporarily stopping the inflow to the tumor. And what you see here is we're excising or cutting into the kidney around this tumor, which is the round yellow structure that's now being held up and to the left. And you see this kind of crater or defect in the kidney, which is where we make sure we have a clean margin, and that is good, healthy kidney on the inside. Once the entire tumor is removed, we can then switch out our instruments and sew that defect closed. And here you see just some of the suture being used to close the inside of the kidney before we go ahead and close the outside of the kidney. Do a couple hundred of these operations per year here at Penn. What about the recovery from surgery? Why would you want to do an open surgery versus a robot surgery? So in general, robot surgeries are 2 to 3 hours and include an overnight stay. Some people will obviously stay longer. Most people recover about 80% of their function within 2 weeks and fully recover 4 to 6 weeks after surgery. With open surgery, the OR time is about the same, typically about 2 to 3 hours, but everything else is twice as long. Hospital stay in general, 3 to 5 days. Can take as long as a month to get to 80% recovery and a full 3 months to recover from a big incision. Really important to remember, though, that long-term, 6 months, a year, 2 years after surgery, the recovery is exactly the same and patients do incredibly well. I'll show you some of the incisions we make. This is a schematic with some of the common incisions, open incisions we make for kidney surgery. And you can see they can be done in a variety of ways, and we often tailor those incisions to the patient, to the tumor, and to the surgery that needs to be done. Here's a post-op picture of robotic incisions, and you can see 4 small incisions on the patient's left and 1 larger one near the midline where the tumor was removed. And this is a fresh post-op open incision. This was done for a tumor thrombus. And not always do we get to choose our incisions. It really is a lot of times the biology and the tumor that determines what the best and safest approach is. And while you might want a robotic surgery, or you might prefer open, the surgeon will help you decide what is the best approach for your tumor, your cancer, and your overall best outcome. So I'll just kind of summarize our management strategies here. So we'll start with surveillance. This is ideal. Staying out of the operating room is ideal for patients with 2 centimeters or smaller tumors, although we can watch many patients up to 4 centimeters and even a few patients who have tumors bigger than 4 centimeters. The approach is serial imaging, and the big benefit is avoiding unnecessary treatment and a very small risk of developing metastatic disease. Patients who undergo partial nephrectomy, this is for basically our localized kidney cancers, where location is more important than size and our technical ability to do the surgery. Most of these are done robotic, but an open partial nephrectomy is still a very safe and good operation that we do not infrequently. Big benefit is to maximize kidney function, although it does have the risks of bleeding and urine leak because we are cutting into the kidney. The last nephron-sparing approach is ablation, which I didn't spend a lot of time on, but this is ideal for tumors that are less than 3 centimeters, typically on the periphery or outside of the kidney, where our interventional radiologists can easily get to these masses through the skin. Saber or stereotactic radiation size is less important, but it's more about location in the body. Typically done, as we said, percutaneously or through the skin. It has the lowest risk of complications or morbidity, but most ablative techniques will not totally get rid of tumors, and so you will always see them. And so we talk about local persistence versus recurrence. Recurrence rates are low, but it's an important conversation to be had. And then lastly, we talk about radical nephrectomy, and this is typically done only with tumors that are really not amenable to nephron sparing or partial nephrectomy, patients who have tumor thrombus or cancer growing into their veins, locally advanced cancers either in lymph nodes or growing into structures around the kidney like the intestines or the liver, and for patients who have metastatic cancer, meaning cancer that has already spread. We typically prefer to remove the entire kidney than to try and just remove the focal local kidney. Most of the time, we do robotic surgery, but the approach is really equivalent here. The outcomes, the really important outcome is cancer cure, and if an open incision is better than robot for that, that's the approach you should have. The big benefit is that it's definitive. The entire kidney, the entire cancer is removed, but it does carry the greatest risk in decrease in renal function, which for most patients is not impactful, but for some patients can certainly make a difference. So in the second part of our talk, how do we choose the right surgery and surgeon? Well, first thing that's important to note is that experience matters. And this is just a graph, one simple example, showing that operative time for radical nephrectomies decreases pretty dramatically over a surgeon's experience as they do hundreds and hundreds of cases. You could also look at things like blood loss and oncologic outcomes. And we know, as in many surgeries and many cancers, experience matters. So you want to go to someone who's done at least 100 cases or has been trained in a place where they do hundreds of kidney surgeries, so they understand the nuances of the surgical approach. But experience also matters prior to the operating room and in the clinic. These are complex graphs, but these are called caterpillar plots. And what they show is the variation in treatment by an individual urologist or surgeon. So you can see briefly, only about 13% of surgeons will recommend non-surgical management or active surveillance. 30% will recommend partial nephrectomy, 40% a radical nephrectomy, and only about 12% thermal ablation. Now, we expect some variation, right? We all have people in our practice. There are some of us that do more partial nephrectomies than are others. There are some who are great at radical nephrectomy, so we do expect some variation, but we see tremendous variation that we know we can improve upon because people often choose the thing they're best at, not necessarily the thing that's best for the patient. So second opinions from experts are extremely valuable for these less common diseases like kidney cancer. And we think 60, 70,000 people per year in the US diagnosed with kidney cancer. Not all of them are surgical, need surgery, but having that expert opinion is extremely valuable. Average urologist sees about 6 to 7 kidney cancers a year because there's only about 10,000 urologists in this country. Second or third really important opinion here is don't ever feel pressured or rushed into a kidney cancer surgery. There's really good data that says kidney cancers are probably born decades before they actually come to diagnosis by CT scan, MRI, ultrasound, blood in the urine, however it's done. So the tumor has been there for years. It may have grown over the last months, or it may have shown some aggressive features over the last months, but that cancer has been there for a very long time. So you do not need to act in a matter of hours or days, especially if you feel pressured or rushed into a treatment choice. It's certainly okay to seek out second opinions and think about what you want done. And when we think about managing any cancer, but specifically kidney cancer, the first thing we always think about is tumor factors. Do you have a big tumor? Do you have a little tumor? Is it in the middle of the kidney? Is it outside of the kidney? Is it a tumor thrombus? Has it already spread? These typically help us decide the first steps in treatments. Then we want to think about your individual health factors. The most common one we talk about with kidney surgery is kidney function, but this could also be lung function, heart function, your overall mobility. How can a surgery affect your ability to recover and your ability not only to have a long life, but a healthy and good quality of life for the remainder of how long any of us are around? And then the last part of this is preferences and values. Every patient and family are going to have individual preferences and values. Every surgeon is going to have different preferences and values, and we want to try to align those as much as possible. So to summarize, not all kidney cancers and kidney tumors require surgery immediately. Active surveillance is a great option for many patients with small renal masses and small kidney cancers. So before you rush off to the operating room, think about if this can be managed without surgery. Second, really, tumor characteristics and surgeon experience are going to determine both if nephron sparing or saving a kidney is possible, as well as the approach, open versus robotic. You may not be a candidate for exactly what you want, but an experienced surgeon should be able to talk you through the rationale for the correct choice. Remember, surgeons want the best for you, but skill sets and experience may vary. So you may really like the first surgeon you met. They may be a great person and they may really want to help you, but they may not have the right skill set or experience to help with your kidney tumor. And surgeon experience certainly matters. First, as we select choices, but then in terms of our outcomes, both surgical outcomes in the operating room and hospital stay, as well as our cancer outcomes, which really are the most important long-term choice here. Lastly, take a deep breath. A second opinion or third opinion can be extremely valuable, especially when you're dealing with a relatively rare disease like kidney cancer and kidney surgery. You ultimately may end up with the first surgeon you met. You may really like them. They may be really good at what they do, but getting that second or third opinion can help you maintain confidence in that choice. And if they're not the right person, then you found the correct person in your second opinion. So I wish you the best of luck. Here's my contact information. I look forward to talking to you in the future.
Good morning. My name is Vivek Narayan. I'm a GU medical oncologist here at the University of Pennsylvania, and I'm really glad to be a part of this conference again this year, and specifically to present this year on the topic of locally advanced kidney cancer. I think as brief background as we get started, one important concept to begin with is the concept that kidney cancer we know is a highly variable disease. There are some kidney cancers that can be more slow growing and have more indolent disease behavior. And these are the snails or the tortoises of the kidney cancer spectrum. And these particular kidney cancers, we generally expect not to be the types of kidney cancers that may cause cancer-related symptoms and be at risk for distant spread or ultimately kidney cancer mortality. However, on the other end of the spectrum, we know that there are some kidney cancers that can grow more rapidly and reach more advanced stages. And these are the kidney cancers, the so-called hawks or hares, that we know are those kidney cancers that are much more likely to result in cancer-related symptoms and ultimately distant spread and cancer-related mortality. We have many different ways of trying to estimate or understand the potential biologic behavior of a kidney cancer. But one of the ways that's most commonly used is an understanding of the size and extent of the kidney tumor itself. And this gets to the concept of locally advanced kidney cancer. The way that we make this assessment is largely through what we call tumor staging. We know that stage 1 and stage 2 tumor stage kidney cancers are those that are under 7 centimeters in size, and are largely confined to the kidney tissue itself. However, when we get to tumor stage 3 kidney cancers, these are those kidney cancers that are beginning to extend out of the kidney tissue, so perhaps into the fat surrounding the kidney itself, or to the vascular structures, the blood vessels entering or exiting the kidney tissue. And finally, when we get to tumor stage 4 kidney cancers, these are kidney tumors that, regardless of size, are beginning to extend well outside of the kidney capsule. So, for example, invading adjacent structures, such as the adrenal gland that sits atop the kidney. And it's really these latter two tumor stages, tumor stage 3 and tumor stage 4, that we ultimately deem as locally advanced kidney cancers. The reason why this is really important is we know that as we move from the left side of the spectrum to the right side of the spectrum, and particularly to those locally advanced kidney tumor types, we know that the risk of recurrence following kidney surgery dramatically increases. And so if we look at this another way, if we look at the 5-year recurrence-free survival, so in other words, the relapse risk or lack thereof for patients following kidney surgery, and we divide patients or stratify the kidney tumors into low risk, intermediate risk, or higher risk disease, we see that there's a clear difference in the 5-year recurrence-free survival rates, where some patients with intermediate to higher risk disease, it's more around 50% relapse risk within the initial several years following kidney surgery. There's many different ways to think about how we could potentially reduce the risk of recurrence following kidney surgery. And one key concept here is the concept of adjuvant systemic therapy. And so this is the use of medicine therapies for especially higher risk kidney cancers after the surgery to try to reduce the risk of recurrence. One important study in this regard is the Keynote 564 study, which took patients with clear cell kidney cancer, all of whom had undergone surgical nephrectomy or removal of their kidney tumor within 3 months prior to study participation. The patients were then randomized either to the use of an immune checkpoint inhibitor called pembrolizumab for up to 1 year following the surgery, or to a matched placebo, also given for 1 year following the surgery. And here the primary endpoint of the study was to see whether the use of adjuvant pembrolizumab for 1 year could potentially reduce the risk of recurrence, or in other words, try to improve the disease-free survival after the surgery. And for this primary endpoint of an improvement in disease-free survival, we saw that this study met its primary endpoint. So in fact, pembrolizumab appeared to improve the disease-free survival following kidney surgery relative to the placebo, where there was about a 32% relative risk reduction in the risk of relapse. But if we look about 2 years after surgery in this population, we still see that up to a quarter of patients still may develop a relapse despite the use of adjuvant immune therapy after surgery. And so when we look at our current national consensus clinical recommendations for those patients, especially with higher risk kidney tumors at the time of surgery, we see that we can either use adjuvant pembrolizumab for these higher risk tumors or standard imaging surveillance after surgery as both potentially suitable management recommendations for those patients following surgery. But we know that there's still a number of essential questions that still remain. First, who really derives the most benefit from using immune therapy following surgery? And more importantly, how can we further improve the risk of relapse and improve disease-free survival for patients, particularly with locally advanced disease? So here, an additional concept that could potentially be applicable is the concept of neoadjuvant systemic therapy. And what neoadjuvant means is giving systemic therapy before surgery and many times after surgery as well. So really a more perioperative approach, and in this case with immune therapy both before and after surgery. And some of the rationale for a neoadjuvant approach would be, number one, could this potentially prime the pump, so to speak, of the body's immune system to better allow for a response to immune therapy after surgery? And also, could we use neoadjuvant systemic immune therapy to develop a better understanding of who's likely to derive the most benefit from immune therapy following surgery? And in fact, this concept of neoadjuvant therapy is an evolving standard approach in other solid tumor cancers, such as breast cancer, lung cancer, and bladder cancer. So just as an example, shown here on the top right of the slide is a patient with lung cancer. And you can see at an initial diagnosis, this patient has a relatively large tumor at the base of the lung. This patient undergoes neoadjuvant systemic immune therapy. And we can see that even after 4 weeks of this immune therapy, there's a marked regression or shrinkage of the size of this primary lung cancer. And ultimately, when this patient does undergo resection, surgical resection of this residual lung tumor, we see that although there is some still residual lung cancer under the microscope, the vast majority of the tissue under the microscope is actually infiltrated by immune cells, indicating the on-target effect of this neoadjuvant immune therapy approach. So how can we begin to apply this concept of neoadjuvant therapy to patients with kidney cancer, and particularly those with locally advanced disease? Well, in fact, this has already been tested in a large phase 3 clinical trial in kidney cancer. So this is the PROSPER study, which was actually co-led by Dr. Haas here at the University of Pennsylvania. And this was an international study primarily conducted here in North America. And here, this study took patients who were being planned for surgery with their urologic oncologist, and patients were ultimately randomized to either receiving 1 dose of nivolumab, the immune checkpoint inhibitor, prior to surgery, undergoing standard partial or radical nephrectomy, and then receiving adjuvant nivolumab, the immune checkpoint inhibitor, for up to 9 doses after surgery. This was being compared to those patients who just underwent the standard surgery, followed by observation with imaging surveillance following the surgery. And here again, the primary goal was to see if this strategy of using nivolumab before and after surgery could potentially reduce the risk of relapse or improve disease-free survival. Here are the baseline patient characteristics for the about 800 or so patients that enrolled in this PROSPER clinical trial. And again, one key point is that the enrollment was based on that clinical tumor stage. And so about half of the patients were actually of a clinical tumor stage of either that tumor stage 1 or tumor stage 2. And ultimately, after an interim analysis of the study results, it was found that there was no significant benefit observed in reducing the risk of kidney cancer recurrence using the perioperative nivolumab before and after surgery. And so ultimately, this is what we call a negative study. But there's many potential reasons why a treatment strategy or a study may not work. One reason, of course, is that the medication is just not effective. A second could be that perhaps the strategy itself is not effective. Maybe neoadjuvant systemic therapy just doesn't work in kidney cancer. But there's many other reasons why a study could potentially not show a benefit. Perhaps we're just not testing the strategy or the drug in the right patient population or in the right way. So here we could potentially learn from some of our colleagues who have understood or better understood neoadjuvant therapy in other diseases. And here's some work from our colleague here at the University of Pennsylvania, who's a cancer immunologist and has done a lot of work in patients with melanoma. And this is work from Dr. Alex Wong, who studied that a single dose of neoadjuvant immune checkpoint inhibitor blockade could potentially predict clinical outcomes for patients with melanoma that have locally advanced disease being planned for surgery. So ultimately in this study, patients with locally advanced melanoma underwent a single dose of immune checkpoint inhibitor prior to their planned surgery, and then again received the immune checkpoint inhibitor for up to a year after the surgery. And what was learned from this mechanistic study is that there was a certain immune cell type called progenitor exhausted T cells, and it appeared to be those patients that had a higher concentration of these T cells appeared to derive greater responses. So in other words, complete responses even from the use of the single dose of immune checkpoint inhibitor. And more importantly, when these exhausted T cells became reinvigorated with the use of the immune checkpoint inhibitor and ultimately had brisk infiltration into the tumor tissue, it's really those patients that derive the greatest benefit from the use of the immune checkpoint inhibitor before and after surgery. And so shown here on this plot, those patients that had that brisk infiltration really did not develop relapse of their melanoma, whereas those patients that ultimately did not have this marker of benefit, ultimately many of them did develop relapse even despite the use of the immune checkpoint inhibitor after surgery. So we know that melanoma is a very different disease from kidney cancer, but how can we potentially apply this concept and potential benefit to those patients with locally advanced kidney cancer? And one important point here is we know that as our kidney cancer systemic therapies get better, there's also a potential greater opportunity to improve our systemic therapy before and after surgery and derive greater benefit. And we can also learn from our colleagues methods to potentially identify those patients who are most likely to benefit and reduce the risk of recurrence. So in that realm, I'd like to just briefly present a patient case of mine that hopefully illustrates some of this potential benefit. This is a patient who's a 57-year-old man, otherwise very healthy, who unfortunately presented with blood in his urine and some flank pain on the left side. He undergoes a CT scan that unfortunately shows about a 12 centimeter, so relatively large, left kidney mass. And on the CT scan, we see that it has this very heterogeneous appearance, as is often common with kidney cancers. But in addition, he also has multiple and rather bulky lymph nodes in the upper abdomen. He undergoes a biopsy of one of these lymph nodes, and in fact, it shows clear cell kidney cancer. He's evaluated by one of our surgical colleagues here at the university, and unfortunately, it's not really amenable to surgery. And this is primarily related to both the size and extent of these lymph nodes in the upper abdomen. And so the patient ends up in clinic with me in medical oncology, and we start him on systemic treatment in the combination of both an immune checkpoint inhibitor and a VEGF receptor TKI therapy. And after a few months of this therapy, not only is there a regression or shrinkage of these lymph nodes in the upper abdomen by about 50% or so in size, but the kidney tumor itself on the repeat CT scan appears to have a more homogeneous appearance and really what the radiologist characterizes as what appears to be what we call a necrotic appearance, which is, in other words, it looks like on a CT scan that as opposed to a lot of viable cancer tissue, more like dead or dying cells. And importantly, we don't see any new sites of kidney cancer spread. And so at this point, he's able to be reevaluated by the surgeon and successfully does undergo a radical nephrectomy and lymph node dissection about 10 months after the initial evaluation. And although at the time of surgery, they do still see some residual viable kidney cancer in the tumor that's been removed, it's largely composed of what we call treatment effect in areas of necrosis, which is again those cells under the microscope that appear to be dead or dying. After the surgery, when the patient recovers, we elect to give him 6 additional months of adjuvant immune therapy, but then we stop all treatment altogether. And when I saw him in clinic just a few weeks ago, now 3.5 years later, there's thankfully still no evidence for recurrent kidney cancer, and the patient has remained off all medical therapies. And so this type of typical patient experience has led us to design a new clinical trial to try to better understand how to improve systemic therapy both before and after kidney surgery for those patients with locally advanced disease. So shown here is a study schema of an ongoing clinical trial that we have here at the university, and this is really a mechanistic study to try to better understand how immune checkpoint inhibitors like pembrolizumab, with or without VEGF receptor TKI therapies like lenvatinib, could potentially improve these immune changes that we see prior to kidney cancer surgery. And specifically, we want to see how this type of neoadjuvant therapy affects those progenitor exhausted T cells, tries to improve the reinvigoration of those important T cells, and ultimately improve the immune response. So this is what we call a neoadjuvant window of opportunity clinical trial, where we get paired tissue and blood both before and after the neoadjuvant systemic therapy, and ultimately trying to not only see how we can better understand how to improve immune therapy for patients with kidney cancer, but ultimately try to improve long-term clinical outcomes. So this study is currently enrolling. We recently began enrollment a few months ago and is thus far going successfully. So just with some closing thoughts, we know that locally advanced kidney cancer is a kidney cancer that is higher risk for both disease-related complications and ultimately a relapse or metastatic progression. Currently, adjuvant immune therapy, which is immune therapy after surgery, or standard surveillance are preferred management options following kidney cancer surgery. We're hoping to identify measures to seek those patients that are most likely to derive benefit from the use of immune therapy and, importantly, decrease relapse rates. At the current time, neoadjuvant systemic therapy has not yet shown benefit in reducing relapse following surgery for kidney cancer, but we and many others have ongoing clinical trials to try to improve this mechanistic understanding and hopefully refine, ultimately, perioperative systemic treatment strategies. So with that, I will conclude and really look forward to questions and discussion. Thank you.
Hello, my name is Matt Zippelman. I'm a GU medical oncologist at Fox Chase Cancer Center in Philadelphia. I specialize in patients with all GU malignancies, but have a special interest in patients with kidney cancer, and I'm excited to have the opportunity to speak with you today. So my talk today is adjuvant therapy for patients with renal cell carcinoma, picking perfect patients despite imperfect evidence. And today I'll try to talk to you about several different things. First, I'll try to set the stage and just give some background about what we as doctors and oncologists mean about adjuvant therapy. I'll give a little bit of updates about the endpoints and clinical factors that we think matter, both for patients and for doctors when we're speaking about how patients can benefit from adjuvant therapy. I'll go into the data a little bit about what we know and what's available for patients when thinking about taking treatment, and try not to get too far into the weeds about the numbers, and just really give an overview about how we see the data and how patients might better view this. I'll look at things both from the doctor perspective and the patient perspectives, and then hopefully close with some points to help seal what I spoke about. So first, what is adjuvant therapy? So this is the definition that we see at the National Cancer Institute: additional cancer treatment given after the primary treatment to lower the risk that the cancer will come back. Basically, when we're talking about patients with renal cell carcinoma, generally the primary treatment is surgery, having your kidney or part of your kidney removed. And we know, however, that unfortunately in too many patients, that even when surgery seems like it got everything, as the surgeons may often say, patients will have recurrences. And we think that this is because microscopic disease, microscopic parts of the cancer have developed the ability to get out of the mass where it started and get through the bloodstream or the lymphatic system and take up residence in other parts of the body. And these lesions eventually start to grow. And unfortunately, this can sometimes happen before surgery. So the idea is, can we give some sort of treatment after surgery to eradicate that microscopic disease and hopefully prevent recurrence? Here's a little bit of a cartoon about that. And so this is what the standard paradigm should be. Patients develop a mass in their kidney. We introduce them to a urologist, a surgeon. The surgeon goes in and cuts it out, and hopefully that takes care of it. But sometimes patients go for surgery, they have a tumor in place, but they may already have microscopic disease that we can't see on scans or detect with blood tests. And it may look something like this. There's small amounts of disease that have already left the primary tumor. In that case, the surgeon goes in and removes it, but that disease is already there. And over time, as we follow with scans or other entities, those will start to grow and eventually establish itself as metastatic disease. So the idea of adjuvant therapy, or at least ideal effective adjuvant therapy, is to give some sort of medicine after that surgery, which will hopefully eradicate that microscopic disease and prevent that from ever coming back. Unfortunately, current adjuvant therapy options are not ideal and not always effective. And so how do we decide both the right patients and the right treatments? And really, a lot of my talk will be going about balancing the risks and the benefits. And really, that's the conversation that we're all often having with patients in this situation. So what are some of the considerations? I think it's important here to set the background and make sure everyone is sort of speaking the same language. So one of the things we think about is overall survival. This is basically the expected lifespan, regardless of cause of death. So essentially, we're trying to help people live longer, whether it's from getting rid of their cancer, but also related to the effects and side effects of treatment. We also think about disease-free survival. So this is a little bit different. And this is really the period of time when patients are living without known cancer recurrence. And so this is the idea that we give a treatment for microscopic disease after surgery, and we're either delaying the time when their eventual metastatic disease will grow to a point that we can see it or detect it with symptoms or on scans, but we may not actually be curing patients. In other words, getting rid of or eradicating all of those cells. But there are other things. This is really not a question just of survival. There's also obviously quality of life, the effects of how the treatment has on patients. And we really want to balance that effect. Of course, everyone wants to be cured of their cancer, but we need to balance that against the short and long-term effects of whatever the treatment is that we choose. And there are other factors as well. The cost of cancer care. I think we've all heard about patients who've gone into bankruptcy or have had financial troubles as a result of their cancer treatments. And that's causing a whole new set of problems for patients and something we want to avoid. I think a newer entity that's being discussed more is the time cost of cancer care. The time patients spend going to and from the doctor, waiting in the waiting room, getting treatment, all those factors that are taken away from their normal life and their time spent with family. And then related to these is how this impacts other family, friends, and other people in the patient's lives. So of these endpoints, what matters to clinicians, and maybe more importantly, what matters to patients? Well, obviously, the ideal goal of adjuvant therapy is to increase cure. And as I'll show later, and as I think many of you would agree, this is certainly one of the most, if not the most important idea. And so this is really where overall survival as an endpoint comes in. And so we want to be able to measure and give a treatment that helps improve overall survival. But overall survival is confounded by other things. Subsequent therapies that patients may get if they do have recurrence can affect ultimately how long they survive. Access to drugs can affect that. And so when we run these trials across different places, including different countries that maybe have availability of better drugs, that can affect how overall survival is measured. And then other unmeasured effects that maybe we don't have a full understanding of, but can ultimately affect overall survival and what happens after a trial or after a patient gets a treatment post-surgery. So that's where disease-free survival comes in, because this directly measures the effect of the treatment on the trial. And so really you're just measuring when does their cancer come back based on the drug that we give them. But this does not necessarily correlate with patients living longer or living better or more patients being cured of their disease. And so while this is a measure that is often accepted as an outcome when we're doing trials and studying adjuvant treatment for patients, this may not really reflect what patients ultimately want: living longer, living better, being cured of their disease. And then what's the cost of whatever we choose, both the short and long-term risks associated with treatment? And this is really the quality of life idea. So a little bit of background about what exists and where the world of adjuvant therapy has gone for patients with kidney cancer. Really until 2017, we didn't have any available adjuvant therapies, and all patients who had surgery went on a surveillance regimen with scans and follow-up at a regular basis, and we just waited to see if their cancer came back. Then in 2017, we had approval of the first adjuvant therapy, the oral drug sunitinib, which is a oral drug that targets the VEGF pathway, a common pathway we treat and target in kidney cancer. However, as I'll discuss in a minute, there was not a lot of uptake of use of this drug because it did not necessarily meet all of the endpoints that were felt important for patients. And then most recently, the approval of pembrolizumab, an intravenous immunotherapy targeting the programmed F1 pathway or PD-1 pathway that is now a standard of care option for patients, at least in the United States. So this is just a little bit about the approval process and these drugs. So I mentioned that in 2017, this oral drug, sunitinib, was approved as an adjuvant option for kidney cancer patients. This was based on the S-TRACK study, and in this study, patients received this drug or placebo. And this was the only trial at this period that showed a benefit compared to a whole host of other trials with similar drugs and similar designs that did not show a benefit. The benefit we saw in the S-TRACK trial was that patients received this oral drug for a year, and they had about a 1.2-year delay or average delay in their cancer coming back, but no improvement in overall survival. And so really, you took a drug for a year, you suffered through the side effects of that, and it basically, on average, delayed your cancer coming back for a year or a little bit more. And given the side effects associated with this in patients who may have been cured, there really has not been a wide uptake of this drug since it did not improve overall survival. And then that leads us to sort of the new round of adjuvant trials, the immunotherapy trials. The KEYNOTE-564 trial led to the approval of pembrolizumab. And this trial compared pembrolizumab to placebo in patients who'd had surgery for their kidney cancer. But again, we see a host of other negative trials or trials that did not show a similar benefit. These trials differed a little bit in their design and used slightly different drugs, but they were overall somewhat similar, and yet one trial showed a benefit and the others didn't. And so trying to understand this and how this might apply to an individual patient is a challenging concept, but I think also somewhat important. So this is one of the few slides I'll show curves and numbers, but I do think this outlines it somewhat. So this is the results of the KEYNOTE-564 trial. What you see is this is disease-free survival again, so the time delaying until your cancer returns. The time on the bottom is months, the time since you started treatment. And then basically the orange curve are patients who got the drug, pembrolizumab, and the blue curve are patients that got placebo. And you see that those curves are different. And so as time goes on, more patients fall down onto the blue line, and that means their cancer has come back versus the orange line. And you see at 2 years, I've sort of marked this, 77% of patients on pembrolizumab were still alive and cancer-free versus 68% on placebo. And so this is the benefit or the delay in time to recurrence that we see from that trial. This is compared to the 3 other trials that I mentioned in the previous slide. And really what you see here is that those curves are on top of each other. So in those other trials, the drug was not better than the control group. Those curves did the same thing. But if you look at the actual numbers, you see that the numbers can be somewhat similar. At 2 years in the KEYNOTE trial, 77% of patients were alive and cancer-free, but it was 76% in the middle trial, the Ipi-Nivo trial. It was 72% in the nivolumab trial. So you see different trials use different patients and can be slightly different. And so maybe one shows a benefit and one doesn't, and that can be really confusing when we're trying to decide what the right treatment is. And this is where really the devil is in the details. The way you design a trial, the patients you include in it, all of these affect ultimately the result that you see. And I'll try to highlight a couple things and why there might be differences here. Basically, this is the KEYNOTE trial that I've highlighted here. And these are percentages of patients on the trial that have a few different factors that may affect outcomes. We know that patients with larger tumors have a higher risk of their cancer coming back. And we can see in the KEYNOTE trial that they had the highest percentage of large tumors. We know that lymph nodes being present or cancer in your lymph nodes can increase that risk. And KEYNOTE had one of the larger percentages of that. Also, non-clear cell carcinomas. These are the less common types of kidney cancer. Most are what we call clear cell, and those probably respond less to immunotherapy, but the KEYNOTE trial didn't include any of those patients while some of the other trials did. Additionally, a type of kidney cancer called sarcomatoid, which is when your kidney cancer has a sarcoma-like appearance when they look at it under the microscope, and these patients these cancers respond the best to immunotherapy, and we see the KEYNOTE trial had the highest percentage of these. And then finally, this some patients, or some of these trials allowed patients who had an area of cancer that spread outside the kidney if it was able to be removed at surgery. And we know that those patients are probably the highest risk. And the Keynote trial allowed some of those patients, but they had to have this done immediately at the same time. Whereas some other trials allowed that, but allowed patients to have their disease resected much later, which may have portended a slower type of cancer biology. And so basically the bottom line is that in the Keynote trial, they may have put on the highest risk patients, which may have helped lead to the benefit seen. So how do we choose the most at-risk patients and then really find out those most likely to benefit? Well, even amongst clinicians, these things differ. The FDA in the United States approved pembrolizumab for use in the United States based on the data I showed. But in the European Union, they looked at it differently, and they felt that this data was weak and did not approve pembrolizumab based on this trial. And so even amongst physicians, what's important and what matters can differ. So I'll tell you how one of the ways that I help patients choose and do this. This is an online risk calculator that I'll often do in the room with patients or before I see them to help them understand what their risk of recurrence is as they're making a decision whether to get treatment. This is really in many ways has a big Philly connection with our presentation here in Philadelphia. This nomogram is available online through the Fox Chase Cancer Center. This was prepared by one of our urologists, Andres Correa, but using data from the large adjuvant ASSURE trial, which was headed by Dr. Naomi Haas, we know from our presentation today. And so there's a lot of Philadelphia connections to this. So this website can be accessed by patients or clinicians alike. Basically, you go in and input some information about your cancer here. Most of these would be available to you with your doctor. And then you can it spits out for you a risk of recurrence and tells you how likely it is that your cancer recurs. And this may help a patient decide, what's my risk and should I think about getting treatment? So I talked a little about some of the factors that matter to doctors, but what really matters to patients? This has been a hard thing to study, but the KC Cure Group run by Dina Battle has done a really nice job with several different surveys with patients trying to understand this. One of their first ones asked several different questions, but one of them was this: if you were able to get treatment to prevent recurrence of your cancer, what would be important for you? And you'll see here the blue and the green, the largest groups of the pie, more than 50% of patients. And in this one, they said more information is needed, or they would only use it if it prolongs survival. So you see patients really according to this, wanted some information, but survival seemed to be the primary focus. Also, as part of this study, they weighted overall survival and disease-free survival as the most important points. But you see toxicity and other things had relevance too. But I'll point out that they didn't really differentiate overall survival and disease-free survival. And so while this is something we debate ad nauseum at medical meetings and amongst doctors, patients maybe don't differentiate these endpoints in quite the same way that we do. This was in a more updated trial or survey done by the KC Cure Group. And this was of patients who either went on or were eligible to receive adjuvant therapy. So 67% of the patients had received some adjuvant therapy, 20% were offered it but declined, and 14% went on one of those trials and were randomized to the control arm of the trial. So one of the things they asked was, what do you estimate as your recurrence based on, and this is stratified by what stage they were. And the green bars here show what the doctor assessed as the likelihood of recurrence, and the orange bars are what the patients thought. And you see the patients tended to estimate a higher risk of recurrence than the doctors did. So there's a disconnect there. Doctors are not doing a good job of getting across to patients their risk. And I've sort of taken the data and made this chart, which I think is telling. The patients were asked what their recurrence risk was, and whether in the first bar, whether it would reduce their cancer risk by 50% or more, and 25% yes, if I take adjuvant treatment, it will reduce my risk by at least 50%. And then about half of patients thought that it would reduce their risk by at least 30%. So this is what patients think taking adjuvant treatment will do. But in actuality, if you look at the pembrolizumab, the Keynote trial, the relative risk reduction is only about 9 to 10%. And so again, we are not doing a good job of really estimating risk for patients. This is another trial where investigators tried to just ask patients how they understand adjuvant treatment and making these decisions. The specifics of this chart aren't important, but basically what I'm trying to show you here is they gave patients sort of two patient scenarios, including risk of recurrence and what side effects you might incur, and asked, if you were in this situation, which path would you choose, A or B? And they had several of these for each patient. And basically the take home was that one thing, that the most important feature that patients graded as well as physicians when either took these tests was improving the chance at survival, and I've marked that here. Although physicians marked that even higher, 50% of physicians said this was most important, about 30% of patients. But I think maybe more importantly is there was a disconnect between things like side effect risk, time on treatment, duration of treatment, time spent in the facility, that was marked much lower by physicians than by patients. And so again, there's a mismatch about what patients view as important and what physicians view as important. And then just what about side effects? What about toxicity? I haven't gotten into the details of immunotherapy side effects here, but I'll just sort of point out across these trials that all of these drugs are relatively similar and have similar side effects, but there are significant side effects that patients are at risk for. On all of these trials, the risk of having a side effect that affects your daily life occurred in about a third of patients. When they looked at which ones of these were clearly related to the drug, because patients can also have effects just from normal life or from the cancer coming back, somewhere between 15 and 30% of patients had side effects that affected daily life. And so these are significant side effects that really impact patients' quality of life. Additionally, about a third to a quarter of patients had to discontinue drug for side effects, and a significant proportion had to take high doses of steroids to treat an immune side effect. And so these are sort of the real risks and toxicities associated with these drugs. And then finally, the idea of time toxicity. And so this was a study not specific to kidney cancer, but where they tried to look at and talk to patients about the risk of time toxicity. And if you look at sort of these hypothetical bars down here in the table, the option A with the blue boxes and red boxes is one chemotherapy regimen, while option B is if patients got no cancer-directed treatment. And what they're just trying to show here is that in this example, patients in option A may have gotten a certain amount of better survival as a result of being this, but a lot of those days were spent in the hospital. So they lived 150 days, but only were home for 90 of them. The rest of them, they spent some time in the hospital, versus 120 days survival, but most of those days are spent at home. And so what are you really valuing here? How much time are you willing to give up, and for what benefit? So some conclusions and takeaways. Really, the addition of pembrolizumab for adjuvant treatment in kidney cancer is certainly a welcome addition. We have a good option now, but it's likely not for everyone, and clinicians really have to help patients choose. Optimizing these decisions based on risk and patient goals is really a process of shared decision-making, and this is really the key part of the discussion. Differences in outcomes across the trials may be due to trial-specific factors, not necessarily that one drug is that much better than the others, but the data is the data, and we have to go with that. Toxicity factors, including physical side effects, but also time toxicity, financial toxicity, these are all important factors, and they need to be discussed with and incorporated into decision trees, both in discussions with patients and in trials. And finally, future adjuvant trials need to prioritize the highest risk patients that are most likely to benefit, and making sure they understand the risks and benefits. Thank you for this opportunity, and I look forward to the discussion during the open session.
Hi, I'm Dr. Eric Yonash. I'm professor of medicine at MD Anderson Cancer Center, and it's a great honor to be able to present at this conference. I'm going to share my screen. And the topic today for my presentation is hereditary kidney cancer. Am I at risk? Here are my disclosures. And so just a couple of cases to get the conversation going. So a 42-year-old woman is found to have tumors in both kidneys. She undergoes a removal of these tumors, and the pathology report demonstrates that these are papillary kidney cancers. So the question really here is it possible she has a hereditary cancer syndrome? Next case here is a 28-year-old woman who presents with sudden loss of vision in her left eye. And the exam reveals several small blood vessels, rich in blood vessels in each retina. An MRI of the brain demonstrates some small spots in the lower part of the brain called the cerebellum. A CT scan of the abdomen shows a couple of small tumors in her kidneys. And the question is, what genetic abnormality causes the constellation of these findings? So we're going to talk about these hereditary kidney cancer syndromes. I'm going to go through these in some details. And then at the end, sort of the question of who should undergo genetic testing will then be addressed. So we're going to talk about von Hippel-Lindau disease. We're going to talk about hereditary papillary renal cell carcinoma, something called HLRCC, or hereditary leiomyomatosis renal cell carcinoma syndrome, Birt-Hogg-Dubé syndrome, tuberous sclerosis, the succinate dehydrogenase or SDH syndromes, and the BAP1 syndrome. So here we go, basically the topics. And before we do that, let's just talk a little bit about what does it mean to have a hereditary syndrome. So here are our 23 chromosomes, and just a fun fact, the reason that they're numbered the way they are is the bigger they are, the lower is the number. So chromosome 1 is the biggest. And then we'll go all the way down the line. So in the chromosomes, we have genes. And there are a whole bunch of genes. There are many, many genes. We have over 20,000 genes in our chromosomes. And we can see here that we have the two chromosomal arms that carry somewhat identical information. And you could have a mutation in one of those chromosomal arms on a particular gene, or you could have one in both. Okay. And depending on whether or not you're dealing with an autosomal dominant or an autosomal recessive hereditary syndrome, this will influence what type of manifestations your person's going to get. So back to that image that I just showed before, if you have an autosomal dominant hereditary gene mutation, that means that if just one of those two genes is mutated, that's enough to create disease manifestation. So over time, that one mutation in that one gene is going to be enough to create these manifestations that may be associated with this syndrome. And the other gene that may be normal isn't enough to kind of rescue. An autosomal recessive situation is one where both genes need to be abnormal or lost to create the disease manifestation. So you're going to have a mutation on both sides inherited for this to happen. And for example, sickle cell trait versus sickle cell disease is an excellent example of where you have, with the trait, there's virtually no symptoms whatsoever, but with recessive, you're going to get the full-blown sickle cell disease. So kidney cancers are not one size fits all. There's multiple different subtypes. And we have here these various subtypes. We have clear cell, papillary, chromophobe, and then there's this benign syndrome called oncocytoma. And there are particular mutations that can occur, hereditary or non-hereditary, that can actually induce these different subtypes. We can have the VHL mutation, we can have a MET mutation, a fumarate hydratase mutation, follicular mutations. These are just examples. There are others, syndromes that can be caused by other types of mutations that can cause kidney cancers. The other thing that's important is the tumor patterns matter in terms of whether or not we think about a hereditary versus a sporadic tumor. So in the case of what are called sporadic cancers, kidney cancers, meaning that these are kidney cancers that are just kind of happening by chance or not because you're carrying some sort of hereditary abnormality, you typically will get one tumor in the kidney. But in the inherited or hereditary kidney cancer syndromes, a lot of cases, you're going to get multiple tumors in both kidneys. The exception to this one tumor is sporadic situation would be HLRCC or fumarate hydratase mutations, where you will typically only get one, although this is inherited. So let's talk about some of these key syndromes. We'll first talk about von Hippel-Lindau disease. So this is a multi-system disorder. It's caused by a mutation in the VHL gene. It's an autosomal dominant disorder, meaning you just need to have one mutation in or a mutation in one of your genes to get this. And these individuals will get multifocal manifestations. First, they get multifocal kidney cancers, as you can see this little cartoon at the top right here. But they're going to get hemangioblastomas, which are benign tumors in their eyes, their spine. They're going to get pancreatic cysts and pancreatic neuroendocrine tumors, renal cysts and multifocal renal cell carcinomas, pheochromocytomas in their adrenal glands, and epididymal cystadenomas and round ligament cystadenomas. So this is not hard to miss. It's a pretty typical or it's very common that patients with VHL disease will get multiple manifestations like this. And, if you know anything about hereditary kidney cancers, this is something that's recognizable. And these individuals require annual follow-ups with imaging studies and various other things to follow them if they're found to have this disorder. Tuberous sclerosis is another autosomal dominant mutation, gene mutation, which is a mutation in the tuberous sclerosis gene. And these individuals, once again, are going to get multifocal manifestations. Oftentimes, they will get abnormalities in the brain, which will maybe cause some cognitive problems. They may get some hamartomas in their eyes. They may get some lung manifestations. They may get some liver cysts. And they may get some benign and occasionally cancerous tumors in their kidneys. And once again, this is generally not hard to sort of detect or identify because of this constellation of findings. And these individuals also need to undergo regular follow-up. Here are just some images. Okay, we have an MRI here on the left, and you can see, so what we're looking at the outer part here is basically the skull, and then the inner part is the brain, and we can see that there are these whitish spots that are in the brain tissue that aren't supposed to be there. On the right here, we have an MRI of an abdomen, and we can see here there's actually a kidney on the right here, and then you can see this round area inside that's not supposed to be there. That's an angiomyolipoma. So these patients can get cysts in their kidneys. They can get these benign tumors called angiomyolipomas, and they can get bona fide kidney tumors. And the most common thing they're going to get are these angiomyolipomas, and 80% of individuals will have involvement of both kidneys. So moving on to papillary hereditary kidney cancer. So this is once again a multifocal syndrome, and like the tuberous sclerosis syndrome that I talked about before, and the VHL syndrome before that, these patients will get multiple tumors in both kidneys. This is also autosomal dominant. It's usually a mutation in the MET gene. These will occur somewhat later in life compared to some of these other syndromes, multiple tumors in both kidneys. And these can, if they grow large enough, have metastatic potential, which is also true for the VHL tumors. And so these individuals require follow-up and perhaps potential removal of these tumors if they increase in size over time. So the follow-up for these individuals, we generally recommend that you start watching with scans around the age of 30 or so. And imaging modalities can be MRI or CT because ultrasound tends not to be super great for following these hereditary kidney cancer syndromes. Moving on now to the Birt-Hogg-Dubé syndrome, a mouthful of a syndrome, but it's because you have these three people who were named after this syndrome, or the syndrome was named after. Once again, this is pretty rare. It causes multifocal kidney tumors. It also can cause some spots on the skin called fibrofolliculomas. These people can also get spontaneous pneumothoraxes, meaning collapse of the lungs over time. And they get kidney tumors, but they can be multiple different types of kidney cancers, including clear cell, chromophobe, and oncocytomas. And you can see here that just sort of a picture of a patient who had these, where you had an oncocytoma, oncocytic kidney cancer, chromophobe, renal cell carcinoma. So multiple different types of things can occur in the same kidney in these individuals. And here we have these bumps on the skin, the fibrofolliculomas. And the follow-up for these individuals is a little bit unclear because of the fact that it's so rare, but we generally recommend that you start getting screening of the kidneys starting at the age of 30. So both for VHL disease, for tuberous sclerosis, and Birt-Hogg-Dubé, as well as hereditary papillary kidney cancer, a lot of these individuals, as we're going to talk about later, if you have parents that have these, syndromic manifestations, and they're diagnosed as having one of these, kids will then get genetic testing relatively early on in their lives to be able to figure out whether or not they're carriers or not of these autosomal dominant genes, which will allow them to get onto a screening program. So let's move on to HLRCC, or hereditary leiomyomatosis renal cell carcinoma syndrome. This is a syndrome that typically will cause single kidney tumors, although it's a hereditary syndrome with a mutation in the fumarate hydratase, or FH gene. These individuals can get very characteristic cutaneous bumps called leiomyomas, which under dermatologic evaluation and pathology evaluation are pretty characteristic. And they can get these fairly rapidly growing kidney tumors in about 20% or so of these patients. And the women in the family who have HLRCC will get fairly large fibroids in their uteruses that often require surgical removal. And so the rapid growth rate of these tumors and early potential for metastases mean that we need to watch the kidneys of these individuals fairly carefully. And if we do see some tumors, we'll get these removed relatively early on. It's a bit different from some of the other syndromes like VHL disease and also the hereditary papillary renal cell carcinoma syndrome that I talked about before. There, if we see tumors in the kidneys, we'll watch them until they reach a certain size, usually about 3 centimeters. And then, that's when they start becoming more dangerous or potential for dangerousness. And then we remove them. In these cases where the HLRCC patients, we see a tumor, it gets taken out. The screening recommendations here, because of the fact that we really don't want these tumors to grow quickly in the kidneys, we're recommending that if you have a family that has HLRCC and you then test the kids and the kids are positive, start doing screening on the kidney tumors or the kidneys at around the age of 10, because we have seen individuals as young as 12 get these manifestations. So let's move on now to succinate dehydrogenase mutations, a mouthful. What this is, and if you might remember from your high school biology classes, the Krebs cycle is the cycle that takes glucose and basically turns glucose into ATP, or fuel for the cell. And there are a number of different enzymes that exist in this Krebs cycle, and mutations in some of these enzymes are associated with kidney cancer syndromes. Like, for example, fumarate hydratase that I was just talking about before for HLRCC is actually one of the Krebs cycle enzymes. Succinate dehydrogenase is one that's immediately next to that. And germline mutations in succinate dehydrogenase, as with fumarate hydratase, can cause autosomal syndromes, which can also include kidney cancers. So these SDH, or succinate dehydrogenase genes, can cause things called paragangliomas, which are kind of endocrine kind of tumors, but they also can cause kidney cancers. And so if you have a person that has SDHB germline mutations, we start recommending that these individuals undergo kidney screening on a regular basis. BAP1 familial syndrome. This is BAP1 is another mutation or another gene that can get mutated. And this is pretty rare, but BAP1 mutations in families can also be associated with melanoma and mesothelioma, which is a sort of a lining of the lung tumor. And Prevalence is pretty rare, but it's still something that we take note of and we look for if we find a patient that has clear cell kidney cancer and a family predisposition. So in conclusion, I've outlined a number of rare but potentially dangerous hereditary tumors that can arise in the kidney. We're trying to figure more and more out about these. In who have these genes will these kidney tumors manifest themselves, how to better diagnose them, how to better treat them if they do arise. So who should get genetic testing? So this is based on the NCCN, latest version of the NCCN guidelines, and sort of a loose sort of summary of this. First of all, close relatives of somebody who has a known germline genetic mutation. So if your parents have one of these mutations, you should get tested because you have a 50% chance of inheriting those. Second would be individuals with kidney cancer who are young, under the age of 46. There's an increased possibility that this is because of a hereditary cancer syndrome. Also, as I mentioned before, anybody who has multiple kidney tumors, this is more likely to be associated with hereditary syndrome. Or if you have kidney cancer and you have a first-degree relative with kidney cancer, that increases the possibility this is inherited. It's somewhat obvious. The tumor characteristics themselves, if these tumors are removed and the pathologist says, this really looks like some sort of a hereditary tumor syndrome, which can be, for example, the papillary, the fumarate hydratase, the tuberous sclerosis-related tumors. They have characteristic findings. That should make one think of germline genetic testing. And then also, if you're an unaffected individual, but you have at least 2 first-degree relatives with kidney cancer, you should probably consider genetic testing. So we're going to go here back in summary. Here are the syndromes. If you were a doctor studying for an exam, this would be a very useful slide, but it's as a patient who's sort of thinking about these things, this has sort of the names, that has the gene location, the gene name, and also some of the key manifestations. And so I'd like to thank you for your attention, and I hope this was helpful and instructive.
Thanks, everyone. It's wonderful to be here. My name is Katie Beckerman. I'm a GU medical oncologist and assistant professor at Vanderbilt University Medical Center in Nashville, Tennessee. I'm very excited to be talking to you today about how to think about what treatment options are available in the frontline setting for patients who have stage 4 or metastatic kidney cancer. So I've entitled this talk, "My Kidney Cancer Has Spread. How do I choose the right combination of therapy, triplet therapy or doublet therapy?" I'll briefly go through this outline, a little bit about why we've created these therapies based on the biology of kidney cancer. How do we stage kidney cancer? What are some of the things that maybe your doctor is thinking about to individualize treatment options for each person? When is it right to start systemic treatment or treatment that goes and covers disease throughout the body? Again, which type of treatment is right for each person? What are some of the broad guidelines that different doctors are able to look up and resources that are available? I'll try to briefly summarize a little bit how we've created those guidelines based on some of the clinical trial data that we have, and then end the talk, if there's time, with a little bit of information on would we ever consider other treatments such as surgery or radiation. So I'm going to start, as I mentioned, to talk about why we've created the treatments that we do have and exist for patients whose kidney cancer has spread. And I've made these 3 bullet points here for you on the left that really, the majority of our treatments really target blood vessels growth, target how the cancer cell itself grows, or target how the immune system could fight cancer cells. And so that's what these pictures really try to represent. And it's a busy slide, but on the left, this picture basically says that we recognize the majority of kidney cancer results because of loss of this top protein VHL, which upregulates blood vessel growth downstream of that loss of VHL. And on the right, I'm showing many of the different drugs that have been approved and where all they act, either at the level of the cancer cell, they're in the orange, or in the blue and green, the level of the T cell where we have immune-based medicines. So when would you even think about using one of these medicines? And I'd say that the majority of people where the cancer has spread outside the kidney, this is what we typically think of as being a definition of stage 4 or metastatic disease. And so there on the left, we use the staging system called the TNM stage. So cancer limited to the kidney is earlier stage, like a stage 1 or a stage 2. Stage 3 is when the cells have tried to start to leave the kidney, either by spreading directly outside into the fat, through the blood vessels. And then stage 4, as I mentioned, is going even outside the organ itself, traveling perhaps to the common areas that we unfortunately see, which I'm showing on the right. Kidney cancer tries to go to the lung, liver, lymph nodes, bone, and brain. And so how do we individualize? How do we understand what the patient who's coming in and sitting in front of us, what their particular kidney cancer is behaving like? And we utilize this knowledge that we've gathered from hundreds of patients. This information was gathered from patients who were being treated on those blood vessel targeting medicines. And we tried and figured out different clinical factors and different lab factors that helped us understand how their biology of their disease, how aggressive their cancer was. And so these are still the same factors, even though we've moved on to some newer treatments such as immunotherapy. We still utilize many of these factors for when a patient, sits with me for that first time to understand how aggressive that cancer is. These different curves on the on your screen in blue, orange, and green just say with each of these risk factors. So for example, with anemia, which means low red blood cells or high calcium or high platelets or high neutrophils, having each one of these means that the cancer is maybe behaving a little bit more aggressively and has our mind thinking a little bit more about how best to treat someone. So I wanted to include this slide because I think ultimately this is a large decision to make, and it's certainly a conversation that should be had between your doctor and with your own goals and your input. So, a back and forth conversation. But when we think about how do we start treatment, what are our patients' goals? What are they worried about? What are the financial implications? What are the side effects based on someone's other medical history? So I think it's not just we see that a clinical trial has improved overall survival and that's the only treatment regimen we're going to recommend. It has to be taken into the larger context. And so we really try to consider the person sitting in front of us and what's best for them. So to the point of trying to think about for each person, I often have to consider what are the other problems a person comes in with. So for example, if someone's been dealing with really hard to treat blood pressure for a number of years, then the side effects on a VEGF tyrosine kinase inhibitors, these blood vessel medicines, we recognize can cause worsening blood pressure. So, I might pick a particular medicine in that class that has less likely chance of causing worsening hypertension or high blood pressure. And on the left here, the immune-related side effects, we know that some persons unfortunately already have an autoimmune disorder and that we could certainly aggravate or exacerbate that problem with some of our immunotherapies. So I think many of us try to take a full understanding of the patient and certainly discuss those risks with the treatments that we have for kidney cancer. So a colleague of mine helped build this, and I like to show this as we've really come a long way with having more treatment options and newer categories to fight kidney cancer. So on the very left, back in 1992, FDA approval of an old method of immune-based treatment with high-dose IL-2. And then kind of in the bulk of the 2000s, many different oral and IV medicines that target blood vessel growth. And then more recently, really since 2015, the last 5 to 10 years, approval of a number of immune checkpoint inhibitor therapies. Again, a novel immunotherapy to fight kidney cancer. So with all of those options, how do we pick? And we use information given to us by these large randomized clinical trials that have shown improved benefit based on controlling cancer, based on tumor shrinkage, and based on overall survival. So this is called the NCCN guidelines. And these are the recommendations for a patient's first treatment option. You can see that it's broken down on the very left into favorable and poor and intermediate. And that's based on those different clinical characteristics I mentioned at the beginning of this talk, the IMDC criteria. But what you'll see is in the favorable risk, it's a combination of one of the oral blood vessel targeting medicines recommended in combination with one of our newer checkpoint inhibitor treatments. And for patients who have a risk factor in their cancer, the poor and intermediate risk also adds an additional treatment option of a combination of immunotherapy. And then, I wanted to highlight here that just to mention active surveillance as one of the things that we think about for individuals who come in and don't have any of those risk factors for their kidney cancer, and we call it favorable risk disease. We recognize that cancer might be quite slow growing. And because many of our treatments unfortunately have side effects, we've recognized by trials led by Dr. Rini in a prospective fashion that we can monitor patients, not start systemic therapy right away, perhaps consider localized radiation or some surgical approach, and then monitor with a regular surveillance scan using, CAT scan or imaging to just monitor this, recognizing that then at some point, it may be that a person needs to start on systemic therapy, but that we don't lose any efficacy by doing this monitoring for individuals who have favorable risk disease. So I just wanted to highlight that if some individuals may not even need to start systemic therapy right away. And so that's this clinical trial that included a number of patients who had good risk disease, no risk factors, and then they were monitored with scans every 3 months in year 1 and every 4 months thereafter. And really what I want to highlight from the results of that trial that did a prospective observational study was that the growth rate of these patients who had good risk or favorable risk disease was 0.09 centimeters per month. And so that's a very small amount and allowed, as you can see here, no difference in the overall survival for patients who on average were able to go approximately 15 months before starting systemic therapy, before starting that first treatment for their kidney cancer. So again, highlighting that favorable risk, if active surveillance is not what you and your physician choose, these are the recommended immunotherapy and blood vessel targeting medicines that we have. And that in the poor and intermediate risk, it's those same treatments. And in addition to that, it's using a combination of immunotherapies. And this is a summary table showing, again, the benefit that each of these clinical trials that have gotten approval for these combination medicines have led to. And I've tried to highlight here because it does have a lot of data here that what the standout features of each of these trials are. So for example, Checkmate 214 was the very first combination therapy. It combines those two immunotherapy medicines. It has the longest follow-up now, and we recognize that it improved overall survival. And compared to our single agent blood vessel targeting medicines, I've highlighted there at the bottom, CR means a complete response. And on a scan, that means for us having no evidence of cancer. So you can see across the board that each of these trials, regardless of whether it was PD-1 and CTLA-4 or, an immunotherapy and combination or an immunotherapy with a blood vessel targeting agent, we were successful compared to the control arm of a single blood vessel targeting medicine to improve overall survival and to improve the percentage of patients who are achieving this dramatic tumor shrinkage and sometimes even taking away the cancer. Again, hoping here that we're improving cure. So there are many different factors that I think it may be too hard to go into today to choose why a physician would choose one of these combinations over another. But one of the concerns with some of these treatments is that we want to do better. We want to cure more people. We recognize some people don't respond to this medicine, and we don't know how to predict who responds to which one always. And so the question is, can we improve and do better by adding all the medicines together? We know there's examples in other cancer types. Here I'm showing you that we know in testicular cancer, when we took multiple different chemotherapies, traditional chemotherapy, that we increased the chance for cure. And more recently, patients who have prostate cancer, they found that we could improve overall survival by putting essentially all the ways that we could fight the cancer all together at once. So the next step for us was to say, well, if we were either using immune medicine or an immune medicine and a blood vessel targeting medicine, perhaps we could, again, improve cure and improve overall survival by putting all of these medicines together. So instead of a doublet, could we try a triplet therapy? This clinical trial read out, I guess, now about a year and a half ago, and it did this exact test. It asked here, it included patients who had intermediate or poor risk disease, so had some aggressive biology, and patients either got the standard of care on the bottom of the combination immunotherapies or all three medicines, two immune medicines with nivolumab and ipilimumab, and here testing the addition of one of those blood vessel targeting medicines using cabozantinib. This trial did have some success in that it met its primary endpoint. The study was designed to understand, would we control cancer better? So we did that by looking at the progression-free survival, and the triplet, all three medicines together, is there in the orange arm, and you can see that is above the blue arm. And so this trial had an improvement in PFS. It also had a benefit by decreasing the number of patients who experienced progressive disease on scans as their response. So you can see here on the right in the control, for patients who got the two immunotherapies, about 20% of patients ultimately progressed on that treatment, whereas in the experimental, when cabozantinib was added, only 8% of patients progressed on that scan. Unfortunately, what we had hoped to see was that there would be an improvement in complete response. Again, understanding that not everyone who has complete response may have a cure, but really using more therapies to try to improve cure, but we did not see that. And there's many questions about, why that was the case. Some concern was that it makes sense, unfortunately, if you use three medicines over using two medicines, there were increased side effects. On the left is a bar graph looking at side effects, any grade. versus grade 3, grade 4. And the grading system just means more severe. So in the black bars is the more severe side effects. And you can see in the triplet for individuals on all three of those medicines, 79% of patients had a severe side effect compared to 56 in the doublet. So many patients had to hold their treatment, didn't get as much of the medicine in, or had to lower the amount of that blood vessel targeting medicine, cabozantinib, due to side effects. And so some question is, perhaps this was just such a difficult regimen, all three of these medicines together, to manage the side effects, that not enough effective medicine was in. I don't think people have given up hope at all in trying to see if there's other ways to make improvements and cure, to maybe grasp a better sense of breadth of the biology for patients with kidney cancer. And so others in this table, I'm just highlighting, there's a number of different trials going on looking at other triplets, either trying to combine different immune and different blood vessel targeting medicines, or trying to fight the cancer actually in a totally different way. For example, I'm involved in a trial combining the immunotherapy medicines with a new agent that targets the metabolism of kidney cancer, using that ciforadenant. So there's lots of new and exciting ideas. I don't think we've seen the last of triplet clinical trials, and trying again to improve our treatments and improve cure rate overall. So I think the conclusion as of right now, and we'll expect to see more data from that trial, but the goal for triplet therapy is to increase cure and decrease number of patients who don't respond to that first treatment. What we've seen so far is that triplet was able to improve cancer control, did decrease the number of patients whose best response was progressive disease, but it had a lot of challenges. Toxicity was seen, and I think we've learned a lot from that trial. So hoping to see going forward more options, and us to learn better ways to manage side effects. And then lastly, just to briefly mention, many of my patients come in and say, well, you're talking to me about treatment, but should I also be thinking about surgery or radiation? And we have lots of data, understanding of when surgery has been helpful and when it hasn't. And I think now we need to understand, in the current treatment era of checkpoint inhibitors, those are those immunotherapy agents, what is the best thing to do? There are ongoing trials trying to test this, but just to give you a broad scope, historically, back when we used high-dose IL-2 and cytokines, we did see that when the bulk of the cancer was in that kidney, taking out that kidney and then doing systemic treatment did show benefit. More recently, those blood vessel targeting medicines that have come up in between and been a mainstay of therapy for a number of years, in kind of early 2000s until our checkpoint inhibitors, these new immunotherapy agents, have been used. We tried to ask the same question: do we need to do surgery as well as target the blood vessels? And it wasn't always necessarily the case that was beneficial to put a patient through a major operation, and to then do systemic therapy did not result in improvement in overall survival. And so, we think that there's, again, obviously this is going to be an individual discussion and based on an individual patient approach, but we still go back to those IMDC prognostic factors, and perhaps for patients who have slower growing cancers where the bulk of the cancer is in the kidney, depending on what treatment is being started and what is needed, it might still be considered to undergo the removal of your kidney or radiation to the kidney to kill those cancer cells. And here's kind of some of the classic examples. So on the left, this would be on top left is a kidney cancer there. This is in the right kidney. It's a large mass. And this person has a single site of cancer outside of the kidney here in the lung. And so it would make sense. This is being able to remove really the bulk of the cancer, and perhaps even, improve symptoms. And there's not a lot of cancer outside of the kidney. These next two examples, it's a little bit of a harder decision because there's more cancer outside of the kidney. Here in the middle example, in the lungs, there's multiple areas. And so perhaps you would start a patient first on systemic therapy and then consider whether or not a partial nephrectomy or some radiation treatment would be done. And then on the last picture, I think, well, there's a large size tumor. Many of us would be worried that putting someone through an upfront nephrectomy might delay them getting to their systemic treatment to control the rest of the cancer in the lung. So I think right now the standard approach is often to start systemic therapy and again consider whether or not a nephrectomy in the later lines would be helpful. So I apologize if I've gone through that very fast, but just wanted to highlight some key points here. You know, we understand a lot about the biology of kidney cancer and how it's escaped the immune system, how the loss of VHL leads to blood vessel recruitment, and have targeted our therapies to really hit that biology. When kidney cancer cells leave the kidney, it becomes classified as stage 4. And we look at each individual patient's cancer based on these IMDC risk factors. As I mentioned, not all kidney cancer requires treatment immediately. Some a small percentage of patients can just be monitored closely with scans. Right now, when you're talking to your doctor, we don't have an exact biomarker, although many people are working on this, to predict which medicine you'll respond the best to. So we have to take into consideration the clinical trial data, medical comorbidities, your other medical problems, what your goals are, and what the data show as being the best treatment options. I still think that right now the current standard of treatment is a doublet immunotherapy-based treatment, but I look forward in coming years to seeing likely more triplets and trying to fight the cancer by different methods. And with that, just wanted to include, again, thanks to the Judy Nicholson Foundation for the invitation to talk to you all today, and include just a list of wonderful resources that the kidney cancer community has.
It looks like Dr. Jonas's presentation is in the background there. Okay, great. Well, thanks for having this wonderful set of talks put together for this morning. And very happy to have my colleagues here, Dr. Pierrazzo, Dr. Beckerman, and Dr. Narayan joining us. And this is a discussion session, and we're going to be looking for questions. And there's Dr. Haas, who's our leader. That's
okay. You can be the leader. I'm happy to help with that question. So,
yeah. Do we have any questions? How's this working? Do we have questions that are coming up on the chat?
So there was a question on the chat by Deb Maskins, who was asking whether there was a way to really explain disease-free survival to patients in a meaningful way that would sort of clear up some of the confusion that I think patients have when they're hearing us talk about overall survival or disease-free survival. And so I don't know if one of the speakers with either adjuvant or perioperative therapy, Dr. Narayan or Dr. Zibelman, do you want to take that question?
I'm happy to start, and then Dr. Zibelman, I'm sure, can add on with any comments. But I think it's a great question, Deb. And I think where your question stems from is some of the confusion surrounding the term survival as it pertains to the term disease-free survival. And so, the term survival in disease-free survival is really a statistical description of what we call a time to event endpoint. It doesn't necessarily imply anything about what we commonly think of as survival in terms of overall survival. And so here, I think the concept to really understand is from the time of surgery, what is the time until development of some recurrent manifestation of kidney cancer? And I think that's really what disease-free survival is trying to capture here. So I think one way to think about it more conceptually is time until recurrence or time until relapse of kidney cancer following surgery.
I agree with everything Dr. Narayan said. I think it's a really challenging topic and distinction to make with patients, and particularly when you're discussing adjuvant therapies and the goals and roles of adjuvant therapy. I addressed this a little bit in my talk. And
I think one way to think about it more conceptually is time until recurrence or time.
Should I keep going? We good? I talked a little bit in my talk that there is evidence that patients have trouble making the distinction and understanding the difference. And, when I talk to patients about adjuvant therapy, I really just try to talk to them about the, I think, primary goal that we all want, which is, can we cure you and use some sort of adjuvant therapy to increase the chance that the cancer doesn't come back? But there's also a chance that regardless it will, and that some sort of therapy may delay that time when the cancer is coming back. And I talk to them about the sort of difference between time on adjuvant therapy and how that might delay when and if the cancer come back, and the risks and benefits of that. And so I try to sort of talk about it in sort of terms of what they may experience in their life, but I think really trying to describe the endpoints and how they're different and how we use them in trials is something that I think is hard for patients to grasp, especially in a 45-minute discussion in clinic for the first time.
Thanks. There were also questions, a couple of other questions. One of them was, is the approach for surgery different for papillary kidney cancer than for other types of kidney cancer? And I think they meant the surgical approach. So maybe, I don't know if Phil is able to be on the call or not. And if not, okay, there he is.
Yeah, no, it's a great question. The brief answer is the surgical approach is the same no matter what the tumor is. So it's not like for a papillary tumor, if we're doing a partial nephrectomy, we want a bigger margin or something like that. What is different is that we are more likely to go to the operating room for papillary cancers in the setting of locally advanced or advanced kidney cancers. And it's basically because most of our systemic therapies are directed towards clear cell renal cell. That's just where we have the most data. In general, our response rates are not as good for papillary and some of the more rare subtypes. So we tend to lean slightly more heavily on surgery in these settings because we know to expect less of a response to the systemic therapies. So someone who has node positive clear cell, you may want to treat them with systemic therapy up front. Somebody with node positive papillary renal cell cancer, which from a biopsy, we may lean more heavily towards surgery.
Hello, this is Jim with the Judy Nicholson Kidney Cancer Foundation.
Thanks, Phil. There was another question that was, I think we can direct this one to Eric. So there was a question about whether the individual kidney tumor should be submitted for genetic or somatic testing in every case.
So I think that question could be asked both from a somatic, from a non-hereditary or hereditary kidney cancer perspective. I'll start with the non-hereditary. So if you have a smaller tumor in the kidney that's clear cell, for example, and that's what the pathologist would call it, the likelihood that additional genomic testing would really provide you a lot of information in 2023 that will change the way we treat this patient is relatively low. When we start seeing tumors that are a little bit unusual, so we've got a number of these different classifications. We've got the clear cell, we've got papillary, we have chromophobe, and then we have unclassified type tumors in that. When things start getting a little bit sort of unusual or weird, if we will, from a pathological sort of designation perspective, then it probably would make sense. What we generally recommend is for the tumors themselves to undergo testing for their genomics, because that helps us sort of better understand what kind of tumor we're dealing with. If you're dealing with a hereditary cancer syndrome, so, I talked about von Hippel-Lindau disease, papillary, renal cell carcinoma syndromes, and that most of the time there, if we're pretty clear on what the syndrome is, then we don't really need to do additional genetic testing on the tumors that are removed from the kidney, because we kind of know what's driving it. So there, the additional information that we would gain from doing the tumor-specific testing isn't super necessary. And let me take this opportunity also to really, once again, and I mentioned this at the beginning of my talk, to clarify the difference between genetic testing for asking the question of whether or not your body has a mutation in the gene in every cell of the body that predisposes you to things like kidney cancer, versus looking at the tumor itself and what type of genetic or genomic changes exist within the tumor that have arisen over the course of the development of that particular cancer. Very distinct differences. And one is to basically figure out, do you have some sort of hereditary cancer syndrome? The second is, what's going on with this tumor, and can this help us inform us in terms of how we further treat that tumor?
So, Eric, with belzutifan or HIF inhibitor likely to be becoming more available for patients with non-hereditary kidney cancer in the future, do you think that is, knowing what their VHL status in the gene is going to be helpful in any way in considering that treatment for patients?
So I think that's a great way, once again, of clarifying how we use the germline genetic testing, basically the whole body testing, which the way the testing is done, by the way, it can be done with saliva, it can be done with a blood test to determine whether or not you have VHL disease or not. What we found in the study that looked at people with VHL disease is that if they develop, and these individuals will develop eye, brain, cerebellum, spine, kidney, pancreas, adrenal gland tumors, that the tumors that arise from VHL disease all respond really nicely to belzutifan. What we also know is that in the study that we did I led with Dr. Schwery in 55 patients, that those individuals who had clear cell renal cell carcinoma, just by what the pathologist looked at, that a lot of them had really nice response to the treatment. And we didn't do genomic testing on the tumor to see whether that tumor had a VHL mutation or not, to be able to answer the question of whether that will increase the likelihood of response, because most clear cell tumors will have some kind of inactivation of VHL in the tumor. So moving forward, I think it's a good question, Naomi. Should we be looking at the tumors of people with non-hereditary kidney cancers and seeing whether or not the presence or absence of particular types of VHL mutations in the tumor will be associated with better or worse response to belzutifan? It's a great question. We don't have the answer for it right now. For now, and I think it's when belzutifan gets approved for treatment refractory renal cell carcinoma. If you got clear cell, you should try it. From a research perspective, we need to get more information from the tumors to see whether or not this can predict for response.
Thanks, Eric. And I think, that sometimes the other reason to look at the somatic tissue is there are some clinical trials out there that sometimes will accept patients that have specific mutations in their tumor. I know of one such trial, which is run by Dr. Yasser Ged at Johns Hopkins, which is enrolling patients with kidney cancer who have a BAP1 mutation, and it can be either a BAP1 mutation in the kidney tumor itself, or it can be, more of a hereditary thing. And he's also enrolling patients with BRCA1 and 2 mutations, which are much more, they're much more common in other kinds of cancer like breast cancer and prostate cancer. But in his trial, it's treating with what we call a PARP inhibitor trial. And I know that in that one, identifying kind of unusual mutations will sometimes open doors for other trials. I'm just looking to see in the chat if, so here's a question for Katie Beckerman. It says, are there ways to modify immunotherapy when a patient develops colitis? Can it be attempted again if colitis becomes controlled with Entyvio, or is it too risky for other side effects to develop? And so Katie, if you can comment, and I'll also say that Taryn Ferencik is speaking about management of toxicity later on this afternoon, so you can also tune into that discussion as well.
Yeah, that's great, Naomi. I look forward to hearing that talk. When I think about modifying immunotherapy, I think that's a little bit of a challenge because we have a pretty strict flat dosing of immunotherapy. But I think to your question of can we re-challenge, the comments I'll say is that we have data from the very first clinical trial in kidney cancer that treated patients with PD-1 and CTLA-4. And the way that trial was conducted, patients who had an immune-related side effect, whether it be colitis or some other side effect that required them to stop therapy, many of those patients continued to have a controlled cancer. And some of them now, we have kind of 5 years of survival data. Some of these even have continued to have great control of cancer without having to restart the therapy. So that's one thing to think about, is that sometimes we almost a little bit assume that if you've had a pretty severe immune-related side effect and you have great control of cancer, that this, altogether represents the fact that your immune system really has been affected by the therapy. There is data from patients who had melanoma and got the same PD-1 and CTLA-4 and looked at, is it safe to restart immunotherapy based on certain situations, and specifically with colitis. And so there is safety data to say that we can, and this is in a different patient population, but we could restart PD-1 with less chance of having recurrent colitis. But I really think it's a very patient-dependent discussion that has to be had. Severity of the colitis, how refractory, how many treatments, et cetera, all those things kind of are how I think through it. And Naomi, I don't know if you have any comments on that when you're thinking through maybe a re-challenge.
So I think absolutely I agree with what you're saying. I do think that it really depends also very, very much on the severity of the patient's side effects. And also, some of us are quicker to institute some of these other antibodies to treat colitis earlier than other people. So I do look at the degree of treatment that a patient is receiving. Did they get treated with steroids for, 2 months before this went away? Did they have a little bit of diarrhea that after like a week of steroids, it was totally gone and they, feel better? So, what we want to do, the problem with immune therapy is that some of the side effects can be permanent. And so we want to make sure that we are treating the cancer, but not loading patients with permanent disabilities that can cause a lot of trouble. And I think it's a fine line to walk. We certainly want to cure as many patients as possible, but and control disease as much as possible, but we do want to weigh into quality of life. I had a question for Dr. Zibelman and Dr. Narayan, and that question is, what do you think, and maybe any of you can chime in, but Dr. Pierorazio as well, I know is interested in this. What do you think are some of the ways that we could do a better job of developing either neoadjuvant or adjuvant therapy trials to really hone in on the patients that we think would benefit? What do you think are going to be the most promising tests that we could use in the future to help design those studies to really get at the meat of the question?
I guess Vivek took the bullet first last time, so I'll go first this time. I think that's a really great and really hard question, Naomi. I think, we've had one large neoadjuvant trial or perioperative trial that I talked about a little bit in my presentation that didn't show a benefit. But I do think there's a lot of potential with using neoadjuvant treatment. And I think particularly the way immunotherapy works, and we think immunotherapy works, is we're trying to get the immune system and the immune cells to recognize that there's a cancer there and then maintain an immune response against that abnormal cancer. And so it makes sense to me to start treatment when patients have a big tumor in place in their kidney and hope that continues after we remove it. And so I do hope that we do try some more neoadjuvant trials and not not just go by the disappointment of the PROSPER trial. I think right now clinical factors are the best way we have to look at that, and so I think trying to really learn from PROSPER and make sure that we pick the sort of most at-risk tumors. Hopefully some genomic factors like Dr. Yonash talked about may help us with that, and maybe whether it's sarcomatoid features or features in the cancer that we know sometimes are more likely to respond to immunotherapy, or specific mutations that we can detect. And I think whether blood-based markers may be helpful. We're trying to use and think about using things like ctDNA, so circulating evidence of the tumor in the blood that we're using in other tumors, not quite as been shown to be as helpful yet for kidney cancer, but that may be another way that we can help stratify and find the highest risk patients. And then I think for adjuvant too, I think really the next sort of generation of adjuvant trials really need to prioritize the most highest risk patients. We have a lot of great data, some of which Naomi, you were able to help us with the from the ASSURE trial, and really understanding who the patients are that are most likely to recur. And I think really running trials that stock it mostly with those patients, I think gives us the best chance of showing benefits.
It's the only thing I'll add to what Matt just said is I completely agree that even despite the negative PROSPER findings, it's really important for us not to throw the baby out with the bathwater and still focus on the potential improvements we can gain from a neoadjuvant approach. And especially as our systemic therapies become more active, that gives us an opportunity to really test those strategies pre-operatively and really try to refine these therapies in a perioperative manner. And I think it really comes down to what I think Matt really nicely highlighted in his talk, that the benefit we stand to gain from perioperative therapy really depends on the concept of risk. And so the relative risk reduction is really dependent on what that baseline estimated risk is going to be. So we should really be testing these strategies in those patients who have an elevated risk estimation, and that's where we're most likely to derive clinical benefit.
I'll just make two quick comments, Naomi. I agree. Matt and Vivek are incredibly smart and established in this area, so I don't have much to add about their systemic therapy, but I will just say, I don't really view PROSPER as a truly neoadjuvant study, so I don't get too upset with those results. There were smaller studies from Hopkins when I was there, one from Memorial that were, phase 1 studies, but, promising early data. I think if you look in every other disease state that has an immune profile like kidney cancer, neoadjuvant therapies are changing the disease. The difference is that for decades in kidney cancer, we had nothing. So we ran to the operating room as quickly as we can. So surgeons and patients are both terrified about any delay in treatment. So I think our biggest challenge is getting patients and surgeons to take a deep breath and say, this tumor has been there for months or years. A few weeks of giving effective systemic therapy that could change the ultimate course here is the right thing to do. So don't rush off to the operating room. That's a much bigger challenge than finding a biomarker, to be honest with you. So, but we're working on it.
Sorry, I realized I was muted. That's a great discussion, and I would just like to mention that one of the other things that came up in the chat was specific about surgery, SBRT, and systemic approaches for papillary renal cell cancer. And Dr. Mohammed, who you heard speak this morning, we're actually going to be replaying that video a little bit later in the next session, I believe. And so he will be participating in that to answer some of the questions about SBRT. And then Ulka Vishampaya is going to be talking about treatment of papillary cancers and other types of cancer like that that need systemic therapy. So I think you'll get some additional treatment discussion about that. And then certainly Dr. Yonish in his hereditary talks. I don't know, Eric, if you want to just mention some of the therapies that are being explored and some of the cancers with mutations like an SGH mutation or fumarate hydratase mutation that or even chromophobe that are under consideration.
It's a challenging field, actually, from a therapy perspective. I'd say the easiest there in terms of specific treatments for specific rare tumors, the FH mutation or the HLRCC tumors, the folks at the NCI found that the combination of bevacizumab plus erlotinib, two drugs that are rarely used in renal cell carcinoma, actually worked particularly well there. Chromophobe is a huge challenge from a systemic therapy perspective, and we're having a hard time really finding something that's working. And that's, I think, a big area of research and discovery right now, and is being supported by grants from the DoD and that, so we can get smarter in that. Similarly, for the SDH tumors, tumors arising from tuberous sclerosis have been found to respond well to everolimus or Afinitor. So that's sort of a short list of at least the hereditary or hereditary-like tumors where we do have some specific types of treatments. It's an area we have to do a lot more work and better understanding. And I think with regards to the questions of specific local therapies and that, you'll hear a lot more from the next speakers.
Getting some other great questions from the chat. One of them was about with meds as expensive as they are, can we benefit from also looking at labs of inflammation like LDH, fibrin, AFP, galectin-3, CA15-3. So we certainly, I think you'll see a variety of cancer centers and oncologists sometimes measuring LDH, lactate dehydrogenase, as a marker. Not everybody does that. I think that the results, when they're really high, they can be useful, but in a lot of patients, it doesn't really correlate with how the cancer is doing. These are certainly, I think there's a lot of thought going into what other things could be measured. I know at one point we had a patient with sarcomatoid kidney cancer who had an elevation of a pregnancy blood test called HCG, which was useful in following them. And that was only discovered because she was going on a clinical trial and we had to do a pregnancy test. So sometimes you stumble over these things that might be high in a particular individual patient, but I think it's very hard to condone looking at some of these other tests without really studying them thoroughly. And the other thing that I worry about a little bit is that insurance covering some of the other tests and racking up costs for patients. So I wouldn't recommend them outright as something to follow. There were a couple of other questions related to immunotherapy, and I think any one of you oncologists could answer these. But the first question is, are there statistics as to the percentage of patients who develop adrenal insufficiency as a side effect of immunotherapy? So I don't know whether one of the three of you want to answer that question.
Happy to start. So I think the question about adrenal insufficiency, or maybe just more generally endocrine hormone-related toxicities in general, is a really great one. I think it somewhat depends on the regimen of immunotherapy that's being used. And so in patients who are getting a combination immune therapy approach, so a CTLA-4 inhibitor and an anti-PD-1 inhibitor, so an example of that would be ipilimumab and nivolumab given in combination. In general, immune-related toxicities, including things like adrenal insufficiency, are at a higher incidence when compared to just receiving an anti-PD-1 immune checkpoint inhibitor such as nivolumab or pembrolizumab by itself. Having said that, adrenal insufficiency overall is, I think, a relatively uncommon immune toxicity. But one of the issues with it is that it can be a very it can be an immune toxicity that has a profound impact on patients. And so although it doesn't occur in very many patients, in those whom it does occur in, it can be very important. First of all, from a symptomatic perspective and a medical perspective, when patients present with acute adrenal insufficiency, that can take a drastic physiologic toll on a patient where they can have a whole variety of problematic symptoms, low blood pressure, profound fatigue, sometimes abdominal pain and electrolyte abnormalities. And so these really need to be promptly recognized and therapy needs to be started right away. And then the other impact of adrenal insufficiency is that when it does occur, it tends to be an indefinite or lifelong toxicity. And so oftentimes patients will be required to remain on some form of corticosteroid replacement for their lifetime. And so although relatively uncommon, it does depend on the regimen that's being used. And when it does occur, it needs to be promptly recognized and often requires lifelong management.
And I might just add to that. I totally agree with everything that was said. And I think maybe the extra thing there is that some patients who unfortunately develop maybe another immune-related side effect, for example, the colitis that we were discussing earlier. And as Naomi mentioned, if someone had been on steroids for a prolonged period of time, this is maybe so it's kind of a side effect of a side effect, unfortunately, that we're giving you steroids to quiet another side effect that could ultimately leave you adrenally insufficient. And certainly we work very closely with our endocrinologist trying to slowly taper and see if we can get the adrenal gland function to return. But that's another scenario, kind of, again, not a direct side effect in this situation of the PD-1 and CTLA-4 medicines. But if you're having another colitis or other side effect that we're using steroids, that can end up leaving a patient adrenally insufficient.
And I'll just add that adrenal insufficiency can be from two causes. One is direct side effects to the adrenal gland, and the other is an indirect, where the pituitary gland, which is at the base of the brain, is affected. And if the pituitary gland is affected, it might be one part of the body, one organ system that's affected, but it could also lead to all sorts of low things like low testosterone or low cortisol or thyroid overactive or underactive thyroid. So we also have to sort of figure out whether it's coming a central problem that was related to the immune therapy or whether it was local. I think there's one other question, and that has to do with the duration of immunotherapy. So the question is, since we've been in the IO world for a few years, so we have a large population of patients with IO experience, what do we know about long-term IO use? And I'll maybe let Katie answer this one, but I'll just say that a lot of our data, again, we are pulling from both melanoma and non-small cell lung cancer because they've had immunotherapy even longer, but it's to some extent, how long to give IO therapy for kidney cancer is still under investigation, but maybe Katie, you can elaborate more on that.
Yeah, I think that's a great place to start. I think the answer is we need to study it further. We don't know how long to use IO, and that's because in our kidney cancer clinical trials, they've been written differently. Some of them, for example, the ones where we use a PD-1 inhibitor and combine that with an oral VEGF medicine, most of those trials were written and stopped where the immunotherapy stopped at 2 years. So that was the amount of data we have for those patients. And then for other trials, we've allowed patients to continue on therapy. As Naomi just mentioned, we have some data from other tumor types where we recognize that continuing immunotherapy can be associated with late toxicities. And so I think we're trying to balance this cautiousness again of wanting to cure as many patients as possible, but not increase or cause permanent side effects for our patients. I don't know if anybody else has anything additional to add.
I think I agree with everything Dr. Beckerman said. I'll just say we just need to learn a lot more. I think that's something that we really need to start researching as these drugs are more and more available for more and more cancers. The issue of survivorship and just sort of understanding the long-term impact of these drugs and its effects, I think are really, really important. And it's something we definitely, all need to work together to study more.
So I want to thank all of the speakers, and we're going to take a short bio break, and to stay on time, the conference will resume at 11 o'clock. But again, thank you, patients, for all of your questions, and thank you to all of our speakers here for giving such great talks. And I believe that the talks will be available at a later date in case you missed any of them to view. Thank you again.
Thanks all.
afternoon. My name is Naomi Howes, and I am a medical oncologist at the Abramson Cancer Center at the University of Pennsylvania. It is my pleasure to co-host this Judy Nicholson Kidney Cancer Foundation Patient Conference, and we are resuming our sessions this afternoon. You will hear from a wide variety of speakers from across the country. Our first speaker, most of these are directed towards more advanced kidney cancer in this next session, and there will be a question and answer session by chat. So please register in the YouTube chat if you're joining. Our first speaker will be Dr. Osama Mohammed, who has recently moved and is faculty at Memorial Sloan Kettering. I'm sorry, MD Anderson, apologies. So with that, without further ado, we will start the session.
Hi, good morning, everyone. My name is Osama Mohammed. I'm a radiation oncologist from the MD Anderson Cancer Center in Houston, and I specialize in treating prostate and kidney cancer. It's a pleasure to be here with you today. All right, let's start. Today, I'm going to be talking to you about the use of radiation therapy in patients who have kidney cancer. And we're going to specifically talk about a specific form of radiotherapy called SBRT. And let's start with my conflict of interest disclosure. I don't have any conflicts of interest to disclose. And let's start with the learning objectives for what my goal for you today is. So today I want to go into details into the use of, again, SBRT in patients with kidney cancer. And I'm going to specifically talk about 5 different kinds of patients or 5 different presentations of patients. And I promise I'm going to define each of these in a second. So patients who have primary RCC, patients who have oligometastatic RCC before starting systemic therapy, patients on systemic therapy but then limited progression or oligoprogressive, and then patients who have kidney cancer which has spread to the brain or spine. And again, let's start first with definitions. So today we are going to talk about kidney cancer, and that kidney cancer it can be still in the kidney, or it could have traveled or metastasized somewhere else outside the kidney. But we are going to still call it kidney cancer, even if it's in the brain, even if it's in the bone or in the kidney. We're going to call it kidney cancer that metastasized. And we're going to specifically talk about one particular form or subtype of kidney cancer called RCC. And it stands for renal cell carcinoma. This is the most common subtype of kidney cancer. About 85% of patients with kidney cancer has this type, RCC. And we're going to talk about the utility of SBRT, which stands for stereotactic body radiotherapy. And this is different than the traditional radiation that is mostly given for other disease sites. It's definitely gaining more and more popularity, the use of SBRT. And when we say SBRT, we mean 3 things. First, we are giving high dose of radiation per treatment session. And we are doing the radiation under image guidance. This is why we call it image-guided radiotherapy. And this means that before every radiation session, we are going to take a picture, usually with a CT scan, to make sure that we are precisely targeting the tumor that we want to target. And also SBRT automatically implies that we are delivering the treatment in 5 or less sessions. And we need the 3 criteria for the definition of SBRT. Now, the disease sites we are going to talk about, the location of the kidney cancer, we're going to talk about kidney cancer that has remained in the kidney. We call it primary RCC. Primary means it's in the primary site, which is the kidney. And we're going to talk about 3 other manifestations or spread of kidney cancer. The first one is when the cancer spread to the brain or to the spine. And we are going to talk about oligometastatic RCC. This is when the cancer has spread beyond the kidney, but oligometastatic. Oligo means few spots. So it's only has spread into only a few spots outside the kidney. And we're going to talk oligoprogressive RCC. This is cancer that has spread outside the kidney to limited sites, and the patient is getting already the systemic therapy. And by systemic therapy, I mean whatever infusions or pills or immunotherapy they're getting. And while they are on the systemic therapy, the cancer is progressing in a limited number of spots. I promise you, I'm going to repeat these definitions multiple times before each section. So let's start. So it's very important for me to tell you, before we talk about all these applications of radiation, I want you to see what is radiation and how it's applied. This is a video I put from YouTube, and I am not making any advertisement for the company, but they have a very nice video. So let's look at it.
Today's radio.
So this is called IMRT. SBRT is delivered use MRT. As you can see, this is the patients on the machine, and you see the head of the machine here is shooting the radiation to whatever site we want. And then these two parts take pictures. I told you about image guidance. So you have image guidance, radiotherapy delivery. And it's very important here to look at the head of the machine. As you can see, in the head of the machines here, there are these metal-like structure, which as the machine is rotating around the patient, these structures will move in and out to conform to the shape of the target that we are treating in order to give this very precise radiation. And now that I've told you how the radiation is delivered, you have an idea what it means. So let's start with my presentation. So the first most common question actually I get asked is this question. And usually when a patient comes to me to see me in radiation oncology or other non-radiation oncology, our colleagues in different specialties, they always ask me the same thing, that my doctor or the doctor would say, kidney cancer does not respond to radiation. Is that true? Well, that was true, but probably a few decades ago. And historically, when we were doing radiation therapy to the kidney, we were using conventional radiation treatments. And by conventional, I mean the delivery methods were old, there was no image guidance. Instead of giving high doses per treatment for 5 or less sessions, we were doing small doses or treatment for large number of sessions, usually 20, 30, or 40. Because of these older conventional radiation treatments, radiation therapy was not effective against kidney cancer until SBRT came and the new studies started to show some effectiveness, some good effectiveness of radiation therapy against kidney cancer. So now almost all patients who are getting radiation for kidney cancer are getting this SBRT. So let's start. I told you we're going to talk about 5 presentations of kidney cancer. The first one is SBRT for primary RCC. Again, these are patients whose cancer is in the kidney, did not spread beyond the kidney. As you can see here, this is a patient. These are the 2 kidneys. Eventually, some of us will develop kidney cancer, and then we can use the radiation to kill the cancer in the kidney. As you can see here, there is no cancer anywhere else on the body. We are going to call this localized primary kidney cancer or localized primary RCC. Who are the best candidates for primary RCC? These are patients who have a single lesion or a single mass in the kidney and it's growing. We do often see many patients who have like 2 centimeter mass that maybe it's growing like 1 millimeter or 2 millimeter every few years. We don't need to treat these patients. So single mass is great. Growing is good because if it's not growing, probably does not need to be treated. Of course, the smaller, the better. Think about it. If we are treating a small mass versus a larger mass, it's always safer and more effective to treat a small mass. Also, the best candidates are those where the cancer did not spread to the kidneys around, to the tissue around the kidney, and there is no cancer in the lymph nodes, and no metastasis, meaning that the cancer did not spread. The best candidates will have good baseline kidney function because radiation will affect kidney function. So the better your kidney function at baseline, the less likely that your kidney function will decline significantly or that you will need dialysis after treatment. And at least 1 centimeter from bowel, because the kidney is here, the mass is on the kidney. Usually there's lots of bowel, small bowel, large bowel, very close to the kidney. So if there is at least 1 centimeter, this can be done very safely. If there is less than 1 centimeter, the radiation could still be done, but we have to do more maneuvering, or maybe we have to reduce the radiation to part of the cancer a little bit in order to make sure we do not damage the bowel. And finally, it's best if the cancer is on one side of the kidney, usually upper pole or lower pole, and rather than in the center, because cancers that are in the center, usually when we do radiation on them, we impact a larger proportion of the kidney as compared to the ones that are more polar, either upper part or lower part. And I just want to point out something very important, that patients with primary kidney cancer, cancer that did not spread yet, their standard of care today is surgery. And usually if surgery is not possible, then the patients are sent to our colleagues in interventional radiology to do ablation. However, more recently, SBRT is gaining more popularity, and we are seeing more patients with primary kidney cancer. What's the process like? Usually patients walk through the door, I meet them as a radiation oncologist, and then once we have decided that, okay, the radiation is useful for them, usually we can do a CT scan and MRI before the radiation in order to understand the anatomy, the size of the cancer, the location in the kidney. We may also need to check other body sites, like to get a CT scan or a bone scan to make sure that the cancer did not spread beyond the kidney. And very often also I would get kidney function testing, like a creatinine blood levels or a GFR. And we may also get a scan called kidney nuclear scan, which tell us the function of the kidney, how it's going. Once we have decided the patient is a good candidate to get SBRT, we bring them to the clinic. We do what we call CT and MRI simulation scan. And on that day, we evaluate how the kidney cancer is moving, because as we move, the kidney move with breathing. And we may do some techniques like breath hold or abdominal compression to limit this up and down movement. And sometimes we may insert a marker. This is a separate procedure by our intervention radiology colleagues. They put a small needle, put small gold marker inside the kidney so that we can see it. And then we may use CT or MR contrast. These are injectable dye during the simulation scan in order to see the mass better. Once we are done with this procedure, we get the CT and MR pictures. We draw our target, we draw the organs that we want to avoid, such as the bowel, the rest of the kidney, and the spinal cord. And then radiation usually starts 2 to 3 weeks later, and it's usually lasts either 1 session, 3 sessions, or 5 sessions, usually every other day, and each session would last 1 hour. What to expect? We don't have like 10-year data or 20-year data because this technique is very new, but at least for last year, a very nice paper was published, and it showed that patients who received SBRT to the kidney cancer that is in the kidney, there is about 90 to 95 chance of cancer control in that area. Of course, smaller cancer has better control than larger cancer, and the cutoff, like we usually say, 4 to 5 centimeter. Treatments done in 1 session maybe have better control than those done 3 or 5 sessions, but it's not always feasible or technologically possible to do 1 session. Most centers can do 3 to 5 sessions. 1 session, we are still, most centers are still trying to understand if they can do it, whether they have the technological capacity. Very, very important point. Let's say a patient comes in, they have kidney cancer, and we treat it with radiation. Although radiation is capable of taking care of that mass in 9 out of 10 patients, in a lot of these patients, we have to continue to monitor the abdomen and the chest, because even if I control the cancer in this area, it's possible that even before the radiation, one of a few cancer cells have already gone to the bloodstream, and eventually they are in the kidney or eventually they are in the lung or they are in the bone. And so we have to continue monitoring for cancer spread, even if the treatment in the kidney has been successful. During treatment, I expect some patients to have some side effects, usually very mild side effects. Nausea, vomiting, we treat them conservatively with Zofran or just lifestyle changes. Very commonly, patients have some mild fatigue. Some patients may have diarrhea. Almost all of these symptoms usually resolve in 1 to 4 weeks. However, from my experience, I notice like patients in their 80s, and I occasionally have treated some patients in their like late 80s, and it just takes a little bit more time for these symptoms, specifically the fatigue, to resolve in these patients. And honestly, in 4 years of practice, the only patient I see, like hundreds of patients, I've seen treated hundreds of patients. The only one patient that could not continue any kind of treatment is a patient who had a kidney cancer. She was an elderly lady, and she was feeling very tired. She was telling me like it felt like she was having the flu every time she get the treatment. She received 4 sessions and she refused to continue the end of the treatment. But again, in younger patients, like in their 60s and 70s, this is very, very well tolerated. Long-term side effects, the most common question I ask, will I become on dialysis after treatment? Dialysis is very rare in these patients. However, we have to be very careful. There will be a drop in kidney function, but usually the drop is very mild. As I told you, we usually do a blood test to get a number called creatinine or GFR. Usually in normal kidney, that number is greater than 60. As it drops 60, 50, 40, 30, then the kidney function is not as good. So patients whose kidney function is in the 30s and 20s, they may progress to dialysis. However, the caveat here is that if we don't treat that kidney cancer, the cancer will grow enough to affect the kidney, and they will progress they may progress to dialysis anyway. So it's a balance. And so we have to be mostly careful about those patients who have poor baseline function, if they have single kidney, or if they have like advanced diabetes or hypertension. Serious side effects such as bowel injury is rare, less than 1 in 50 patients. So the take-home points for patients with primary RCC: SBRT is safe and effective. Control rates are high. Only 1 in 10 will have a recurrence in the kidney. The side effects are rare. However, we have to be careful. We need enough good setup to see the tumor, to manage the motion during the radiation. And it's also very important to know that this is not the number one standard of care for these patients, but it's gaining more popularity as the time goes by. So this is the first indication. Let's go to the second indication, SBRT for oligometastatic RCC. Let's define it again. These are patients who were recently diagnosed with RCC, renal cell carcinoma, that has already had a limited number of spread, like usually less than 5 sites. Or, for example, 3 years ago, they had kidney cancer only in the kidney. The kidney was removed, so we thought they were cured, but now they have recurrence, and the recurrence, let's say, is in 2 or 3 spots in the bone. So it is new diagnosis or an old diagnosis, but new spread, limited number of spread, and should not have aggressive features. We'll go and we'll just explain these aggressive features. And these patients usually, this is what happens. So again, no aggressive cancer, usually less than 5 lesions. Usually our colleagues in medical oncology, they look at the patient in general and look at the big picture. Patient does not have a very aggressive cancer. And they think like, the patient has 3 sites, 2 in the bone, 1 in a lymph node, or 1 in the lung. And they think, what? The cancer is not very aggressive. Maybe I can hold the progression of the cancer, not cure, but hold the progression of the cancer with SBRT or radiation, and I can save the chemotherapy or the immunotherapy or the pills for the future. And usually for example, like this schematic here, 3 sites, we can target them with radiation. Usually after this radiation, we monitor with imaging, such as CT scan or bone scan. And usually in the future, if they have a new sites that's coming up, then we have to make the other decision. Can we repeat the radiation for the new spot? Or should we start systemic therapy, again, the immunotherapy or the pills or combination? And this is, as you can see, this is a multidisciplinary discussion. These decisions can be complex, actually, because there are lots of different little details that are very important for the discussion here in MD Anderson, I see like we have a lot of discussion in tumor board with our colleagues in urology, the surgeon, or medical oncology to discuss these patients. Now, what's the process like? Similar to when we are treating the primary kidney, you come to me, I do evaluation, suitability for the SBRT. But then here, because I'm not treating, I could be treating the kidney, but in general, this is when the cancer spread, treating the area where the cancer has spread. So depending where the cancer is, the setup of radiation, the number of treatments, the side effects of the treatment may be different. For example, somebody who has metastasis to the rib is different than someone who has metastasis to the pelvis, is different than somebody who has metastasis to the lung. Usually, for example, this is my own style. There's different ways of doing it. In the rib or in the bone, I usually do 1 session or 3 sessions. In the lung, I usually do 4 to 5 sessions. Each one is a little bit different, and this is beyond the scope of this talk. And again, for each one, there is a different setup. For example, the lung, the cancer in the lung will move with breathing, but the cancer in the bone will not move with breathing. So the way I set up the patient and evaluate and treat is different. But again, usually 1 to 3 to 5 sessions, 1 hour each session. And usually I can treat multiple sites. For example, if there is like a rib and a pelvic bone, I can treat both on the same day, no issues at all. What to expect? Again, cancer control in the area that is treated is very high. 1 in 10 or 1 in 9 patients will not have recurrence in that particular spot. But remember, the cancer is already spread. So our enemy is not where we treated, but in the other spots where we did not treat because we cannot see. There's nothing visible on imaging yet. So the highest risk of recurrence is elsewhere, usually in the bone and lung. And studies have suggested that in carefully selected patients, this SBRT strategy may delay the start of systemic therapy by 1 year. Again, I told you this is a patient comes to the door. Our colleagues in medical oncology say, you know what, maybe I don't need to start you on systemic therapy. Let's do the SBRT, and then we give you systemic therapy when you progress in the future. And again, this strategy may delay systemic therapy by about 1 to 1.5 years. Again, the side effects of the treatment are dependent on where the cancer is. Cancer in the abdomen, kidney cancer in the abdomen or pelvis usually cause nausea, vomiting, diarrhea, fatigue. In the lung, fatigue, difficulty swallowing, cough, chest pain. Again, mostly are mild. They resolve within 1 to 4 weeks. Have to be very careful with older patients. And again, long-term side effects usually are the serious ones are not very common. Bone fraction does happen, such as in the rib or vertebra, is like in about 1 in 10 or 1 in 5 patients. However, most of these are completely asymptomatic. For example, somebody fractured the rib. In the majority of cases, it is not a big deal. Now, take-home message, the decision for the treatment of patients with oligometastatic RCC is multidisciplinary. We have to be talking with our colleagues, medical oncology, urology. The treatment is safe and effective with minimal impact on patients' quality of life, and it's supported by retrospective and prospective clinical trials. Large clinical trials are pending. They are on the way, and it's good for patients mostly with non-aggressive subtypes. The third presentation of patients is patients with oligoprogressive RCC. Again, these are patients who have, for example, give you an example, they have metastatic RCC that has spread, and maybe last year their medical oncologist already started them on some form of systemic therapy, for example, immunotherapy and pills, or pills alone, or immunotherapy alone. And the patient is doing great, they are tolerating the treatment very well, and everything's going well, except maybe 1 or 2 spots in the body are showing that they are becoming resistant to the immunotherapy or the systemic therapy. So here the medical oncologists, they say, you know what, the patient is on systemic therapy, these sites are limited, and I don't want to switch the systemic therapy. The patient's tolerating it very well. Overall, in general, he or she is doing well. So, and because keep in mind that although the treatments for kidney cancer have significantly improved over the past few years, we still have limited number of systemic therapy options, and we still have to be very careful. We have to talk with our colleagues, and we have to really make sure that every option we use it very judiciously. So the medical oncologists say, let's try to do SBRT to the progressing side. So I'll give you the schematic. Patients initially treated with 1, 2, 3, 4, 5, 6 spots, metastatic RCC. The doctor say, let me give you a systemic therapy. All of these spots are not growing or are gone, except one area, let's say in the pelvic bone. Instead of switching systemic therapy, we can do radiation to the spot. Again, the patient gets radiation, continue on the same systemic therapy, and in the future, if they progress again somewhere else, we can either repeat the same strategy, SBRT, or we can at that time switch systemic therapy. The process is exactly the process to the kind of cancer I explained in a few minutes ago, which is the oligometastatic cancer. That the process with radiation oncology and the treatment and the breath hold or no breath hold and the imaging and the number of treatments is exactly the same, and it's dependent what area we are treating in the body. But very important caveat, previously the patients are not usually on systemic therapy, now they are. And for a lot of these systemic therapy, for example, immunotherapy, we do not like to give immunotherapy on the same day as radiation, so we try to not have them overlap. You can be getting immunotherapy, let's say you get your immunotherapy every 3 weeks. We can squeeze the radiation between these immunotherapy. And some of the pills, we also will talk to you and to the medical oncologist to stop those pills. We really don't know how much, but usually 7 days to 10 days before and 7 to 10 days after to let the radiation pass, and then we can get back to it. What to expect, again, in the area that we treat, very high rates of cancer control. However, again, because the patient has already cancer that spread and it's already showing signs of resistance, there could be in the future risk of cancer progressing somewhere else. And by doing this strategy in carefully selected patients, this SBRT strategy may delay changing systemic therapy by about 9 to 12 months. Again, what to expect in terms of side effects? Mostly it's related to the areas we are treating. Again, abdomen, nausea, vomiting, lung, fatigue, and difficulty swallowing, and the long-term side effects are rare. Take-home points, decision again should be multidisciplinary. The treatments are safe and effective with excellent control, minimal severe side effects, and it's supported by small clinical trial. Now, the last kind of presentation is patients who come to us usually either with a spot or cancer of the kidney that spread to the brain or to the spine. I will not get into too much detail for this section, but basically patient on systemic therapy, everything is going well. The brain, a spot shows up in the brain. This can be also a nuanced presentation because some of the systemic therapy can cross the blood-brain barrier, go to the brain, some don't. But usually these patients, we see them a lot in the clinic. We give radiation to the brain. Again, the decision should be multidisciplinary. The treatments are safe, and we have to really do good image guidance so that the brain or the spinal cord are not damaged. So finally, in summary, the indication of SBRT for RCC is for primary RCC, kidney in the cancer that did not spread, or cancer that spread but did not start. We don't want to start the systemic therapy yet. We want to delay it a little bit, or that cancer that spread and they are on systemic therapy and 1 or 2 spots are not responding too well, or cancer in the brain, spine, and I did not talk about this indication at all, but sometimes patients come to us, they have very advanced cancer, but it's, for example, it's in their femur, the hip, or the arm, or the shoulder, or a rib, and it's very painful, or maybe at a high risk of fracture. We can do short course of radiation for these patients. And I just want to point out two important national studies that are ongoing or about to start. The ECOG, which is one of the national groups which design clinical trial, and the NRG, also national group which design clinical trial. We have two studies. One is called SOAR and one is called Samurai, and both of them are using radiation in conjunction with systemic therapy to treat kidney cancer. If you want, I think you should ask your doctors if you are eligible for either of these studies. And this is all what I have. I really appreciate the invite from the Judy Nicholson Foundation to give the talk. It has been a pleasure. And this is my email if anybody has any questions. Thank you so much and have a great day.
Hi there, my name is Naomi Haas, and I am a medical oncologist at the Abramson Cancer Center and one of the organizers of the Judy Nicholson Kidney Cancer conference that you are hearing online today. How is everybody doing? So I hope that my talk will complement a lot of the other talks that you're hearing today from other people, but this is in the situation that your cancer might have become resistant to therapy, and this is after you've had one prior type of treatment for advanced kidney cancer, meaning kidney cancer that has spread and for which systemic therapy is needed. So how does one decide what the next type of therapy should be? And this is kind of a shared decision between yourself and your treating provider. And the important questions that I ask myself when I'm seeing a patient, and I also want the patients to think about, is, did I benefit from my prior therapy? In other words, did the cancer shrink or stay stable at least for a while? And did I feel okay on my prior therapy? At the other end of the spectrum is not benefiting from the previous therapy, and that means your cancer got worse on the previous therapy. And kind of in the middle there is a situation that we see a lot, which is my cancer shrank or stayed stable for a while, but I didn't feel well on my therapy. And so, you know, it's really, do I want to stay on this treatment? Do I feel awful on the treatment? So those decisions are and questions are important things to think about in deciding what the next therapy should be. And we physicians use something called the National Comprehensive Cancer Guidelines a lot to help make decisions about what are other good therapies. But I want you to know that there are a lot of choices of therapies out there. And right now, there's really no firm consensus about what the next line of therapy could be. We certainly have clinical studies that show benefit, and I'm going to go over some of those. But what I want you to see here is, and I'm part of this committee, is that we kind of divide some preferences into preferred treatments into whether you've had an immune therapy before, which is prior IO therapy, or whether you've never had an immune therapy before. So some people start on just something like Votrient, or more recently cabozantinib, and some people start on combinations, as you've heard about already, like axitinib and pembrolizumab, or cabozantinib and nivolumab, or lenvatinib and pembrolizumab, or ipi-nivo. So there's lots and lots of different choices. So if you were on a VEGF therapy alone, and a VEGF therapy is a pill therapy that targets the blood vessels, what are some options? So if you had terrible side effects, you might look at an immune therapy because because that's something that you haven't had already. But I do want to emphasize that sometimes another VEGF therapy is better tolerated. So you might feel well on one and not so well on another, or vice versa. If you're resistant right away to a VEGF therapy, then absolutely you want to consider another type of therapy, or you might want to consider another VEGF pill that might be considered more active. And that would be, for example, if you started on a drug like Sutent or a drug like Votrient, it would still be very much worth trying any of the other ones like axitinib or lenvatinib or cabozantinib. So let's look at some established treatments. So here's some evidence that, if you've been on a VEGF inhibitor, that using another one does work. This is an older trial. This was called the Meteor trial, but the two drugs that were tested in patients who previously had a VEGF inhibitor were cabozantinib or everolimus. And obviously in this one, the cabozantinib, which is in blue, did a little bit better than the everolimus, but you can see that everybody did pretty well for at least a couple years on both of these drugs. But as far as shrinkage of tumor, there was more shrinkage with cabozantinib than with the everolimus alone. Now, another example is this other small trial, which was looking at lenvatinib or lenvatinib with everolimus or everolimus alone. And this was also for patients who'd previously had a pill therapy with a VEGF inhibitor. And you can see in this one that there was a lot of shrinkage with the lenvatinib everolimus combination alone, and single agent lenvatinib also has activity. So if you were on an immune therapy, what are some options? So if you had severe immune side effects or you didn't respond, then it doesn't make sense to continue on another immune checkpoint therapy like that. And my advice there would be to go to a VEGF therapy. But if you didn't have side effects or you responded really well, then there is some precedent to considering other immune therapy approaches. So here's a larger trial that looked at patients who had previously been treated with an immune therapy, and they were treated with either this drug tivozanib, which is another drug that targets blood vessels, it's another VEGF inhibitor, or sorafenib, which is a drug also known as Nexavar that has been approved for a long time in kidney cancer. And what you could see with this one was that what you could see with this one is that 26% of patients had already been treated with immune therapy, and there was shrinkage observed in both of these drugs, 18% with tivozanib and 8% with sorafenib. So here's another study, and this one was lenvatinib and pembrolizumab. So it's combining a VEGF inhibitor with an immune checkpoint inhibitor. Pembrolizumab is also known as Keytruda. And you can see in this one that even though people had immune therapy and had had several treatments, if you weren't treated previously with immune therapy, you had a good response. That means partial response or stable disease. And if you previously had been treated with an immune checkpoint inhibitor, you still had a good response. So all of those things look really, really promising. Here's another example of, if you were on immune therapy, how it makes sense to continue to do things with immune therapy. So part A of this study was patients with either clear cell or non-clear cell kidney cancer who were treated just with Opdivo or nivolumab. And if they were divided into whether they had shrinkage of their tumor, so a partial response or a complete response, or if they had stable disease that was about a year or a progressive disease. And in that case, if they had, and this is the group we're talking about here, is, if your disease eventually progressed or didn't do anything, stayed stable, these patients went on to get ipi-nivo. So that was what we call part B of the study. And you can see that even in this case, this is what we call a waterfall plot. And this is a group of patients where the dimensions of the cancer shrank. So this group of people really had some pretty dramatic shrinkage with two drugs when you add a second drug into it. So that's another study that shows that this is an encouraging approach. However, there is a little bit of controversy. So this is the context study, and this was presented at our American Society of Clinical Oncology just this spring. And this was a trial that took patients who were immediately coming off of another immune therapy, and they were treated with either cabozantinib or they were treated with cabozantinib and atezolizumab. Now, atezolizumab is a little bit different than pembrolizumab and nivolumab in that it has what we call a PD-L1 target, and the other two have a PD-1 target. So it's a slightly different drug. And you can see from the results of this study that everybody did exactly the same. Now, everybody did pretty well. You can see that 50% of people were still doing really well without any progression, even at 12 months or so. But it didn't show a benefit. And so that led some people to say, well, maybe re-challenging with an immune checkpoint inhibitor after getting a previous one doesn't work. But I would argue, because atezolizumab is a different type of drug, that we really need to stay tuned for this next study, which is the T-NIVO-2 trial, which is looking at tivozanib and nivolumab or Opdivo versus tivozanib in patients in this situation. And I would just say that the jury isn't out at this point, and I still very much consider treating patients with immune therapy if there's a good rationale for that. So let's talk about some new drugs now. And some of these drugs you've probably heard a little bit about already. For example, Eric Jonash is talking about von Hippel-Lindau, and a drug that has been approved there is this drug Welireg or belzutifan. Now, belzutifan has also been tested in patients who don't have a genetic disorder for kidney cancer. They have clear cell kidney cancer. And this small study of 55 patients treated patients who'd had a lot of different therapies. Some of these people had had even 5 or 6 prior treatments of therapy, and they all got belzutifan until their cancer got worse. And lo and behold, you can see in this group of patients, this is another waterfall plot, that 64% of patients had shrinkage of the cancer. And I don't have time to go into the side effects in this particular discussion, but you can hear a little bit about that from Dr. Jonash's talk. And what's different about this is that this kind of drug has a different side effect type of spectrum. We look for risk of lowering of oxygen levels or lowering of hemoglobin, but you don't get the taste bud problems, you don't get the high blood pressure, and some people tolerate this really, really well. So about 2 weeks ago, there was a press release that the bigger study looking at this for patients with regular old clear cell, not genetically driven, there was a trial of patients who'd previously had a VEGF inhibitor and also had an immune checkpoint inhibitor, and they were treated with either belzutifan or everolimus. And what the press release said was that the study met its primary endpoint. And since the study was run by Merck was hoping that belzutifan would do better than everolimus. So the press release would at least suggest that there's going to be another drug that's going to be easier to be used in treatment of your kidney cancer. Lastly, I want to focus on new drugs and clinical trials. And you're going to hear about clinical trials from Glenn Sykes, who's a patient advocate. But I do want to briefly talk about what a clinical trial is. So phase 1 basically is this is the route that all drugs go through for FDA approval. They go through phase 1, phase 2, and phase 3. And it doesn't matter if it's a blood pressure medicine or it's a chemotherapy. These are the phases. And the phase 1 basically says, are we using the right dose? Are there side effects? So it's sort of a first time a drug is being tested in people. The benefits, though, are that there's a lot of flexible eligibility. It gives you access to drugs that might not otherwise be available. The con is that we don't know what the level of activity will be for your cancer. Phase 2 says that it's being tested specifically in a particular type of cancer. So, for example, kidney cancer. And in this case, there's been some promise in earlier studies, and so they're now looking at it in a bigger group of patients with kidney cancer. And then phase 3 is testing whether the drug is better than what would usually be out there. So the example of the belzutifan versus the everolimus would be an example of a phase 3 trial. And just going back there, clinicaltrials.gov is a website that you can go to see about other trials that might be open for you. So here's an example of a phase 2 trial. This is using a drug called girentuximab, which is radio-labeled to lutetium. So it's a little bit of a radioactive molecule tagged onto an antibody. And what's important about this antibody is that it's targeting a protein called carbonic anhydrase 9, which is a protein that is shown on the outsides of cells of clear cell kidney cancer. So if you have clear cell kidney cancer and your cancer shows this protein, which is done by looking at your kidney cancer cells under a slide and seeing if they stain for it, then you might be eligible for this trial, which is combining nivolumab with this girentuximab. And basically it delivers a little bit of a radioactive dose to all of your areas of kidney cancer in your body. Another example is something that my colleague Katie Beckerman is probably going to talk about in her one of her slides earlier in this conference, and that's a triple therapy. But I argue that these will also be used in second line, and this is using an adenosine inhibitor in combination with ipilimumab and nivolumab. And here's the trial and the study, and she may have shown it already, but we're going to be opening this at the University of Pennsylvania. It's already open at MD Anderson, and it'll be open at Vanderbilt. And the idea is to add other things onto the immune system that massage the immune system further and might give even better responses to patients. Some other combinations are, again, there are other HIF inhibitors being tested like belzutifan. These are other new drugs. They're being tested in combination with immune checkpoint drugs, so PD-1 inhibitors, but also things like adenosine inhibitors. This is another phase 1 study that I saw on clinicaltrials.gov. This is Inhibrx, which is another way to massage the immune system. It's a 4-1BB inhibitor, and that's given with Keytruda or pembrolizumab, and we have that open at the University of Pennsylvania in a number of different cancers. And then this is another drug that stimulates IL-15. So these are other ways to kind of make your immune system work better even with other immune checkpoint inhibitors. And all of these drugs are basically helping your immune system to do better. And then the last group of drugs that are really exciting that are starting to come out now are what we call these CAR-T trials or these BiTE trials. CAR-T stands for chimeric antigen receptor therapy, and BiTE therapy stands for bispecific T-cell engager. So we'll start with the BiTE study. This is the ZenCore study. This is open at a number of sites. And this is an antibody that you can see has two targets. It has one that attaches to T cells, so part of your immune system. And then it has another target that attaches to the cancer cell. And these two go together and they connect, these two antibodies go together and they connect the T cell with the cancer cell. The other thing that's open is a CAR-T trial. And the way CAR-T trials work are that we put a piece of protein into your T cell and we change it and we tell that T cell to go after your cancer better than what your immune system would do. And so there's a CAR-T trial called Allo316, which is open to patients with kidney cancer. We're going to be opening this at Penn. It's open at other sites as well, but it is using a CAR-T that is designed specifically to change your immune system to go after kidney cancer. And I'm going to end my discussion with sort of a fun slide. This is for a prostate CAR T, but you can see what happens here. So in this case, the T cell is armed with this vector. It's usually a virus we put into the T cell, a virus that can't hurt you, and it's targeted against a particular target in your body. And then what happens is the slide isn't working. Oh yeah, it attaches to the TGF beta, so you see that drop down there, and then it activates part of the cell and says, okay, we need you to be more active here. And then the other part of the CAR T, the PSMA in this case, targets the cancer cell, which is at the top of the screen there. So it just sort of shows there are multiple things that happen with the immune system to make things work better. So finally, what I want to show you is, in summary, you have many options. The decisions are based on your prior experiences, both side effects and also how well your cancer did to a particular type of therapy. There are many new directions that are happening, so please stay tuned. And I do draw your attention to these other speakers, which will give you even more information about these drugs and about clinical trials. And I'm happy to take any questions. Thank you.
Hello, everyone. I'd like to thank the Foundation for inviting me to give this presentation today to all of you. My name is Dr. Ulka Vaishampayan. I'm a professor of medicine and GU oncology at the University of Michigan in Ann Arbor. And I am the director of development of novel therapies or phase 1 therapies at the Rogel Cancer Center, which is affiliated with the university. Our today's topic of discussion is going to be on non-clear cell kidney cancer. So slightly unusual or rare variety of kidney cancer is what we're going to be talking about. So our topic of discussion today is non-clear cell kidney cancer, and we're going to try and discuss the current therapies as well as what is cutting edge and new in this disease. So non-clear cell histology, first you have to understand that this is a mixed bag of multiple different kinds of cancer. So, clear cell histology, we know that it's one type of disease that is, you're always going to see on your pathology report that it says clear cell kidney cancer or clear cell renal carcinoma. But in non-clear cell histology, there are multiple different types of tumors, and I've listed the main kinds here. So papillary is the most common non-clear cell histology. So you should always, as a patient, be asking to look at your pathology report, because that is what tells you from your biopsy or from the surgery, that is where you find out what kind of kidney cancer you have. And that's where, if the report says papillary, that is the most common within non-clear cell histology. So it forms about 15% or so of all of the kidney cancers there are. Then there is chromophobe, which is again about 2 to 3% or so of all kidney cancers. Medullary carcinoma of the kidney is very rare, and it is actually seen mostly in young people, and it's associated with sickle cell trait. So if patients have sickle cell disease or trait, that is typically what medullary carcinoma is associated with. Then there is unclassified. Obviously, the pathologist is not clear about where to put it, and those are the unclassified, very challenging to treat because it's very hard to make a decision. And then translocation associated. This is also a disease that is frequently seen in younger patients, and it is associated with the specific genetic translocation that you can detect under the microscope and by FISH testing. And then collecting duct. Collecting duct is a type of kidney cancer within the non-clear cell histology that really is towards the area where the ureter or the tube starts from the kidney. And because it involves that area, it very much tends to behave somewhat like ureter or bladder cancer. And because of that, frequently it is treated with chemotherapy. So let's look at the similarities and the differences between clear cell and non-clear cell RCC. And the reason this is important is, first of all, almost majority of the information that you're looking at on the web or in clinical trials, majority of that is going to sort of involve clear cell kidney cancer patients. Obviously, that's the most common. That is where most of the medications, most of the clinical trials are directed towards. There are some specific non-clear cell kidney cancer studies that have been conducted, and we'll talk a little bit about those. But first of all, looking through the similarities, typically both are going to have kidney mass. I mean, that's a given. Then they can spread to other organs. So clear cell or non-clear cell histology totally can spread to other areas. They can present with blood in the urine, kidney mass, or the symptoms of spread, as in if it goes to the lungs, it can cause fluid around the lungs or cough, shortness of breath. If it goes to the bone, it can cause pain and, sometimes nerve root compression, things like that. So bottom line, it can present the same way. So from the presentation, it's almost very hard to find whether this is clear cell or non-clear cell. And then lymph nodes and lung are the most common areas of spread, same for clear cell or non-clear cell. What are the differences? So the differences are critically important because that is what makes these diseases behave differently. So appearance looks different under the microscope. Clearly, that's going to be the first clue on your pathology report. You will see that the description of the cancer is different from clear cell carcinoma. The cancer cells behave differently too, as they not only do they look different under the microscope, but the overall behavior patterns of spread are very different. Some types, such as the translocation RCC or, medullary carcinoma we talked about, translocation can be associated with very young age, even, teenage years sometimes with the big kidney mass. The genetic makeup of these diseases is very different from clear cell. Medullary carcinoma is associated with sickle cell trait. We talked about that. And then response and treatment may be different. Right now, for the most part, we treat them pretty similar to clear cell cancer of the kidney, but there may be some nuances and differences which are important to identify. So the genes that are associated with non-clear cell kidney cancer are pretty important. One of which for papillary, like I said, that's the most common non-clear cell histology, is papillary kidney cancer. The type 1 has MET gene alterations, and type 2 has each of these that are listed here, multiple different types of genes. Unfortunately, as of now, we don't really apply it to treatments to make treatment decisions. So pretty much, but if there is papillary cancer, there is a specific treatment such as cabozantinib. That one has MET inhibitory activity, and because of that, we tend to use that as the front line. Also, there are clinical trials that have shown us that cabozantinib is sort of the primary standard of care therapy for papillary kidney cancer. Chromophobe. So chromophobe, one of the clues can sometimes be these main genes, the TSC1 and 2. So if you see any of these genes, TSC1, TSC2, it is important for you to be on an mTOR inhibitor. And mTOR inhibitors are, everolimus is one of the common ones used. It's an oral agent that is approved in metastatic kidney cancer. So definitely that would be something to consider. Medullary cancer of the kidney, like I said, the one that's associated with sickle cell trait, has this SMARCA1 gene expression, But so far, that gene is not really used for treatment decisions. But medullary carcinoma of the kidney typically responds to chemotherapy. So frequently, that is what we have to use here. The typical immunotherapy and anti-VEGF TKIs are not very helpful in medullary cancers. Translocation RCC, as I said, usually affects younger population, really no standard therapy, but currently we use both the typical immunotherapy as well as VEGF TKI therapy and sort of monitor the patient. But in general, they do get some responses. This can sometimes be slow growing, but the genes that we see or the translocation really has not translated into treatment decisions. Unclassified, completely variable. You just have to try. Up front, we typically use a combination of VEGF TKI with immunotherapies to see if they respond to something, but this is a notorious disease, and so is chromophobe, by the way. If the TSC1 and TSC2 mutations are seen in very small proportion of chromophobe, otherwise it can be a tough disease to treat. Collecting duct, again, can have any of these multiple gene mutations. Again, not very useful in terms of treatment decisions so far, but also there can be, this is also a disease that we typically use chemotherapy. HLRCC, so fumaritase hydratase, FH gene alteration. This is one treatment that this one usually will respond better to immunotherapy up front. And there is a study that looks at Avastin, bevacizumab plus erlotinib that has shown tremendous efficacy also in this disease. So that is something that came from the NCI that, this combination for this specific disease is fairly helpful. As of now, not a whole lot of help in terms of seeing these genetic mutations. For papillary, though, there are some MET inhibitors that are now in clinical trial testing, but so far there is no specific MET-only inhibitor that has shown enough of a response in papillary kidney cancer for it to be useful and approved specifically for this disease. So here is some non-clear cell cancer studies that were done. So ASPEN trial and ESPN trial. So they have catchy names, and they were basically pretty similar studies that were done comparing sunitinib, which is, as you know, an oral antivascular therapy, compared to everolimus, which was an mTOR inhibitor. So bottom line, what they showed is that sunitinib was typically better, except in chromophobe cancer. So in chromophobe cancer, everolimus was better. So if patients have chromophobe type of disease, you may want to go towards an everolimus-containing therapy as compared to if they have any other non-clear cell histology, then you would go with the VEGF TKI, and in papillary, cabozantinib has proven to be better than sunitinib. So what about VEGF TKI efficacy? Typically, there has been like a response rate of about 14 to 20%. So not great, but disease control rate can be fairly high. And sometimes these can be long-lasting. But the median time to progression was about 8.6 months. So within 8 months or so, typically, you will start seeing progression. You have to start looking at other therapies. Median survival in this particular study, looking at cabozantinib that was used in non-clear cell cancers, was about 2 years. Again, that should be gradually changing. There are ways to sort of tackle patients who have only progression in one or two areas. You have to get creative and do multidisciplinary management. So not just treatment itself, but also adding radiation, for instance, adding surgical management of the disease that is growing. So, but bottom line, what this tells you is that outcomes in non-clear cell RCC need major improvement. So there's a lot of research and work to be done in all of these diseases. So here is one sort of promising study that was recently reported of a combination of both the VEGF-TKI lenvatinib with mTOR inhibitor everolimus. And what it showed is that there was a response in majority of the patients. If you look at this, the people, each of these is one patient, and the patients who are with the bar going below the line are showing a response. So majority of the patients had some kind of tumor shrinkage. Only about 4 patients, as you can see from the bars here, had actual growth of the cancer on this therapy. So this may be a very exciting treatment to consider. Again, these are newer treatments, so we don't have long-term follow-up as yet on a lot of these treatments. And then the left side graph is showing you what we call a swimmer's plot. So this one is the swimmers, the other one is the waterfall plot. Waterfall is showing you that this is a pretty strong waterfall, that there is multiple patients who are getting a response or tumor shrinkage. The swimmer's plot, this length of the bar shows you how long the patients have gone before their disease started showing progression or growth. And as you can see, there are some patients who have gone a long, long time. The pink bar is the papillary kidney cancer, and the blue ones are the chromophobe. The gray is the unclassified. And even in unclassified, we saw somewhat a sustained response with this combination. So here is the standard therapy that was established of Cabometyx. So cabozantinib, or Cabometyx is the trade name, was established as the standard therapy for papillary kidney cancer based on this study, SWOG 1500, or PAPMET trial. And what this study did is that it compared 4 different medications to see which one would emerge as the better one that we should automatically use in every papillary cancer patient. And within these 4, 2 of them, we had to stop the study, those arms earlier, because those were not showing any benefit. So those were crizotinib and savolitinib. Both of these are actually MET gene inhibitors, but they did not show enough of a response to become worthwhile. Between sunitinib and cabozantinib showed a longer duration of response, with median being at 9 months, as compared to sunitinib, the median was about 5.6 months. So that tells you that is what established cabozantinib as the standard therapy for papillary kidney cancer. What about immune checkpoint inhibitors? You know, you will say that you haven't really talked about immune therapies in non-clear cell histology. That's because there is very few studies that have looked specifically at non-clear cell histology kidney cancer with immune checkpoint inhibitors. But this is one. Keynote 427 had a cohort that was only in non-clear cell kidney cancer, where they used pembrolizumab or Keytruda as a single agent in this therapy. And as you can see, clear cell cancer, the patients, about 36.4% got a response. In non-clear cell also, though, there was about 26.7% who had a response. So there was a decent response that makes immune checkpoint inhibitor worth considering in these patients. So then there is another recent study that also showed lenvatinib plus pembrolizumab. So can we combine the VEGF-TKI and the immune checkpoint therapy, put them together, and see what happens? Well, this was a study that looked at that. And disease control rate. So 82% of the patients had some kind of tumor shrinkage in this with this therapy. So if you put combination of lenvatinib, which is an antivascular oral agent, along with pembrolizumab, an immune checkpoint inhibitor, you're likely to get a decent response. Now, majority of the patients were papillary, but there were some chromophobe, 29 patients. For a rare disease, that's fairly decent. And unclassified also were 21 patients. So this was a fairly large study that looked at this combination and showed a decent response. And the response was sustained for an average of about 17.9 months, which is also looking very promising. So the next wave of studies, what are we looking for next? So we are not sure yet if doing the combination is worthwhile, because clearly when you do two treatments, you're likely to get side effects from either one as compared to just doing the one treatment. So I showed you that cabozantinib has been established as the standard therapy. But the next study is SWOG 2200 or PAPMET2, and this is looking at cabozantinib by itself as compared to cabozantinib plus atezolizumab, which is an immune checkpoint inhibitor. So the combination of oral VEGF therapy with immune therapy as compared to just using the oral VEGF therapy. So that is the next study wave. So definitely please look into this study if you are a newly diagnosed patient with papillary kidney cancer, or if you have friends or family members that have this, this study should be available in multiple areas all around the country. So this is something to look at, and primary endpoint of the study is looking how long are the patients, can they go before progression? So progression-free survival. So bottom line, what are our principles of therapy? Whether we do VEGF TKI immunotherapy, we don't know if combining them together is really worthwhile, although it might be. There is some information to indicate that it may be useful. So what the main principles of treatment in non-clear cell histology is, if it is just the kidney mass, no signs of spread, remove it, be done with it, and follow the patient. There's no other treatment you can give the patient after the nephrectomy, after the kidney is removed, that has shown to be of any benefit. But what do you do for majority of your patients will have some pattern of spread? And if they have spread, does removing the kidney mass help in metastatic disease? So that is also a question that is being addressed by a study, the SWOG 1931, called the PROBE trial. And what this study is looking at is that everyone starts on a combination, give them both treatments, a VEGF TKI and immunotherapy for non-clear cell histology also. And then you look at how they respond. So if they are responding or even getting a smidgen of tumor shrinkage at 12 weeks, which is typically when we do our first scan to see how people are responding, then they can get randomized to either remove the kidney mass or keep going without removing the kidney mass. So continuing the treatment is the standard arm. Removing the kidney, in this case, is the experimental arm. So we don't know yet if it's worthwhile to put the patients through a surgery where they lose one kidney, and whether that makes a difference in the long term with the life expectancy of the patient. We have more and more lab evidence. Now, of course, we can show all kinds of great things in the lab, but until they work in actual people, we cannot automatically adopt it. So in the lab, it appears that removing the kidney after you've treated the patient for some time or treated the tumor for some time, 10 to 12 weeks with this treatment, will make a difference in the long-term outcomes, because you're sort of removing whatever is left behind, the resistant clones, and the patient's immune system is already working against the tumor. So that is, in theory or in lab experiments, it looks like that should be the path we should follow. But this study is looking at it in patients, and if removing the kidney does seem to help patients get a longer lifespan, then eventually that will become standard if we show that from the study, which we don't know the answer as of now. Okay, then, so bottom line, what do you do now? Usually for type 1 and type 2 papillary. This is a slide focusing on papillary kidney cancer, non-clear cell. The top line, it can be type 1, which is somewhat slow growing. Type 2 is more aggressive. As I showed you, type 1 is usually associated with MET type of treatments. If you find the HLRCC, then bevacizumab plus erlotinib is a treatment regimen that you can use. Or, of course, you can use VEGF tyrosine kinase. As I showed you, cabozantinib is standard of care. But, or you can think of the study, SWOG 2200, cabozantinib plus minus immune checkpoint therapy. If it is HLRCC, then you need to use immune therapy upfront typically. So immune therapy with TKI or use the combination of bevacizumab and erlotinib. Chromophobe disease, as I told you, try to look for the TSC1/2 mutations. Those are usually helped by lenvatinib, by everolimus, mTOR inhibitors, but the lenvatinib and everolimus combination might be something also to think about. Then medullary carcinoma or collecting duct, typically, as I said, we use cytotoxic chemotherapy, or, you can try anti-VEGF TKIs, but not terribly effective. So the typical things that we use for clear cell cancer of the kidney definitely do not work for both medullary and collecting duct cancers. So important points to consider when tackling non-clear cell RCC. What questions should you be asking your physician, your provider? First of all, review of pathology. Get your slides, the biopsy slides, the surgery slides, the microscopic slides reviewed by a bigger center where the pathologist is focused on kidney cancer, because it can make a difference to making the right diagnosis so you can proceed along with the right treatment. Ask if genomic sequencing should be considered. That is a question you should be asking, because in clear cell cancer of the kidney, really genomic sequencing as of now, as of today, has no real role. In non-clear cell, maybe we'll find targets that could help you get on some unique treatments that might help. So for that reason, genomic sequencing should be considered in non-clear cell kidney cancer. If surgery is feasible, as I said, if it's removable, get it out of there, but majority of them are not. At least half of those patients do not have resectable disease. If there are sarcomatoid or rhabdoid, if you see either of these words on your pathology report, you should be getting immunotherapy in the frontline setting. So that is a disease that absolutely has been shown to be sensitive to immunotherapy. And because of that, if you see any words like this, it is important to identify, because chances are you will have a better outcome by getting immunotherapy. And then for papillary RCC, as I said, cabozantinib is standard, but look for clinical trials because they give you that little bit of edge potentially of getting a more cutting edge treatment over the standard therapy. So bottom line, I want to make my final pitch that I will end with. Each and every advance that we have made has come through clinical trials, has come through people like you who have given up their time, their energy, whatever, and have decided that they would participate in a clinical trial that may help themselves, but definitely they have been of tremendous help to others who came after them with this diagnosis. So absolutely, I make this major plea to all of you that think about clinical trials. They are the cutting edge treatment potentially for you, which may likely help you and others. Thank you. Yeah, so mechanistically, at least in the lab, it was reported that HIF may have a role to play in some of the non-clear cell histologies. So those trials will be there. Just stay tuned.
So there was a question earlier that was asking about whether an area that had previously been treated with radiation could be treated again.
Yeah, the concept of re-irradiation is actually very complex. As in the last 10 years, I feel like we have been much more courageous in doing more and more re-irradiation, especially with the development of SBRT. Now, it depends on a few things. The most important thing is, what is the area of re-irradiation? Like, for example, give you an example relevant to kidney cancer. Let's say we treated previously kidney cancer, and the kidney is here. The most important and the critical structures around the kidney that cannot tolerate lots of those is the bowel, specifically the small bowel and the cord. Now, if let's say a patient have another recurrence in that area, we need to treat. So what we do is we simulate a case where we are retreating that spot, and we calculate the cumulative doses to the cord and the bowel. And we have all these charts that have happened over the last 20 years. What can each organ in the body tolerate? And if we don't exceed that cumulative dose, then we can retreat. And this happens over and over and over again. So it's a case-by-case basis, depending on what was treated, what are the critical tissues around it, what is the cumulative dose for the treatments, and what is the tolerance of these organs to radiation.
Those are good points. I think what I would also add is how long has the radiation controlled that lesion in that
Absolutely.
spot? Because, if you have fairly rapid, I just had a case with clear cell, not non-clear cell, but where about 10 months later, the mass is already growing after radiation. So that might be somebody who I'll just go with systemic therapy rather than doing radiation.
Absolutely. But also, thank you. Also about the time, give you one very specific example where time is very important. The spinal cord has an innate ability to regenerate. So let's say I treated somebody 5 years ago to the spinal cord, and now they need retreatment in the very close area. And we say that the spinal cord can regenerate 50% of what was delivered before. So if I gave them, and these are just to measure, if I gave a patient 20 gray 5 years ago, in my head, considering the regeneration of the spinal cord, I would, in my counting for these cumulative doses, I consider it only 10 gray. But if the treatment was only within the last 6 months, I cannot consider this regeneration. It takes at least 6 months.
Yeah, a good point. Okay, so let's work on addressing.
So can we answer the first two questions again?
First two, let me scroll up.
So the one about SBRT for chronic kidney disease, and the one about belzutifan.
Oh, we should do them again, you're saying?
Yeah, the audio was down.
Oh, I see. Okay, the audio was down. Okay, so I guess the question, let me just summarize, was on whether somebody with chronic kidney disease, where you cannot really remove the kidney because they would lose kidney function, can you treat with radiation for papillary kidney cancer? And absolutely, I think that is the perfect setting, in fact, for consideration of radiation, especially if the papillary cancer is localized only within the kidney mass and no evidence of spread anywhere else. I don't know, some of you wanted to.
No, absolutely. It depends on how big the mass we want to retreat. And again, I don't know if I mentioned it in my talk, if this is the kidney, tumors that are on the top of the kidney or on the bottom of the kidney are very easy targets because they expose a lower part, less of the kidney to radiation. But tumors in the center are difficult because they expose more. But I always tell my patients, I hope everybody knows what GFR is. This is a blood test that we do it's a calculation based on blood tests that we do to measure kidney function. I have treated some patients with good GFR, which means good kidney function, 60 or 70, which is great. But I tell them in the next 2-3 years, the 60 will become 50, the 70 will become 60. So 10 points lost. Now, if a patient come to me, their GFR is 30 or 20, I tell them there is a good chance that you are going to become dialysis dependent. So it's a case by case, depending on where the mass is, how big it is, baseline kidney function. And sometimes, even if you have chronic kidney disease, we do a kidney scan, which tell us how much of the total kidney function in the body is done by each kidney. Sometimes the kidney that has cancer already does not do a lot of work. So it does not really matter as much to do radiation, because most of your kidney function is on the other side.
Okay. So the next question, and hopefully now everyone can hear us. The audio is good. Okay. All right. So the next question was about palbociclib. Somebody's asking about why is palbociclib being used in metastatic kidney cancer trials of late. So there is a hypothesis that was shown in the lab that CDK4/6 can be overexpressed as a potential resistance pathway for HIF2 alpha inhibition. So that's why it's being developed more in combination with HIF2 alpha inhibitors. Single agent CDK6 has also been studied occasionally as a VEGF TKI pathway of resistance also. But that, at least as single agent palbociclib or any of the other CDK4/6 inhibitors, have not shown a whole lot of efficacy. But in combination with HIF2 alpha inhibitors, there may be a role, again, still in clinical trials. Then the next, so that's a breast cancer drug, exactly. Okay, and
there was a question about translocation tumors and having side effects from IO therapy, and what would be another reasonable choice.
Yeah. So translocation tumors, I mean, there is no separate therapy that has been approved. So I think definitely going to a different, if they have significant side effects from the immunotherapy, then you would have to stop that and go to a different VEGF TKI. So I don't know what combination was used up front, but going to cabozantinib or tivozanib, if that wasn't used before, is certainly reasonable. I think.
Your answer of previously need to be repeated. For belzutifan, also the audio was down. Please.
Okay. All right. Is it on now, though, or is it not? Because it looks like every question we are getting that back.
Just those first two questions.
Oh, so I guess I answered one. Was the audio on that time? Okay.
Yes.
All right. I'm losing track. Let me go back to which other questions had I answered before. Okay.
Belzutifan.
Is it being used with
belzutifan and immunotherapy? Okay. Yeah. So again, the answer, the question was, is belzutifan being used in papillary kidney cancer, and should it be combined with immunotherapy? Well, belzutifan as a single agent really is mainly developed for clear cell cancer of the kidney, because that is where majority of the sort of lab information and the pathway, it makes sense. But there are some reports now for some of the non-clear cell histologies where the HIF2 alpha pathway may be active, and belzutifan or other HIF2 alpha inhibitors will start being tested in papillary and other non-clear cell histologies. As of now, though, there is no evidence for evaluating those. So right now, I would say stay tuned. There may be clinical trials coming your way for belzutifan or other HIF2 alpha inhibitors as single agent, or potentially in different combinations with VEGF TKI, so, or immunotherapy for that matter. So just, right now there's no evidence. And do you want to do the retreatment with radiation, or that was heard, I hope? I don't know how far back to go.
Let me
I think you answered that one, and I think people heard, but
okay, good.
Speak up if...
Yeah, please speak up if you need us to repeat that. What regimens are available after first-line IOT? We answered that one. And then sorry. No, that's fine. Don't worry about it. Yeah, as long as the message was heard. But yeah, is there any other question that I may have missed? Yeah, they just responded everything else they could hear.
One more question just came up about chromophobe responding to Lenvima and everolimus. Would it transfer to hybrid? A hybrid tumor.
To a hybrid tumor, yeah. Yeah, I mean, hybrid or mixed histologies are always, it's questionable as to which one is really causing the progression and the major is driving the disease, basically. If there is, like I had said, if there is a sarcomatoid rhabdoid component, usually that is aggressive enough that that is the predominant component driving the disease, in which case, immunotherapy should be used. But otherwise, showing chromophobe response, chromophobe tended to respond better to everolimus, and then potentially, combination of Lenvima and everolimus. But if there is quite a bit of chromophobe, yes. I mean, I think even in mixed histology, that would completely make sense to use that combination then. And it already had in non-clear cell histology a very promising response rate in phase 2 trials. So yeah, that is a combination to consider highly. Really interested in belzutifan in non-clear cell RCC. I agree. We will stay tuned, and hopefully next year's symposium, we will have some study results I'm hoping to report. I mean, all of us are working on that and trying to get belzutifan or HIF2 alpha based trials. So stay tuned.
If there are no other questions, I think we'll take a break until the beginning of the session and resume at 1 o'clock. So thank you for your questions. Thanks, speakers, for contributing, and thanks, patients, for participating in this session.
Thank you, and love the interaction. So please, feel free to contact and keep those questions coming. I'm glad you guys are thinking as much also about, and please continue to, feed in. It helps stimulate our research as well. So thank you.
Thank you, everyone. It was a pleasure. Bye-bye.
Bye.
Hello again. My name is Naomi Huz, and I'm a medical oncologist at the Abramson Cancer Center in Philadelphia. And we are heading into our last session with the Judy Nicholson Kidney Cancer Foundation. We have some exciting talks. The first is Glenn Sykes speaking about clinical trial considerations. Next, Taryn Ferenchek, who is a nurse practitioner, will be discussing management of side effects to kidney cancer therapy, followed by Roberto Pile, who will be discussing nutrition in cancer, and finally Hans Hammer with a visionary talk about the future of treatment for kidney cancer. And I believe that the sessions are going to end a little bit sooner than we had forecast on the agenda as far as the question and answer period. So you may want to adjust your schedules accordingly. Thank you very much.
Hey, good afternoon, everyone. I'm Glenn Sykes. I am a person living with kidney cancer since December 2010, and I've been metastatic since June 2015. It's great to be here with you this afternoon. I'm going to share some slides, provide a little bit more information about myself, and get to our topic. I hope you've been enjoying the conference so far. I'm filming this on a rather dreary day in the Mid-Atlantic. I hope by now the sun has come out and shining on your faces, and I hope your head is full of all the great knowledge that you're hearing at today's conference. Thank you to the Judy Nicholson Kidney Cancer Foundation for sponsoring today's conference and inviting me to speak. I have not presented on this topic very often, so I'm certainly open to the feedback during the presentation or through the Judy Nicholson Kidney Cancer Foundation afterwards. Here's a little bit about me, and I'm a Philadelphian. I currently reside here, but I've also lived in other places around the world, some of the world's greatest cities. Professionally, I've spent my career in the business world until retiring about 4 years ago. First on the business side of things, and for the last 23 years, my career I spent in business education. My last position was the Dean of Students at the MBA program at the University of Chicago. My partner, Dirk, who flies for American, and I met, in fact, 33 years ago at Northwestern University outside of Chicago. If it isn't obvious from all that, unlike most of the speakers that you will hear from today, I have no medical training. My perspective today is drawn from nearly 13 years as a kidney cancer patient, including 8 years with metastatic disease, and for my last 4 years volunteering to work with doctors and other researchers on designing clinical trials. I do this through my membership on the Genitourinary Committee of the ECOG Akron Cancer Research Group, which designs and conducts cancer research involving adults who have or are at risk of developing cancers. Finally, from the start of my diagnosis, I've been a believer in the value of patient education, and I'm active in organizations that help me with that goal. There are social communities like Smart Patients. By social, I don't mean that we're talking about topics about parties and what movies we saw, but actually just kind of patient-to-patient education centered organization, like a Judy Nicholson or Kidney Cancer that sponsors education seminars for patients like this. While I learn a lot from my doctors, I learn substantial amounts from other patients, and I know some of them are in our virtual room today. Here are some key parts about my cancer journey, which started in December 2010 when I was 51 years old with a diagnosis of stage 3 cancer renal cell carcinoma. Like many of the patients here today, I can still vividly recall hearing the words, "You have cancer." My left kidney was removed a few days before Christmas at Thomas Jefferson University Hospital in Philadelphia. And then in June 2015, I heard the words that no one wants to hear. "Your cancer has returned," when a scan showed that my disease had spread to my lungs, where it remains today. Certainly not from lack of trying to get rid of it. And since becoming metastatic, I've had both systemic treatment, drug treatments, as well as targeted local treatments, which I've listed up here. I've had periods of stable disease, but also periods of progression when I heard the words, another set of words that no one wants to hear, which is your cancer has spread again. My own experience with trials looks like this, all considered at different inflection points in my treatment. In 2011, I considered and ruled out participating in a full phase 3 adjuvant trial that turned out to be a negative trial, meaning it showed no benefit. It wasn't, in fact, till 2021, based on a different trial, that the drug was shown to have adjuvant benefit for patients. And adjuvant just means reduces the chance of a cancer returning. And I did that right after my nephrectomy. And then fast forward to 2017, I joined a phase 3 immuno-oncology clinical trial in Chicago that started in July 2017. And the treatment arm wrapped up in July 2019. I'm still a participant in that study, and I'm tracked mostly by periodically responding to surveys. I also looked at a non-treatment study and participated in 2022 about time toxicity. And time toxicity is the term used to refer to the time that all the patients and caregivers spend in waiting rooms, waiting to see doctors, waiting to get into infusion chairs, waiting to get labs. We know all those waits that happen. And this was a treatment study designed to see if that could be sped up. And in 2023, I considered and ruled out, at least for now, a small phase 2 radioimmunotherapy trial being run in New York City. So this talk, to give you my advice, as well as give you guidance to help you evaluate a trial. I don't have a vested interest in any specific trial, but I do stand behind the value of trials to patients. In terms of preparation, I draw on the experiences I just went over with you. I spoke to lots of patients. I spoke to my oncologist to make sure that it had her stamp of approval. And I read the literature on the topic. Let's start with what is a clinical trial. On the right, I put the National Cancer Center Institute definition. I'll give you a moment to look at that. Now, I know from my own experiences, if you mention to friends or the family that you are considering a trial, their faces sort of go white often, and they fear for you. And they think that you're going to get treated like a lab mouse with very risky things being done to you. That's simply not the case. Trials serve a very important role in any treatment. Most likely anyone in the audience in treatment has benefited from a trial and any of the treatments that really changed the practice of treating kidney cancer. And there have been several in the last few years, certainly since I've been diagnosed. And like you've probably been hearing from the other presenters today, have come from trials. So you might be surprised to learn that in spite of their importance, awareness, and consequently participation remains low. It's about 10%. Today's presentation isn't going to take a deep dive to looking at the whys to that low number, but there are many answers to that question. But clearly, not understanding trials, having a care team or community that doesn't speak to you about those options, and a heritage of early trials doing harm unknowingly to patients and therefore unwillingly to patients all contribute to that answer. While there have been a small number of trials that have a small number of patients in them, most trials require hundreds of patients, researchers, specialists in fields like statistics, protocol or the plan development, and patient education to achieve their objectives. To make them work, they need sponsors. Some organizations that sponsor research include the National Cancer Institute, NCI, the Department of Defense. They get involved because it turns out that an above average number of veterans are diagnosed with kidney cancer, and of course the drug makers themselves. Once you get into the world of trials, you'll often hear people talk about phases, and there are 4 phases of trials. Each phase is designed to answer a specific question, which I've listed up here on the right. I'll give you a moment to read those. My focus today is on phase 3 trials. Remember, some trials also look at behaviors, not treatment, like my time toxicity trial, but I'm going to focus today on phase 3 treatment trials. Most phase 3 trials compare a treatment to something new. So the standard of care treatment, what's the current practice, to something new to see if it works better. Of course, that's a really important question when you think about cancer treatment. Does something new that's been developed work better than what something is old? And that represents all the progress that we've made. So this slide and the next one attempts to answer the question, what makes a trial a good one for you? And I emphasize for you. I'm assuming that you're going to be looking at NCI approved trials. So I'm not talking about things that might fall better under the category of quackery. If you're giving a trial, then use these points to evaluate it. First and foremost, a trial must offer substantive benefits to you. Most likely it's going to offer some benefits to your trial, to your doctor, to the sponsors, the researchers, simply by having the trial. But it really must benefit you. They don't matter to you in some sense. It's thought that patients that consider trials sometimes have unrealistic expectations for trials. For example, a quick path to a cure. While it's generally good to be optimistic, I'm a believer in that. Take time to work with your doctor to filter those expectations. So share your expectations through reality. For example, statistical information can be helpful in bringing reality to the table. And your doctor ought to be able to help you with that. And speaking of your doctor, I hope all of you practice shared decision-making with your doctor, candid discussions of what is being talked about, pluses, minuses. No thing is all right. No thing is all wrong. Unless it's what you want, your doctor should not be dictating what's done to you. You should be dictating that. One of the key things a doctor will help you understand is also how they will help you stay in the trial when you experience side effects. And they also will help you look beyond the trial. What if the trial doesn't help you? What would be the next steps? And have those discussions as part of your consideration of the trial. And a doctor who's recommending a trial to you must be able to explain in very easy to understand terms, what's the excitement about the trial? Is it a potential cure? Is it going to slow disease growth? Is it going to offer patients a better quality of life? And this last point is related to the previous two. Phase 3 trials include an arm of patients receiving the current non-standard care or treatment. So make sure your doctor can explain to you why they think that may benefit you. Not some lofty goal about understanding this at a very high level, what this will do to the treatment world for kidney cancer patients, but why it will benefit for you. And you should see the theme is keep coming down to thinking about this in very personal terms. Trials are scientific exercises, no doubt about it, in which you are asked to participate. They can be talked about and explained in very dense science-laden documents. I've seen those. Your job is really to break through all that and understand it for yourself. Understand what's going to happen to you and understand what's being asked of you. Fortunately, you do have some help with this, some patient-related documents. The key document will be asked to read and acknowledge with your signature is something called the informed consent. And that document, to which a lot of individuals have input, including people like myself, is supposed to be read. They're supposed to be written to an 8th grade reading level. I don't know what kind of 8th graders you've seen, but I have some questions about that. So if you need help reading it, ask your doctor. That's okay. You may have well beyond an 8th grade education. That doesn't mean it's going to be completely clear to you. Take the time to read it again if you need to, and again and again. I always read my consent several times. Don't ever feel rushed by that process. No one should hand it to you and ask you to sign right there at all. have someone else read it, a caregiver, a friend, another doctor, and think about the questions that pop up for them as well. And by the way, even though it sounds very formal when you sign the consent, every time you show up for treatment, you are consenting to participate in the trial. You can withdraw that consent at any time, and information will no longer be collected. I think a better path, if treatment isn't going well, is just to stop treatment. And you can request stopping treatment. This allows the study to continue to keep information about you, and you might be asked to participate in things like surveys. But that allows you to seek out other treatments, but continue to be a trial participant just without treatment. And let's talk about timing when you're presented with a trial. If you've just received your diagnosis and the trauma of that, the very real trauma of that is fresh, let me suggest that's not the right time. There's a strong likelihood that timing will negatively impact your ability to understand. I can certainly speak from personal experience on that one. I mentioned that I looked at an adjuvant trial in 2011. That happened in January 2011. I was in my urological surgeon's office getting the pathology report that it was confirmed I had renal cell carcinoma. And I think he thought he was doing me a favor. I think it was terrible. He marched me over to the oncologist's office, and the oncologist immediately began to talk to me about an adjuvant trial. And all I could hear were the reading of the pathology report in my ears. So, and was quite traumatized by that. So, hope that never happens to any of you in your care team. And I since changed care teams. Most trials ask a lot of you. Of course, so does treatment and cancer. But trials may require you to travel somewhere for a treatment, different than your regular place of care. It will take time. It'll involve money. You may have work obligations or child or elder care responsibilities, which will have to be addressed. Trials can require extra things from you over the standard of care, extra lab tests, extra scans, extra biopsies. I understand who will pay for them, and if you're in a position to handle the extra time and any out-of-pocket costs. There's a concept in the treatment world. I mentioned time toxicity earlier. There's also a concept called financial toxicity, which means the toxic impact on personal finances for cancer care. And they are substantial. You probably have seen headlines about that. It's also presented in the trial world. It doesn't necessarily mean that everything in a trial will be covered by the trial. Often in a phase 3 trial, the drugs are covered by the sponsor, and there may be some extra biopsies, but there are other things that will be coming out of your pocket or your insurance company's pocket. So we all have limits on our resources, time and money. Make sure that a trial that you're being asked to participate in will not exceed the resources you have or want to give to the trial. I, again, going to give one personal experience. I mentioned that I just considered a trial earlier this year. It was a phase 2 trial in New York City, and it required a lot of visits to New York City. And the consent, in my mind, was not written very clearly for me to understand that. It was certainly written for someone, I think, who was in New York City, who could easily get there. I don't. So it was important for me to understand the trial timeline. They had something called a patient study calendar, which to me was not particularly useful. So I just want to understand it step by step. When would I come? When would I have to come back? When would I come? And map it out in the calendar. And I did work with the study team to figure that out. But that for me was a really important thing, and ultimately was the reason I chose not to participate in the study. It just required too many trips to New York. Are there any poker players out there or gamblers? You probably understand the term table stakes. What has to be just put in just to be in the game? I think that previous slides laid out, the table stakes a trial must meet to even be worthy of your consideration. The principal one being that it has to benefit you. Now, if a trial you've looked at seems worthwhile, this next slide looks at the other benefits to participating. Of course, none of them matter if the trial doesn't meet the table stakes, so it does benefit you. And I'll give you a moment to look over these. Trials often give you access to treatments that you might not have access to except through the trial, particularly in those phase 3 trials when they're looking at a drug that isn't the standard of care. The only way to get access to that may be through a trial. Drugs, as I mentioned, given to a trial are paid for by someone else. These drugs are expensive. For example, each infusion of my immunotherapy drug I get every month carries a charge of $46,000. Fortunately, most of which is covered by my insurance. Something that came as a surprise to me when I participated in the trial was the attention that I received from the study team, and particularly the study nurse. Trials will have study nurses attached to those. Mine was there to welcome me when I came in for my appointment. She tracked my progress throughout the day, and it seemed like I was, waiting too long for something, attempted to intervene. She made my next appointments for me. As a study participant, the team will be really interested to you and probably at a higher level than what you may be used to as a 9 trial participant. Many patients talk about that as really a big benefit that wasn't particularly expected. A trial can give you another option. Often other people will think of a trial when they have exhausted as all other options, like the last ditch thing to try, but really they should be considered at every inflection point, even first treatments in some cases. So if you're having to make a decision and thinking about things that are not through a trial, think about, is there a trial that also would be applicable for you to consider? And it's not uncommon for altruism be thought of as a reason to participate in a trial. Doing for the good of society. And trials do move cancer treatment forward and may represent something good for future patient communities. So there's certainly an altruistic element to participation, and it does show up when you ask the patients why they participated. But what also shows up is no amount of altruism can really make up for a trial that doesn't help you. Most patients participate in the trial, and I advocate this is the best reason, because they feel like it's going to help them, particularly if you have active disease. Now, in the last minutes that we have, I went ahead and anticipated some questions that you have. I wanted to prime the pump a little bit and see what questions you have later on in the panel. So I'm hoping what I've said today to get you interested in looking at trials. An obvious question is to where do you find a trial? The National Cancer Institute has a database. It's generally thought of as cumbersome to use. So I listed some other ways to find a trial. You should always talk to your doctors or doctor and other patients. You can do that through some of the patient organizations, charitable organizations, social media. All those are great ways to find out about trials. I looked at the clinicaltrials.gov database to see how many kidney cancer trials to give you a sense of the magnitude. It's 2,000. That's great news. On the other hand, that means it's really hard to sort through. From the questions that I got from family and friends when I told them I was considering a trial, I know a common misconception is that there's some probability that I'll be given a placebo, a fake drug, and they looked alarmingly to me and thought, you're just going to be given a fake drug or there's a chance. In fact, being given a placebo is quite rare unless there is no existing treatment. If you do get a placebo, often it's usually combined with something that's active treatment. So I wanted to eliminate that misconception. Another common question you might have is, do I get compensated for participating in trial? You're, of course, doing something good for science and pharma companies, so should you get compensated? Sadly, the answer is generally no. Though if underlying your interest in compensation is to help you with the cost of participating in the trial and you couldn't participate otherwise, tell your study team. They're going to be interested in knowing what issues are keeping you from participating. There may be some travel stipends, for example, And there may be other ways to help you mitigate some costs, perhaps doing some lab tests at a facility that's closer to you. There also is an organization called Lazarix. There may be others as well that can help you with the cost of participating. Finally, a common question is if insurance covered the cost of treatments in a trial. If you receive the standard of care treatment, then insurance will generally cover that, or anything that would incur in the cost of being treated, regardless of your participation of participating in a trial. And that's the way to think about it. If I would have these costs, even if I did participate in this trial, then it would go through the same payment mechanisms that you would normally do. New treatments are generally covered by the trial. For example, things done in the name of research, drugs, lab tests, scans. There are costs like travel, housing, child elder care that you incur to participate. And there, as I said, there could be stipends, but don't be surprised if there isn't. Your consent should spell that out clearly. And if you don't understand that, talk to your doctor. Certainly don't sign up for something that you don't understand what the cost is to you. I mentioned here's some other resources. I mentioned that I'm active in patient communities, patient-to-patient communities. I call them social. Smartpatients.com is a leading one that I have participated in for the entire time of my disease, and it's been extremely helpful to be connected to other patients that may have gone down the path ahead of me. There are some experts in there in many fields, and it's good to reach out to them always. There's education research advocacy organizations. I throw Judy Nicholson in there, Kidney Cancer Association, Kidney Can, all of those sponsor patient education conferences like this one, which are really good and advocate for people with kidney cancer. The International Kidney Cancer Coalition is actually an association of associations. They have a lot of great information on their website. I encourage you to look at that. And as I mentioned, Lazarix Foundation is a way to figure out the cost that are involved, help you with the cost involved in participating in the trial. Also, I came up with cancer.gov /trial costs is another resource for helping with that issue. Thanks for listening. That picture, by the way, is a charity event, charity swim event that I've participated in for the last few years that raises money for cancer research. This happened to be in Chicago. It's a fun event, Swim Across America. If any of you swimmers out there, I encourage you to look into it. Here's my email address. If I can be of help to you, feel free to reach out. Thank you very much for your attention. There will be a question and answer session later on this afternoon that I hope I am able to interact with more of you. I look forward to hearing more from you, and I look forward to hearing more from our speakers. Thanks again for your attention. Bye-bye.
Hi, my name is Taryn Ferenchuk. I'm a nurse practitioner at the University of Penn, and I specialize in kidney cancer. Today, I'm going to be talking about managing side effects of cancer and its treatment. So types of treatment I'm going to be talking about are immunotherapy and targeted therapy. And I just want to go over briefly how immunotherapy works, because that can help you understand where the side effects are coming from. So as part of its normal function, your immune system detects and destroys abnormal cells, which helps fight against infections, cancer, and other diseases. Immune checkpoint proteins are a normal part of the immune system. They prevent an immune response so strong that it destroys healthy cells. Checkpoint proteins, along with other proteins, manage the flow of signals to T cells, telling the cells when to turn off and on. So in general, T cells are turned off so that they're not damaging our healthy cells. Checkpoint inhibitors are immunotherapy drugs that work by altering the connection between the checkpoint proteins and other proteins, which turns on the T cells so they can recognize and kill cancer cells. So essentially, immune checkpoint drugs take the brakes off the immune system, which helps it recognize and attack cancer cells, but it can also then attack our healthy cells, which is where we get the side effects from. The types of immunotherapy for kidney cancer, we have nivolumab or Opdivo, ipilimumab or Yervoy, and then pembrolizumab or Keytruda. So I like this picture here. It sort of highlights each body system and the side effects that you can get from immunotherapy. I'm not going to go through all of them. I'm just going to highlight a couple that we see pretty commonly. So uveitis or inflammation of your uvea, hyper or hypothyroidism, which is abnormal thyroid function, adrenal insufficiency, pneumonitis or inflammation of your lungs, colitis, inflammation of your colon, hepatitis is inflammation of your liver, nephritis, abnormal kidney functions, inflammation of your kidney, and then dermatitis is skin itching or rash, arthritis is joint pain, and then fatigue. When we manage side effects from immunotherapy in general, if we can't manage them conservatively, then we do need to treat with high-dose steroids. There's a couple that don't necessarily get treated with high-dose steroids, so I wanted to just highlight those. So adrenal insufficiency, so when your adrenal glands are working properly, they secrete cortisol, which is a steroid, and we need steroids to live. So with adrenal insufficiency, for lack of a better word, the immunotherapy drugs burn out your adrenal glands, so they're no longer producing cortisol. So in this situation, you're going to need lifelong steroid replacement with hydrocortisone, and you're going to need to see an endocrinologist. Uveitis is inflammation of your uvea, so you might have red or bloodshot eyes. We're going to send you to the ophthalmologist, and they're going to prescribe some steroid eye drops. Hyperthyroidism is an overactive thyroid, and that's treated with anti-thyroid drugs or beta blockers, and we're going to have you see an endocrinologist for this as well. Hypothyroid or underactive thyroid, that's treated with thyroid replacement or levothyroxine or Synthroid. This is something we can generally manage, but if it's pretty severe, then we will have you see an endocrinologist. So dermatitis or skin itching or rash, if it's a localized rash, then we can treat it with a topical steroid cream, clobetasol or triamcinolone. Sometimes you can get a pretty severe body-wide rash, blistering rash called bullous pemphigoid. If we see that, we'll send you to dermatology. They usually do a biopsy of your rash, and if it comes back as bullous pemphigoid, then they will initiate on high-dose oral steroids. So pneumonitis, inflammation of your lung, this usually presents with the shortness of breath or a new dry cough. We'll get a CAT scan of your chest to take a look because we can see pneumonitis on CAT scans. And then depending on how severe it is, if you're symptomatic, then we may need to start oral steroids. Colitis or inflammation of your colon, basically diarrhea. Patients say they have 8 to 10 plus loose stools a day. A lot of times it's refractory to antidiarrheal medications, and in this case, depending on how severe it is, in general, we will treat you with high-dose oral steroids. So targeted therapy. Targeted therapy works by blocking the growth of new blood vessels that feed the cancer. It also works by blocking important proteins, tyrosine kinase, mTOR, or HIF2 alpha that help the cancer cells grow and survive. So basically the goal of targeted therapy is to starve the cancer cells. So these are some of the targeted therapy drugs: axitinib or Inlyta, cabozantinib or Cabometyx, everolimus or Afinitor, lenvatinib or Lenvima, cabozantinib or Votrient, sunitinib or Sutent, and then tivozanib or Faticta. So these are some side effects of the targeted therapy. It's not an exhaustive list, but I wanted to highlight some of the things we see pretty commonly. So abnormal liver and kidney function, altered taste, anemia, arthritis, diarrhea, fatigue, hypertension or high blood pressure, hypothyroidism, mouth sores, nausea, and then hand-foot syndrome. So abnormal liver and kidney function, when you're starting out on these therapies, we're going to check baseline labs just to make sure everything's within normal limits. And then we want you to notify your healthcare team if you're having nausea or a poor appetite. Generally, we'll have you go and get a set of blood work, see if there's any abnormalities in your liver or kidney function. And then we'll probably need to hold the drug depending on how elevated your numbers are. And then again, depending on how elevated your numbers are, we may need to start oral steroids. Altered taste, mouth sores, or dry mouth, I grouped these together. These can be pretty severe and pretty bothersome for patients. A lot of times they'll tell me things taste like cardboard or things don't taste good. They may have salt or acid sensitivities. So a lot of times we recommend, changing to a natural toothpaste such as Tom's, Biotine and Oral-B both make a lot of products for dry mouth. They have mouthwashes, they have toothpaste, they have lozenges. A patient just told me about these Xylomelts lozenges for dry mouth you can get on Amazon. I've heard they work very well. You definitely want to make sure you're staying hydrated. And then if these things aren't helping, what we can do is prescribe Magic Mouthwash, which is liquid lidocaine, liquid Benadryl, and Maalox, and that can sort of help numb your mouth. And then lastly, we can prescribe a steroid mouthwash, which can help with the mouth sores. Arthritis or joint pain, we tell patients to try Voltaren gel, which is over the counter. They can take Tylenol. And then sometimes we recommend small doses of NSAIDs, which is Motrin or ibuprofen or Aleve. We just have to be careful. A lot of our patients only have one kidney or they have, altered kidney function. So NSAIDs can be pretty toxic to the kidney. So we just be mindful of that. And then if the joint pain is pretty severe, sometimes we will do oral steroids. Diarrhea, so you can try Imodium, which is over the counter. You take 2 pills after the first loose stool and then 1 thereafter. Lomotil is a prescription anti-diarrheal, so if Imodium's not helping, we can prescribe Lomotil. I also tell patients to make sure they're getting enough fiber in their diet to help bulk up their stool, so they can use Benefiber or Metamucil. And depending on the severity of the diarrhea, they may need to hold the drug. And then we also just want to make sure you're staying hydrated because diarrhea can be pretty dehydrating. Hypertension or high blood pressure, because these oral targeted therapies target the blood vessels, this can cause high blood pressure. So when we're starting patients out on these drugs, we want to see what their baseline blood pressure is. Sometimes patients are already coming to us with high blood pressure. They're already on blood pressure medication. If that's the case, we want to get in touch with either their primary care or their cardiologist and just let them know we're starting them on this drug and they may need some alterations in their antihypertensive or blood pressure regimen. So we ask patients to purchase a home blood pressure cuff and monitor their blood pressure daily. Sometimes the drug companies will send a blood pressure cuff to you, which is really nice. And then we want them to notify us if their blood pressure is elevated. And then the treatment for this is antihypertensives or blood pressure medicine. And I'll use this as my plug for primary care. It's so important for you guys to all have a primary care doctor because they can help us manage things like high blood pressure. Sometimes we'll send you to cardiology. And we're lucky at Penn, we have a cardio oncology team that actually specializes in managing hypertension for patients who are on these oral targeted therapies. Nausea, so I recommend eating small, frequent meals. I know there's been some controversy on the brat diet recently. I put this in here mainly just to highlight that you should try eating bland foods, so rice, toast, crackers, things like that. Ginger or peppermint tea or candies can help with nausea. We can also prescribe ondansetron or Zofran or perchlorazine or compazine. Those are both anti-nausea medications. And then sometimes I tell patients to consider taking their therapy at nighttime. So if they tell me, I take my pill in the morning and then I'm immediately nauseous, sometimes I say, why don't you try taking it at night and see if you can sleep through the nausea. And then hand-foot syndrome. So this is peeling or blistering on your hands or feet, as you can see in the pictures there. And then a lot of times you'll get like a blister or a callus on the ball of your foot. This can be very painful. Patients tell me that, they have a hard time walking because it's so painful. So we recommend emollient-based moisturizer, so Utterly Smooth, Eucerin or CeraVe. You want to wear thick socks, loose-fitting shoes. You want to avoid putting your hands and feet in really hot water. We can prescribe clobetasol or triamcinolone steroid creams can help. And then sometimes we'll prescribe a lidocaine-based cream that can really help with the pain. And sometimes we refer to podiatry or the foot doctor. Sometimes our patients refer themselves to podiatry. They can actually take off the calluses on the feet, and patients tell me that that provides a lot of pain relief. So fatigue. So fatigue is probably the biggest side effect we see. This is both from the treatments and from your cancer. And patients always say, you know, can you give me something? I'm so tired. Can you just give me a pill to make me feel not tired anymore? And unfortunately, we really don't have a magic pill that we can give to make you not feel tired anymore. Recommend getting adequate rest, you know, limiting your blue light time before bed, TV, phones, iPads. If you need to take a nap in the afternoon, do so. Definitely make sure you're staying hydrated. And then exercise. I know it sounds counterintuitive, but exercise can really help with fatigue. And, you know, I ask my patients, do you live somewhere where you can go outside, walk around your block or two, or walk around in your backyard? We're not expecting you to run a marathon. You know, walking is such great exercise. So any kind of activity you can get in. And for patients who are very debilitated, sometimes we'll get them a physical therapy consult just to help them get going. So I want to take a minute just to talk about this newer drug because it has a side effect that the other drugs don't have. So belzutifan or Welireg is the drug, and it's newly approved in patients with von Hippel-Lindau or VHL disease, but it's also approved for kidney cancer in certain situations. And so it works by blocking the hypoxia-inducible factor alpha-2, which is involved in cancer cell growth and the formation of new blood vessels in tumors. And so one of the side effects we see with this one, hypoxia or low oxygen levels, we don't see with the other drugs, and that's because this targets the hypoxia-inducible factor. And then we can see pretty profound anemia or low hemoglobin or red blood cell with this drug as well. Now, you can get anemia with the other therapies, but we tend to see it more with this one. So hypoxia, so like I said, it's a low oxygen level. So we ask patients to purchase a home pulse oximeter, which measures your blood oxygen. You can get these on Amazon or you can get them at the drugstore. A normal oxygen level is 93 to 100%. And then we want you to notify your healthcare team if your oxygen level is decreasing or if you have new or worsening shortness of breath. We're likely going to have to hold the drug and you might need a dose reduction. And then if it's severe enough, you might need supplemental oxygen. And if at that point, you're unfortunately probably in the emergency room. Anemia or low hemoglobin or low red blood cells. So in the beginning, we're going to be monitoring your blood counts pretty frequently. We want you to notify your healthcare team if you're having new or worsening fatigue or shortness of breath. Depending on your hemoglobin, you might need a blood transfusion. We're also going to check your iron levels, and we'll repeat your iron if necessary. And then again, depending on what your numbers are, we may need to hold the drug or consider a dose reduction. So you may be thinking to yourself, a lot of these side effects overlap with the immunotherapy and the targeted therapy. I'm on both therapies, so how do I know what's causing what? So here are the combination therapies that are approved right now. There's cabozantinib and nivolumab. There's axitinib and pembrolizumab, lenvatinib and pembrolizumab, ipilimumab and nivolumab, which is going to be dual immunotherapy, and then lenvatinib and everolimus, which is dual targeted therapy. So in general, if the side effect occurs shortly after starting treatment, it's most likely from the oral targeted therapy because it can take some time for us to see some side effects pop up from the immunotherapy. If we're not sure when, which is causing which, sometimes we'll have you hold the oral therapy, and if the side effect resolves, so if you say, hey, I'm having diarrhea, we'll say, okay, why don't you hold your oral therapy? If the diarrhea gets better or resolves, then we know it's from the oral therapy. And sometimes, we're really not sure. We have to hold both therapies. Sometimes, when it's affecting your liver enzymes or your kidney function, we're not quite sure what's causing what. We might have to hold both therapies until we can kind of tease it out and have your numbers get back to normal. So key takeaway, and I should have said this in the beginning, anytime you're having a side effect or a new symptom, notify your healthcare team. We want to know. They're not bothering us. It's important that we know, as soon as it starts, because sometimes there's things, we can do to help you with this. And also, sometimes we do have to hold your therapy to, get the side effect to resolve or get it to reduce. Patients get very upset when we say, hold your drug for a couple of days, but it's really, benefit. We don't want you to suffer, through your treatment. Although we do want to treat the cancer, it's kind of a risk benefit balance. And so these are my references, and thank you for listening to my talk.
Hi, I'm Roberto Pili. I'm a medical oncologist at the University of Buffalo, and I've been treating patients with kidney cancer for many, many years, but we also try to understand the biology of this disease and try to come up with new strategies. And more recently, we'll be very interested in studying how the diet actually can impact kidney cancer. Good afternoon. It's a pleasure to be part of this meeting this afternoon. And I want to thank Linda and the Judy Nicholson Kidney Cancer Foundation for inviting me. It's been a privilege to be working with you throughout these years, study with Nick. And I want to thank you for all what you do for our patients with kidney cancer. So today I'm going to talk to you about nutrition and kidney cancer. And what I would like to do is really to tell you how diet can actually have an impact on patients with kidney cancer. And I want to introduce you a project that we have here at the University of Buffalo. It's called a SNAC, Sciences, Nutrition, and Cancer, to help a patient with cancer and how the diet can help them. So let me start with just a definition. What we mean for nutrition? Nutrition is really a nourishment of energy that is obtained from food consumed or the process of consuming the proper amount of nourishment and energy. An example of nutrition is indeed eating a healthy diet. And what we define metabolism. You heard about this word. Metabolism is really the change of food and energy that happen in our body. As you know, we intake our food. Those are the components of the food are proteins, complex carbohydrates, triglycerides, and we break it down into amino acid, glucose, glycerol, and fatty acid. And these are the components eventually that get funneled and they produce energy. And the gasoline that we have in our body is called ATP. So why focus on diet and cancer? Now, cancer is impacted by diet and lifestyle. There are many data suggesting that many solid tumors, this is the case of prostate cancer, can be impacted by diet. For example, a population that have high consumption of vegetables and legumes may have less incidence of prostate cancer. This has been shown also for colon cancer, breast cancer, and other disease, and less aggressive cancer. Vice versa, population that have a high consumption of animal proteins may have high incidence of prostate cancer, of cancer in general, and more aggressive type of cancer. I only show this data because it really is a telling how shift from Eastern to Western diet may actually result in increased cancer incidence. This is a cancer incidence of breast cancer, prostate cancer in Japanese population. As you know, in women and men in Japan, there is low incidence of breast cancer, prostate cancer as compared to Caucasian population. Now, when they look at the first generation migrants into Hawaii, and the first and second generation, they saw that the incidence of breast cancer, prostate cancer actually went up. So the genetic of this population did not change, but the environment changed. And of course, the diet may be the culprit for this increase of insulin. As we know, in the YH, there is high consumption of animal proteins, for example. Now, the American Cancer Society has a guidelines on nutrition for cancer prevention. This is a common sense suggestion, for example, achieve and maintain a healthy weight throughout life, adopt a physical, active lifestyle, consume a healthy diet, particularly plant-based diet, and if you drink alcohol, a limited consumption. And I would agree with the CDC that the less alcohol you drink, the lower your risk for cancer might be. If you look at the web, there are several web sites that can be helpful for patients who have history of kidney cancer or been dealing with kidney cancer. I like the World Cancer Research Fund, the American Institute for Cancer Research, a UK-based, where they have a very nice brochure, for example, on nutrition, physical activity for patients with kidney cancer. The Canadian Cancer Society has a very nice webpage on the supportive care for kidney cancer. These are recommendations to preserve, for example, the remaining kidney after nephrectomy, try to use less protein, lower the amount of salt, limit the amount of phosphorus, and limit the amount of alcohol a patient may drink. Now, the only two risk factors recognized for kidney cancer, as you probably know, are obesity, hypertension. Now, there has been a lot of interest in how inflammation can be associated also with kidney cancer and perhaps with obesity. These are, for example, two studies done in Italy and the United States associating the dietary inflammatory index with the risk of kidney cancer. And these are the studies, for example, again, done in the United States or in Denmark, suggesting that indeed body size can associate, especially even in young kids, young adults, with eventually the risk to develop kidney cancer. So what is inflammation? Inflammation, in simple terms, is a disorganized immune response. And why this is harmful? It's harmful because it tends to suppress the good immune response against germs and tumors by inducing immunotolerance. And so a mechanism through which cancer cells are no longer recognized as a foreigner by the immune system. So what is anti-inflammatory eating is really avoiding processed food, excess meat, especially red meat, saturated fat, and eat more plant-based food. That is Cortisol Beth Kirsch, a very talented registered dietitian when I was in Indiana University. So why plant-based eating? Because plant-based food that does contain vitamins, minerals, fibers. There is a lot of recent data how fibers actually can be helpful to have a healthy immune system. They are high in phytochemicals. And that these are recommendations, eating more vegetables, fruit, 1.5 cups of fruits and 2 or 3 cups of vegetable daily. This is the recommendation for cancer prevention. And this is the classical Mediterranean diet pyramids, where on top you have the less often food that you should have, and in the bottom what you should actually eat. Again, a lot of fruits and vegetables, and be physically active, be socially active. Those are very important. So my take-home message for this first part, I would say to reduce inflammation, especially during immunotherapy, I would recommend the following. Probably avoid the dairy products if possible, red meat, increase plant-based protein and fibers, increase cruciferous vegetables like broccoli, cauliflower, eat more fish, and supplement perhaps with vitamin D and vitamin C. And definitely I would integrate dietary changes with regular physical activity. I'm going to mention to you about physical activity and its potential impact at the end of my talk. Now, there's been a lot of evidence just suggesting that dietary intervention may impact important pathway that make cancer cells establish and survive. This is a elegant work published many years ago by Luigi Fontana, a friend and collaborator, is well-renowned nutritionist that has pioneered, for example, the impact of reduced protein intake as a way actually to slow down the aging process. 10 years ago, we actually, Luigi and I got together and test hypothesis when a protein restriction, reducing the amount of protein actually could have an impact on cancer. In this case, we work on prostate cancer and breast cancer. But this was, to me, was an eye-opening experience because, as you saw here, as you see here, these are the tumor we implanted in mice, and we measure the size. And in mice randomized to have a lower amount of protein, 7%, as compared to 21% is the regular side percent of protein in the diet in mice, but also in humans. You can see here the reduction of protein has a dramatic impact on tumor growth. And this, again, was a very fascinating observation because it was like a giving chemotherapy or monotherapy to these mice, but that's the only intervention was the diet. And more importantly, also the source of the protein. Here we show that if we keep the amount of protein at 20%, but we give the source just from soy, for example, plant protein, versus casein is the main protein in the milk as an animal protein. You can see the difference between these two groups, suggesting that animal protein actually was accelerating the growth of this cancer as compared to plant-based protein. We repeat the same experiment actually in the kidney cancer model, and we're seeing, this is unpublished data, see that soy protein, corn protein actually behave even better than soy as compared to casein, suggesting again that the source of protein may be important to slow down the production of cancer, the progression of cancer in this case, in the kidney cancer model. Throughout the years, we've been studying the impact of low protein diet as a way to actually to increase the impact of immunotherapy, and we discovered that a specific subset of immune cells called macrophage, in particular called M1 macrophage, that can actually kill cancer cells, that actually increase if we decrease the amount of protein in the diet. And indeed, we were very excited when we did these animal models for kidney cancer, and we showed that is a survival curve. In purple, you see that animal randomized to a lower protein diet in combination with the PD-1 inhibitors like nivolumab and pembrolizumab, the same type of drug, these mice actually live longer because they have a smaller tumor. That to us was very exciting. That can be eventually, tell us that can be eventually translated in the clinic. Now we talked about micronutrients as the building block actually to generate energy is called ATP. And again, to summarize, protein, carbohydrates, and fats are breaking down into amino acid and glucose and fatty acid. And the normal progression of this, and we call it catabolism of this, are through an organelle called a mitochondria. And that's really is the main source of energy that is done through oxygen and led to the production of ATP. That is the gasoline for our cells. Now, in cancer cells, this production of energy is in kind of altered, and that's what we call a Warburg effect. Again, on the left panel, you see that normal cells use glucose or other components like amino acid and fat to generate energy through the mitochondria, less through lactate, the production of lactate. Cancer cells tend to shift, not to use the mitochondria in general, but to use a lactate as one of the main source of energy. It's a very inefficient way actually to produce energy. Now, kidney cancer is being considered a metabolic disease. This is a very elegant work by Keith Bradmill and Marcel Linehan throughout the years. Again, these accompany the slides, but that tells you how the some specific alteration that we see, in particular in clear cell carcinoma, can actually push kidney cancer cells more to the production of lactate. But also there are some cancer cells that utilize amino acid, in this case glutamine, as a source also of energy, not just glucose, but also amino acid. Again, it's very complex process. But because glutamine has been recognized as a potential source of energy for kidney cancer, that was actually been identified as a potential kills. And throughout the years, actually, there's been some strategy to target the utilization of this amino acid by kidney cancer cells. Unfortunately, we did have these clinical trials led by Nizar Tanier that was negative. When they use a glutaminase inhibitors to try to starve these cells from glutamine in combination with cabozantinib, it was not much better than just cabozantinib alone. Just to tell you how challenging it is to target perhaps some specific amino acid, for example, some specific metabolic pathway in kidney cancer or in cancer in general. Now, in our lab, Sabrina Horse's PhD student is also try to understand how the metabolism may differ among different type of kidney cancer. As you know, kidney cancer are many type of cancer within the same tumor. We have a clear cells, papillary chromophore, translocation. We're particularly interested in translocation kidney cancer. And again, I'm not going to go over this data, it's unpublished data, but Sabrina is using technologies called a seahorse, and shown here, and she can actually measure whether these cancer cells produce energy, ATP, from lactate, from the glycolytic pathway, or from the mitochondria. And this is important because you start seeing that actually these cancers are not metabolically the same. And what she started doing actually starve these cells, not just with glucose, but now, for example, with amino acid. It's called essential or non-essential amino acid. Essential amino acid are the amino acid that are we need to take from outside, from the food. The non-essential, actually, the body can produce. By reducing the amount of amino acid that the cancer cells actually utilize to produce energy, we can slow down the metabolism of this particular translocation kidney cancer. But we believe that we can do that also in a subtype, also clear cell carcinoma. And we do see that slowing down the metabolism, now we can actually decrease the proliferation of these cells. At the University of Buffalo, we have an established program now to bank the tumor from nephrectomy, so the patient get nephrectomy or maybe tumor biopsy, metastatic disease, and we try to establish these organoids, this 3D culture, this spheroid, that we can test it with drugs, but also with changing in amino acid or glucose, and try to learn about the metabolism of each individual kidney tumors, and to see whether, when we put this tumor in the mice, whether a specific diet can have a better impact than another one. Now, if we talk about diet, we cannot talk about bacteria in the gut. And this was an elegant study published in Nature many years ago, showing that in individuals that were asked to eat only cheese and cured meats, there was a very quick change in bacteria. And some bacteria that actually are associated with not a healthy immune system. So diet can change the bacteria in the gut very quickly. And why this is important? It's important because now we have evidence that using antibiotics, for example, that can clear some good bacteria from the gut and have some bad bacteria actually emerge, can be associated with less response to immunotherapy. It has been shown in different diseases, whether lung cancer or kidney cancer. And now the group from in France actually very elegantly showed that a specific immunosuppressive cells actually get recruited inside the cancer when the patient are receiving antibiotics. So again, antibiotics can change the bacteria in the gut, can be detrimental to immunotherapy, and diet can change the bacteria, maybe in the good way, and actually help the immune system to work better. We talked about protein restriction. I want to just briefly mention also another way to intervene in the diet, as you probably heard about fasting or calorie restriction. Basically, reduce the total amount of calories, the total amount of gasoline that we put in our food that can help it to produce ATP. And this is called a reduced calorie restriction. And I've always mentioned about this very telling study was published in Science many years ago. These are rhesus monkeys. They're both 27 years old. But on the left, these monkeys were get free food they could eat anytime. The monkeys in the right was actually given calorie restriction, was get restricted, and the food they could eat from young age. You see the dramatic aging of these monkeys. But more importantly, the monkeys were calorie restricted actually live longer. They have less cancer, neoplasia, less diabetes, less cardiovascular disease. Fascinating data. And we started actually, like others, looking at the calorie restriction. We use an alternative day fasting, so the mice carrying, in this case, a human clear cell carcinoma, they can eat an alternative day. They don't lose weight, but the tumor actually, as you can see here, gets slowed down. And when we collect it, actually, it's half of the size of the mice that get eaten whenever they could. Now, the important part is that, a fascinating part is that, this is a work of Judy, that when cancer cells get stressed, again, we reduce the glucose in the tissue culture, we reduce the glucose in the diet. The cancer cells don't like that. They don't like stress. And that when we hit them with additional stress with chemotherapy radiation, we might actually increase the damage of the DNA. On the vice versa, normal cells, they actually are more resilient, believe it or not, of cancer cell as compared to cancer cell to stress. So they can actually anchor down, and when we hit them with the chemotherapy radiation, may have less suffering. They don't die as fast as cancer cell. So that's has been explored now in the clinic, and try to see whether maybe calorie restriction in patients can not only increase the amount of killing of cancer cell by chemotherapy or radiation therapy, but can also decrease the side effect from chemotherapy or radiation therapy. This is just an example of a couple of studies that have been already done, suggesting the potential feasibility of this approach in patient. In this case, was a patient with breast cancer and ovarian cancer. I want to give you a clinical vignette. This was actually a woman, young woman with the triple positive breast cancer that was treated here in Buffalo, and she really want to try some diet changes. She had to go through chemotherapy before the surgery. That's the standard of care. And so what we did, we came up with a protocol of calorie restriction and switch it to plant-based diet. And excitingly, this is the MRI of the left breast before the chemotherapy and after the chemotherapy, before the surgery. there was complete resolution of her cancer. And when the breasts were actually taken out, there was no signs of cancer. Now, this happened in 20-30% of women receiving chemotherapy for breast cancer, but we want to believe that also the diet maybe contributed to this. And again, there are quite a few studies now throughout the country trying to test this hypothesis. We have 2 clinical trials running at UB right now where we're offering intermittent fasting and plant-based to any cancer patient receiving any type of chemotherapy. And based also on our preclinical modeling, we offer protein restriction approach to any cancer patient receiving immunotherapy, and in particular, of course, kidney cancer patient. So this is, we believe, is the new frontier, not only in oncology, but in medicine. Try really selective diet intervention. We're particularly interested in protein restriction or in calorie restriction, how this can impact directly cancer cells, but also perhaps the gut bacteria. And all this can have an impact on cancer growth and immunity and help the response to cancer therapy. We established this project at UB, as I mentioned to you. The SNAC is really to try to provide a longitudinal nutritional education intervention to cancer patients and help them to achieve a better clinical outcome. This is a multidisciplinary approach that we need to have to bring a lot of expertise to help us to integrate cancer therapy with that intervention. And we're fortunate here in Buffalo we're able to pull it from different schools, the expertise that we need. But that's really the recommendation, eventually, to have a dietitian for any kidney cancer patient as a personal trainer. And because we understand that patients need a different counseling depending on the stage of their disease. Think about weight management. At the beginning, patient may benefit from losing weight, but at later stage, perhaps weight management is important. And this can be accomplished by really a longitudinal counseling from a registered dietitian. This is my dream slides where maybe in the future we're going to have a place where we can have a place where patients come for treatment, but also they learn how to cook, they do yoga, meditation, and they do exercise. We talked about the exercise briefly. The exercise, the other flip of the coin of a healthy lifestyle, is not only healthy diet, but also exercise. When I just mentioned this recent paper suggesting that vigorous intermittent lifestyle, physical activity, actually decrease cancer incidence. Small amount of exercise. So we want to believe that actually exercise not only can help it to maybe prevent some type of cancer, but can help a patient with cancer to do better. And now there is definitely in many places, including our place, to try to integrate diet with cancer therapy. This is an example for patients with prostate cancer. So in summary, there is definitely an unmet need, as you know, about nutritional counseling for our patients with kidney cancer, and also to integrate nutritional support in cancer patients who are receiving therapy. And our goal here in Buffalo is really to try to integrate immunotherapy, targeted therapy with specific personalized diet intervention. We're only at the beginning. There's still a lot of things that has to be done. But we believe that this is the right way. We want to exploit the metabolic landscape of each kidney cancer type for a more personalized diet intervention and overall to improve the quality of life of our patients. I want to just acknowledge people help me throughout the years and more recently. Sabrina was in my lab, Ricardo Cordova, Luigi Fontana as a long-term collaborator. And thank you for listening. I'm looking forward to the live section later on this afternoon. Thank you.
Well, welcome everyone. My name is Hans Hammers. I'm a professor of medicine at Judy Southwestern, and I was asked to talk about some of the future directions where we go in the treatment of kidney cancer. For those of you who have seen me speak for the Judy Nicholson Foundation in Chicago, it won't be too different, so I hope you're not disappointed. Good, I will share my screen. Good, so this is my presentation, Peering into the Looking Glass, how will we treat kidney cancer in the future? And again, there are many different aspects of kidney cancer therapy. Obviously, as a medical oncologist, I will focus on recurrent stage 4 metastatic disease. These are my disclosures. So again, if you think about kidney cancer, there are certain hallmarks that are really very close to the biology of kidney cancer. Besides these general ones, the immune system plays a very significant role, and kidney cancer has certainly learned to escape immune surveillance, particularly by the use of immune checkpoints. So immune checkpoint inhibition is and remains the mainstay of therapy for renal cell carcinoma. The other thing that's very particular for kidney cancer is actually the induction of new blood vessels. It's almost a definition of clear cell kidney cancer that these cells have lost the sense of oxygen. These cells always think they don't get enough oxygen, and so they are almost single-mindedly focused on making new blood vessels. So these are typically very vascular very vascular tumors. But as you can see, there's some other components here that cancer has to learn, and we will see a growing trend that we are going after some of those other potential targets in kidney cancer. So as I said before, immune checkpoint inhibition is the mainstay of therapy, and I would say with the long-term follow-up that we have now since really ASCO 2023, is that probably the therapy that is most ably inducing long-term durable responses and plateau formation with regards to progression-free survival, meaning that patients who start therapy don't progress even at year 5 with roughly 31%, is nivolumab, ipilimumab, which is dual immune checkpoint inhibition. And in my practice, that is the most commonly used immunotherapy regimen. Other patients should use a VEGF TKI, in particular if there's a very large tumor burden, where you really worry about disease progression in the short term with regards to the impact on the patient and the morbidity and mortality. Those are patients that I would choose a VEGF TKI combination. But if you look at the now emerging data at the 5-year mark, progression-free survival rates, for example, for axitinib pembrolizumab is now 18%, etc. So we really don't see this plateau formation on a regimen that's based on PD-1 inhibition alone. With that said, CTLA-4, so the ipilimumab component in nivolumab, ipilimumab is kind of like being revisited. I think there are some very interesting targets like botensilimab from Agenus. There's even a clinical trial coming for that in kidney cancer. ONC392, which kind of like goes after the different if you will, recruitment and disengagement of the CTLA-4 receptor based on pH. These are some of the agents that are actually in clinical trials, also will be looked at in clear cell kidney cancer, and they may maybe down the road actually improve the CTLA-4 component that we feel might be important for the plateau formation. If you look at botensilimab, it's actually quite impressive, has shown a 24% response rate in microsatellite stable colon cancer, where we typically see no responses. So this is a very interesting agent for sure. LAG-3 is the big news in melanoma. LAG-3 is also an immune checkpoint, but the inhibition of this checkpoint is typically clinically better tolerated than CTLA-4 with regards to autoimmune side effects, and has shown a benefit over nivolumab alone. So RELA plus nivolumab was superior when it came to progression-free survival curves over nivolumab alone in melanoma, and is now approved. And there are certainly now efforts going on and maybe starting in renal cell carcinoma, for example, with the triplet trial that will go through the Kidney Cancer Research Consortium that I will mention at the end of the talk. The other thing that's really exciting, I would say, is now the emergence of CAR T cells. So these are really T cells that were reprogrammed to see certain surface markers on kidney cancer. There are the two major companies that are involved at CRISPR, as well as Allogene, and both of those agents seem to show some efficacy in kidney cancer. I think those companies are not turning towards next generation approaches with these CAR T cells, but I think it's coming, and CD70 is a very interesting target. By the way, CD70 is also expressed in a certain percentage of papillary renal cell carcinoma patients and may provide the rationale for treating those patients with this modality as well. Cytokines, there was a lot of hope with regards to harnessing one of the oldest immunotherapy in kidney cancer, so high-dose interleukin-2 in the heydays, maybe roughly 2%, or high days of treatment, roughly 2% of patients had access to high-dose interleukin-2. That was before we had immune checkpoint inhibitors and the VEGF inhibitors, in fact, and could cure a very small number of patients, typically in the single-digit range. This is a very draconic treatment that requires inpatient admission, intensive care unit treatment that, again, we rarely now do these days, or much less commonly. There was some hope that if we can take some of these interleukins and modify them chemically and get some long-term low-dose exposure, we could maybe harness that. And that really hadn't worked out with bempeg-aldesleukin. Those were negative trials. PEG-IL-10 has kind of like disappeared from the scene as well after it was negative in a pancreatic cancer study. But there are newer variants that small biotech companies are working on, like nemvaleukin alpha, for example, and others. So I think there's hopefully some movement coming into the space in the future. The other thing is, some approaches that have been tested and by themselves were less successful, which is suppressing small metabolites that have an immune suppressive effect, such as adenosine. And there's a clinical study going on. Katie Beckerman from Vanderbilt is leading some of these efforts in the Kidney Cancer Research Consortium, where we combine fairly mild agents with nivolumab, ipilimumab, and see if we can get deeper and more responses in those patients. For those of you who love the microbiome, Dr. Pal had shown some enticing data that patients exposed to CBM-588, which is a dietary supplement, really, a microbiotic supplement from Japan, that may increase the sensitivity or response rate to immune checkpoint inhibition. And there are some follow-up studies planned, and we will see if this is real or not, or can be confirmed in larger cohorts. Radiation therapy had a mixed history in kidney cancer. This is kind of like coming back to more like low-dose radiation of the whole tumor bulk. Radioligand therapy, where we take small molecules which bind to certain markers on the surface or inside of certain cancer cells, like PSMA, lutetium-177, for example, that's now FDA approved for survival benefit in prostate cancer, is finding now their way into renal cell carcinoma. So lutetium PSMA targets the blood vasculature, as you can see here on the left in green. And for example, CA9 is a surface marker in renal cell carcinoma with girentuximab. So these are probably modalities that won't by themselves control a kidney cancer, but may modulate the immune system. It may lead to some DNA damage and visibility of these tumors. And so they're being combined with immunotherapies, for example. Normally, we don't think too much about cytotoxic classic chemotherapy in kidney cancer. Nonetheless, antibody-drug conjugates have revolutionized certain diseases such as breast cancer, for example, or are now FDA approved also for bladder cancer. And so similar approaches are now being tested with more modern variations than have been tested in the past, also targeting CD70 and renal cell carcinoma. And there are several companies who are investing in that space. Again, this would be classic chemotherapies. We would expect hopefully some response rates of hopefully some more at least intermediate durability. The big third leg that is going to come in clear cell kidney cancer is the HIF2 inhibition. That's a transcription factor that's important for probably a quarter to a half of clear cell renal cell carcinoma patients. The lead agent there is belzutifan, but there are other companies working in this space, such as Nicholson Therapeutics, for example. This is an agent that by itself has efficacy in roughly a quarter of heavily pretreated patients. And importantly, this is a uniquely well tolerated agent that is, I would say, one of the few drugs where patients have to think about what the side effects actually are. Anemia is the leading side effect, and with it can cause some fatigue. But it's certainly a very interesting agent from a palliative perspective because it's so well tolerated, or potentially in combination with VEGF tyrosine kinase inhibitor if a higher response rate is desired. And some of these studies are ongoing. So these are some of the combinations that I mentioned. Can we combine them, for example, with VEGF tyrosine kinase inhibitors, but they're also finding their way into frontline triple therapy studies. So, for example, MK648212, that's a study that has already fully accrued, and we're going to wait for the next few years for the readout. That is triplets with either combination immunotherapy, PD-1 CTLA-4 plus a VEGF TKI, or PD-1 VEGF TKI plus the HIF2 inhibitor versus the very active lenvatinib pembrolizumab regimen, for example, or belzutifan plus lenvatinib versus cabozantinib in the second line. There are other very interesting combination studies that are coming along, looking at maybe some unique vulnerabilities of clear cell kidney cancer. So this is based on science from Dr. Kalin, essentially exposing clear cell renal cell carcinoma to CDK4/6 inhibitors. Those of you who follow these will know that these are very important agents in breast cancer patients, where they have shown to make hormone therapy much more effective. And there's reason to believe that these agents have a significant effect on VHL now clear cell renal cell carcinoma patients, and hopefully in combination with the HIF2 inhibitor would be even more effective. So there are clinical trials going on with Merck and Nicholson Therapeutics looking for those patients. So if you think about HIF2 inhibitors, maybe looking for some of those combination trials might be worth your time. Obviously, a lot of these pills that we use are classic VEGF angiogenesis inhibitors. There will be some updates coming, so to say, for agents that may be either running out of patent, or where people feel maybe we can modulate some of the toxicity effects. XL092 is an Exelixis follow-up compound that hopefully has less liver toxicity than what we have seen with cabozantinib, will hopefully be more combinable with immunotherapy. And there are clinical trials going on that are looking at that particular question. They're modulators of the tumor microenvironment, but TRXcept is a molecule that targets the Gas6 ligand. That's important, kind of like an important aggressiveness factor in many cancers, including kidney cancer. But it's unclear where this will go. One of the major studies that the company has invested in ovarian cancer was negative. So this may not come to broader testing or fruition in kidney cancer. Here, with this slide, so to say, I would like to close, remind everyone that if you think about therapy, that we cannot make progress without clinical trials and patients who are pioneers and would like to participate in clinical trials. So at any treatment stage that you're in, even if you're untreated, or progress on prior therapy, always think clinical trials first before you engage with the next therapy. Obviously, there are many clinical trials. We have a consortium out of these designated areas here. You can see the website here where we conduct, I think, some very interesting clinical trials. But don't be limited to that. Obviously, there are many sites, many academic sites that will offer a very rich portfolio of clinical trials. That is something that you should certainly always inquire about, in my personal opinion. So with that, I will close and will be available for questions. Thank you so much.
Is no one going to ask questions, or how should we do this?
Hey Hans, how are you?
Good, Roberto, how are you?
I like it.
Yes. Hello. So these are great sessions, and I think we have a lot of questions in the chat. Glenn and Hans and Roberto, thank you so much and Taryn for contributing to this session. I think that one of the, waiting for things to show up in the chat, but one of the questions that I think a number of patients asked was about the probiotic approach that Hans, you mentioned in the CBM 588. And I think there's been a lot of excitement about that for patients.
Yeah, so first of all, thank you, Naomi and the organizers to have me. I think this is a fantastic meeting, and for the Judy Nicholson Foundation. So thank you so much. I think it's actually really exciting to think about agents of that nature because they are pretty much not toxic. And so if there is indeed a signal that they may modulate the immune system in a favorable manner, all for it. We just have to show it now, right? In randomized controlled trials. Is this real? Is this just hype? Was it just by chance that we saw the effect or not, right? This is by no means definitive. And so we will need help from patients to figure this out. Is this real or not? And how can we make progress there? Certainly very exciting initial data that Dr. Pal generated. So I'm really looking forward to those trials in a more definitive manner.
Can you speak to explain to patients why a smaller trial still needs to be looked at in a bigger trial? Because I think that might cause some confusion.
Yeah, no, absolutely. So the truth is, at the end of the day, we want to have the hardest possible data to really make progress. I understand on the individual level, there's a signal with CBM 588. I want to just take it. And we've done that a lot of times, and a lot of times it turns out at the end of the day, those interventions don't really work, may have more side effects than we had hoped for. And we really need to show in a randomized fashion that it actually truly, truly works. If you work with small numbers, this could all just be by chance. And there are also certain, factors, especially if the numbers are small, where that we only can sort of say distribute evenly by randomizing, by having a computer decides who goes on what arm, and the numbers need to be large enough. So the only way to really convince regulatory authorities worldwide to say, hey, we should spend money on this, and this is real progress, is to have these randomized trials. There's just no other way of convincing anybody, including myself. The way I see it is small trials are fantastic signal generating modalities or tools. And I think we need to take it from there and then do the hardcore work to really show once and for all if this works or doesn't work. And we can have a lot of fantasies about certain things, and we may partial or opposing certain things. At the end of the day, we need to generate the data. They can only be done through large randomized phase 3 trials.
And can I just add in, particularly for that one, for CVM 588, it is expected, relative to some of the drugs that patients take, it's cheap, but it's expensive and it's challenging to actually get in this country. And I'm just giving the U.S. perspective. So I think your point is really well taken. It'd be nice to know that we are spending our money and effort for good reason. And to me, it feels still preliminary.
The other thing about a phase 3 trial is if you're doing a smaller trial, it might be done in just one place or two places. And doctors and kind of types of patients might be more characteristic at one. And so doing a bigger trial, you get a more uniform a little bit more real world, looking at different centers treating patients, and also geographically and racially and economically different patient populations. And a phase 3 trial isn't perfect, but it does a better job of gathering a larger group of patients to look at it.
Yeah, no doubt.
There's a question in the chat about vitamin C. Roberto, would you like to comment on vitamin C and testing in kidney cancer or other cancers for vitamin C?
Very interesting question. I don't have an answer. For vitamin D, the only levels we really measure among these immunomodulated vitamins is really vitamin D. And of course, the recommendation is make sure that your vitamin D levels are good, especially if you live in Buffalo, where we don't see a lot of sunshine, right? So you need to have a good level of vitamin D, perhaps, to have a good response. There's a lot of interest in vitamin C. As you know, there's been some places, including Hopkins, that did the high-dose vitamin C, and other places. I think the jury is still out there. So I'm not sure whether there are some levels or some amount of vitamin C you want to take. But I think, as I mentioned, fruits and vegetables, part of your daily diet is probably enough to give you enough vitamin C. And vitamin D, of course, we need to sometimes supplement. Go back on the microbiota modulation and answer, really share very potential exciting news. Let me tell you, you can actually increase the bifidobacteria probiotic just with diet. And talking about expenses, I'm always worried about these specific supplements that are quite costly for the patient. If we can achieve the same results actually with diet, with the high fiber diets, with fruits and vegetables, and our people are looking into it. So, but it's an exciting part. I think the microbiota, as Dr. Hammers was alluded to, is a fascinating. The group at Gustave Roussy in France are really pioneering these studies.
Yeah, that's a very good point. So especially, I would say the high fiber diet, I think that's really exciting in many different ways. You also get less constipated, et cetera, et cetera. So, but coming back to vitamin C, just a little personal note here, because I say that with a half painful face. When I grew up in Germany, so to say, so Germany, first of all, the whole mystery of vitamin C goes back to Linus Pauling, right? He's a Nobel Prize laureate who was infatuated with that kind of thing. And then since then, it had always this mystery around it. And in Germany in particular, where dietary supplements are very popular and the whole homeopathy movement came from Germany. Again, vitamin C is not homeopathy, but vitamin C infusions are very popular there. There was never really ever evidence generated that does anything. In fact, the other thing not to forget, and that's where my painful part comes in, it's water soluble and you don't store it in your system, meaning it will leave your body and has to leave your body through the kidney. And if you're like me and turn this into oxalic acid, you will get oxalic acid stones. The vitamin, as a medical student in Germany, I had 2 episodes of kidney stones, and they were all associated because everybody was into taking high-dose vitamin C because we didn't want to age, even already as medical students. I got 2 times kidney stones. That was my worst experience in my life. I don't ever want to have it again. I don't wish it to anybody. So don't take these 4 or 5 grams of vitamin C. It's complete nonsense. And you will get oxalic crystal stones that will tear your ureters apart, and you will feel it. So be careful with what you're doing.
Good point. Thank you for sharing your personal experience.
A little bit too personal, but who cares?
And Dr. Haas, just to echo that, I in January of this past year, the National Kidney Foundation sponsored a webinar on taking care of your kidney, and I sat on a panel with a nephrologist. And to echo Dr. Ham's words, that's exactly what he said. If he could urge us to do one thing, it was to not be popping a lot of vitamin C. He just doesn't see it as particularly good for kidney health.
Yep.
Thanks. So there's another question here that maybe Taryn could tackle from the symptom management, and perhaps Roberto could tackle from the nutrition, a question about modified citrus pectin in decreasing fibrosis in the tumor microenvironment, and what about apple cider vinegar? And I know that's also come up because it might change the metabolic activity of cells, and so patients wondered whether it might make cancer, might interfere with the cancer pathways. But I also know that pectin is another thing that we sometimes think might help with diarrhea from at least VEGF tyrosine kinase inhibitors.
Yeah, I mean, they can try some pectin to help bulk up the stools, but I'm not sure. I don't know the effect that it would have on the tumors, or I don't think it generally interacts with the medication, but something they could try. I would go with something else before trying that, but I don't know. What are your thoughts, Dr. Feely?
Well, I'm not very knowledgeable about the potential biological activity of cytospectin. I think, we hear more and more patients try to alkalinize their body, with drinking alkaline water. I think it conceptually makes sense, but I don't think it's going to work. It's working. It's just the patient just waste a lot of money because alkaline water is more expensive. It doesn't taste as good as regular water. So the concept that we can change the acid in the microenvironment, the tumor, just with what we introduce in our body, I think it's a misconcept. I mean, cancer cells are very clever.
Yeah. Yeah. So if I may also add, so I totally agree with you. I mean, so if you take a step back, the truth is, if patients are desperate, there will be somebody trying to make money off desperate patients. I think that's a simple truth. And so please take a hard look at what you're being offered. You will get a lot of opinions and suggestions. Again, most of the time they're well-meaning, right? You have cancer friends, family that just want to support you. They give you the layman's suggestions, so to say, that are there, but oftentimes there's either no basis for it, or they might even be counterproductive, like this high-dose vitamin C thing, for example. Another thing that comes up all the time is, well, you shouldn't eat any sugar because your sugar will make your cancer grow. The truth is, I don't think you can control kidney cancer by cutting out your pecan pie or other things, right? I mean, the cancer will take what it wants anyways. And to be honest with you, I think the biggest risk of significant dietary changes are more that you're going to lose weight, you're going to lose stamina, you're going to lose fitness, you're going to be moving less around. And I think that is more dangerous than having the pecan pie coming up for Thanksgiving. It's just not like I think harm is being done by sometimes overemphasizing those kinds of things. And in fact, I remember when I was at Hopkins with Roberto Pili, even then patients came to me and said, well, Johns Hopkins said you shouldn't eat any sugar. Johns Hopkins never said you shouldn't eat any sugar. And the truth is, you can't really control your cancer that way. I think a healthy, balanced diet is a great thing. Have your fiber. It makes no sense not to eat any protein, and maybe Roberto and I will differ on that point for today. But the truth is, you need to maintain your structure, and you need to maintain your performance status. And I think any major deviation from a healthy, balanced diet can actually endanger you by getting weaker and losing stamina. And I think
and I agree with you, Hans. Absolutely. I think a balanced diet, a Mediterranean diet, perhaps is the way. But different stage of disease may have a different nutritional need. I think people are looking at this calorie restriction, intermittent fasting for a short period of time. And in our clinical trials with protein restriction is only for 3 months. So really the time where you want to prime your immune system. So I agree with you, diet intervention not necessarily has to be for the long term, because cancer eventually adapts like a body adapts. But perhaps we can still looking at that intervention for a short period of time. But healthy lifestyle, healthy diet, more plant-based diet, and exercise, to me, that is something that we all should empower.
There's a couple of questions about clinical trials in the chat. One of them is someone considering a phase 2 trial of sorry, I can't even say it, but botensilimab and balstilimab. I can send that one to Dr. Hammers, and also about TiNivo-2 results and when you think those will be in. And maybe Glenn, you can comment after Hans' comments.
Yeah, so the other name studies. So essentially, it's actually, to be honest with you, I think it's really, really fascinating. And there is a phase 2 trial that's coming up under the leadership of Mike Atkins. It really is another PD-1 CTLA-4 combination, okay, such as nivolumab, ipilimumab. And the exciting component here is that maybe this is now a better CTLA-4 targeting approach than what we had with ipilimumab or some other CTLA-4 targeting agents. CTLA-4 is an incredibly difficult target to target well. I think we still don't understand it well. But the exciting news here is that this regimen in a cancer that normally produces no response, which is microsatellite stable colorectal cancer, generated a 24% response rate. That's normally 0, okay? And since we know that kidney cancer actually is a CTLA-4 sensitive disease, I think it was ingenious, quite frankly, for Dr. Atkins to push Agenus to try that through the Hoosier Oncology Group in previously untreated renal cell carcinoma patients. So I think I couldn't be more a bigger fan of this. Obviously, I'm a little biased since that is the primary way I treat kidney cancer. But I think it's an ingenious approach. It will be open through the Hoosier Oncology Group. And there will be a number of sites, I think your site as well, Dr. Haas. And I think there will be certainly a study to look into for previously untreated patients. I hope it's going to be spread in the community, that if you're untreated, that you may want to look at this. The TiNivo-2 study is, I would say, the last bit of data that we need to come to the conclusion, which I don't think is surprising, that if you progressed on PD-1 directed therapy and you just repeat the same PD-1 directed therapy with a different pill, it's just not going to convert you into an immunotherapy respondent. There's very little benefit of continuing to do so. I would say that the CONTACT-03 study presented this year was immensely important because it suggested that an approach that I've seen sometimes in private practice, which is you had, let's say, your nivo-ipi, and then you progress, and then you do your whatever, TKI Pembro combination, Axi-Pembro, for example, that there's just no benefit. So it took patients who had, PD-1 directed therapy of any menu, and then exposed patients to cabozantinib, atezolizumab, a PD-L1 inhibitor, and there was zero benefit, only toxicity, increased deaths. And the TiNivo-2 study is tivozanib with now nivolumab. It's a PD-1 inhibitor, but I don't think that is going to make any major difference. Also, the way, I don't want to go too technical, the way if the FDA forced the trial design, it's doomed to be a negative trial. So I don't think it will be a negative study at all. The only advantage of this study is that we may get access to tivozanib, which is a more selective VEGF inhibitor, in the earlier lines of therapy. And I think it will enhance our menu of the VEGF-targeted options for our patients once they have progressed on immunotherapy. So I think it's important in the sense of getting earlier access to tivozanib than the third plus line where it's now relegated to. And I think that's the main advantage. But I do not think that this will be a positive trial. I bet you any keg of beer against it. It's not going to happen.
Thank you. So there was a question about really a underserved population, which is the question is any trials to further stratify increased risks of severe side effects on immunotherapy of patients with pre-existing autoimmune disease, for example, ulcerative colitis, rheumatoid arthritis. That's a really good question, and I would imagine that most of the studies that are doing that are institutional studies that are collecting their own information on patients undergoing immunotherapy, but maybe the rest of you can comment. Are you aware of any trials in this setting that are specifically inviting these patients to enroll?
Yeah, I think it's the AIM study. I think it's the ETCTN or something like that. One cooperative mechanism has the AIM study, which offers nivolumab in patients with a history of autoimmune diseases, and kind of like organize a panel of the specialists, if you will, GI, lung, and others, rheumatoid, to help overseeing the PI those patients. I think just to collect the data sets. I agree it is a challenging population where we need to have more experience. And it is, I don't necessarily withhold therapy in those patients. It's just something where you may want to engage with immunotherapy maybe sometimes later than earlier. Or you do a calculated risk. If an autoimmune disease process is not active, then you do it, but again, with a high chance that you will flare up the disease. But maybe that is enough, that window of treatment, to actually have a positive impact that might be more durable. So it's never a no-no, but depending on the autoimmune side effect, it can certainly be scary.
I think some of the side effects that scare us the most are in patients who have either systemic lupus or have things such as Guillain-Barré, where potentially they could stop breathing or have brain side effects from the immunotherapy. I think most of us are willing to somewhat consider in patients even that have some gastrointestinal toxicity or arthritis or psoriasis, because we sort of will immediately know if they're having side effects, and we know we have drugs to turn off those issues if they happen.
Yeah.
Dr. Haas, I just wanted to jump back to the previous question, because obviously Dr. Hammers can talk about the trial that I think the questioner had asked about, or is actually thinking about signing up for in a way that I can't. And I just wanted to urge, drugs can have a lot of promise, but ultimately it has to be promising for you, not the promise for a population that you may be part of in a broad sense, but you really do need to understand that. Which is my overall point. Understand that for yourself. So if you're talking to your doctor about that trial, have them explain why they think it's beneficial and might be beneficial to you, and drive it down at that level, and try to drown out the hype of the future promise of something. Just understand it at a really personal level.
I think that's the Architect trial, and I believe it's you can get either ipilimumab and nivolumab, or you can get these two other drugs, and the odds of getting the two other drugs is higher. It's a 2-to-1 randomization for patients who have clear cell kidney cancer who are newly diagnosed, haven't been on previous treatment for metastatic disease. And Hans obviously knows a lot about this as well. So correct me if I'm wrong, Hans, but if that's the one we're talking about.
Yeah, I think that's exactly the one. So it will be randomized, but again, favoring the new experimental arm. It's a trial where you can't lose, right? It's a trial that's very logical to me, meaning nivo-ipi to me, again, I'm biased, but nivo-ipi to me is the most potent immunotherapy you can do in 2023. And so you either get that's the minimum, or you may get exposed again to a new regimen that's very similar, but again has my book, a next generation CTLA-4 inhibitor on board. And so that's certainly very interesting. So I would expect you would at least see something very similar to nivo-ipi. We hope it's going to be more effective. We don't know. But I think, to me, it makes a lot of sense. And I totally agree with what Glenn just said. Don't just accept if somebody tells you that, like the clinical, you really want to understand why that is. And it needs to make sense, right? For example, there's some trials, if I have difficulties explaining to a patient, I tend not to participate in them because, if I don't understand why that's like a great rationale, then don't put patients on. And the truth is there are some trials like that. And I think it's important to really, understand why you're getting into this, et cetera. And also, it may also excite you, right? Why do you want to invest your time and resources to participate in a clinical trial? The minimum that a good investigator has to do for you is to make you understand why you should invest your time and resources in this. And if they cannot excite you, I think it's true.
So I don't see any other questions in the chat. Would any of the speakers like to make any final remarks to the audience? Anything that you think hasn't been brought up, or questions that you are maybe surprised haven't come up and you think we should address?
I want to just reiterate, again, I'm not a nutritionist, but I think taking drugs is important, but lifestyle is important. Get advice and help how you can lose weight, stay healthy, eat better, eat healthy. I think there are going to be fascinating studies showing how diet and exercise actually can help tremendously the patient. I've been seeing it with my eyes, so not only in treating mice, but also in the patients. So be aware, be on the driver's seat on that. You as a patient, really, you can make a difference on how you eat and how you move around, how you socialize, how you get support. And again, we want to, of course, thanks the Judy Nicholson Foundation, Kidney Cancer Foundation, for helping the patient to achieve that. So we're a big team here. And thank you again for giving us this opportunity.
Dr. Haas, I just wanted to add, too late for my slides. In my mail yesterday, there's a publication. There's a group called AACR, great group, put out a quarterly magazine called Cancer Today. If you don't subscribe, I encourage you to. They have some really great articles. And the one I just received yesterday had an article on making cancer trials, clinical trials, easier to sort of find, and had a lot of great resources. You can find this online. The name of the article is Making Clinical Trials Easier. If you just Google that and put AACR in your Google search, you'll come right to the article. They have a lot of great resources, because one of the challenges is, of course, finding a trial. And clinicaltrials.gov, cumbersome, big, and they list some really great resources as to how you might be able to find trials. People are generally positive they feel about trials once they become aware of them. It's awareness is the issue. So if you're finding them and taking them to your doctor, that puts you a lot further ahead of the game, and they have some great resources there.
Thank you. I think there was one other question that came up earlier, and that was a patient who was recently diagnosed with brain metastases, who wondered if it was safe to consider immunotherapy after radiation. And I did answer, and I said from my own practice, what we would look at would be that your disease was stable off of steroids, and before we would add immunotherapy, because immunotherapy can cause swelling in theory in the brain, but in general, we do treat patients with immunotherapy even if they have had metastatic disease to the brain.
Yeah, that I would. I mean, I obviously totally agree. It can be a challenge sometimes because of the steroid use, and I would say, but we have to use steroids obviously when you get side effects, and in that setting, it's typically not detrimental to the immunotherapy response. It's probably not a good idea to have a lot of steroids before you start immunotherapy. I think a lot of data is pointing to that, and so having some distance from the steroid that was used to control your brain swelling, for example, to when you start on it. That's one of the scenarios where sometimes the combination of a VEGF TKI and immunotherapy can be more helpful, because the VEGF TKI essentially serves as a steroid-sparing agent, meaning it can suppress actually inflammation, edema, etc. Not inflammation, but edema in particular, and that might make it more conducive to stay off the steroids if you had a lot of edema, for example, and then help you fold in the immunotherapy later. So I just had a patient, for example, a lot of edema, and we started on a TKI, got rid of the steroids, waited a month plus, and now are starting immunotherapy. So to give the patient the best chance to actually get the initial immune response, that's absolutely critical.
Well, I want to thank all the speakers for your valuable contributions, and I want to thank all of the patients for participating in this, and I hope that you see both things that we can offer locally in the Philadelphia area, but really all over the country. And Judy Nicholson Kidney Cancer Foundation is a nationwide organization that has a number of these conferences and also general information throughout the year. I believe there's Linda Ostowski has a closing remarks or video to show as well. So thank you very much.
I hope you found today invaluable and that you learned some information regarding your care and your cancer. We are here to help you. We are here for your journey. So please go to our website and you can read and see about the great things that are happening in kidney cancer. We have recordings of our old symposiums, and this one will also be recorded. We do have a Facebook group that you can chat with other people and learn from each other and share ideas. I truly want to thank Dr. Naomi Haas and all the speakers and the presenters that gave you this day of hope and caring and sharing. Thank you so much, and good luck on your journey.